10-15 से है। 10-5 हुआ है, होनी चाहिए।
Good morning, Dr.
हाँ
J.K. Singh. This is Dr. Nurul
हाँ,
here.
मॉर्निंग, गुड मॉर्निंग।
Am I audible?
या यू आर 100% ऑडिबल। हाउ आर यू? हेलो।
Am I audible?
या परफेक्ट।
Dr. J.K. Singh, am I audible?
या यू आर परफेक्ट। एम
Could you unmute? I'm not able to hear you.
सॉरी, सॉरी। एम आई ऑडिबल टू यू?
Yes, audible.
Yeah, audible,
ओके
sir.
ओके।
Sir,
द
we'll
स्क्रीन इज
wait.
देयर, कैन यू सी द स्क्रीन?
Yeah, screen is visible.
ओके ओके,
Sir, we'll
नो
wait
प्रॉब्लम,
3-4 minutes more so that more
नो
participants
प्रॉब्लम,
join
नो
and then
प्रॉब्लम,
we'll start.
नो प्रॉब्लम। ठीक, 3-4 मिनट और। हाँ बोलो, बोलो, हेलो। हाँ बोलो। आज हाँ तो बुला लो आज, बुला लेते हैं, बुला लेते हैं। हाँ नहीं,
So welcome delegates in IOCCON 2024 IOCON International Oral Cancer Congress 2026, our 6th edition. And we are welcoming every delegates, every attendees joining across any part of the world. We are on our 3rd day and we'll start our session. This is Dr. Nurul, organizing chairman of International Oral Cancer Congress, which is hosting your program today. There is someone else supposed to moderate the program, but due to unavailability, it's my responsibility now to do the moderation. So we have a long day today, and there would be some 11-12 speakers who would be joining from different part of world, and they would be talking on different topics and all. We would be joining Dr. Cheena Singh, Dr. Saurabh, Dr. Altaf, Dr. Priti, Dr. Sujata, Dr. Erkan, Dr. Yash Mathur, Dr. Divya, Dr. Asim, Dr. Shahida, and Dr. Kehinde would join from US in the late evening at say around 7 o'clock. So we are privileged that Dr. J.K. Singh is with us, and he is a renowned oncologist. He was busy on day 1 actually, and he was traveling, and he reached capital Delhi, and so he couldn't join at that day. So we are very fortunate that he is now available with us, and let me formally introduce Dr. J.K. Singh. Dr. J.K. Singh doesn't require any introduction so far as this oncology is concerned in India and in the globe actually. But as a moderator's responsibility, let me introduce Dr. J.K. Singh. He is a renowned cancer specialist in national and international repute. With his untiring efforts, he has given a new shape in cancer management and care in Bihar and neighboring states. His achievements include he is a director of SS Hospital Research Center Patna, as being displayed on his first slide, title slide. He was former director of Mahavir Cancer Sansthan Patna. He was also director of Paras Cancer Center Patna. He has some 186 publication in national and international journals to his credit. He has successfully completed 61 clinical trials, has contributed in 6 oncological books, associated as chairman ethical committee with many hospitals. He is former national president of 6 oncological associations of the country, India. Ex-national vice president of Indian Medical Association, Delhi headquarters. Presently, National Secretary, Breast Cancer Foundation, India. He is chairman of Cancer Care India, Delhi. Member Task Force, Government of India, Cancer Control. Recipient of several national and international awards. For his outstanding contribution in the field of oncology, Government of India conferred Padma Shri Award to him in 2012. 14 years back, he was given the award. This is a brief introduction of Dr. J.K. Singh, and I would request on behalf of my organizing team, International Oral Cancer Congress 2026, that Dr. J.K. Singh would talk on a keynote talk on the oral cancer and oral oncology. So over to you, Dr. J.K. Singh. Could you please start the sessions of today? Could you unmute Dr. J.K. Singh? Dr. Singh, your system is in mute mode. Yes.
Yes.
Yeah,
I'm
yeah,
audible?
yeah, you are not.
Okay.
Very much audible.
So thank you, Dr. Nurul, for your nice introduction. And my topic today is head and neck cancer, India's silent epidemic, and the urgent call for action. Respected chairperson and esteemed colleagues, my talk is in the 3 part. One is the introductory part, another will be the slide, and third is the conclusive part. So I'm talking about the introduction part. India is standing at a decisive moment in its cancer journey. The rising tide of cancer, especially head and neck cancer, is not just a static, it's a silent crisis unfolding in our homes and communities. Every year, hundreds of thousands of Indians are diagnosed and over a lakh lives are lost to a disease that is largely preventable. But beyond this number are faces we cannot ignore. A father who can no longer speak to his child after losing his tongue to cancer, a young daily wage worker who loses both his livelihoods and identity, and a mother who hides her face after disfiguring journey, and families pushed into poverty by treatment costs. In nearly 70% of the cases, patients arrive at hospital in stage 3 or stage 4, when survival chances are drastically reduced. The tragedy is that oral cancer begins silently, often as a painless ulcer or white patch, visible to a naked eye, detectable by a simple oral examination. 8. Due to tobacco addiction, cultural practices like smokeless tobacco and better and quit chewing, low awareness, social stigmas, and lack of screening, we continue to diagnose it at a late stage. It is not merely a medical problem, it is a social failure to prevent a preventable disease. If we do not act decisively today with a strong tobacco control, early screening, and public education, cancer may soon become the greatest public health challenge in our nation faces. If we talk about head and neck cancer in India, the pattern is changing, and it is deeply concerning also. Earlier, this disease predominantly affected the elderly. Today, however, we are witnessing a disturbing shift. Increasingly younger individuals, often in the most productive and socially active years, are being diagnosed. This is really very challenging. This epidemiological transition signals not only an oncological crisis, but a socioeconomic and generational challenge for our country. Friends, we discuss the treatment of head and neck cancer, we must go beyond survival statistic. These cancers involve the face, oral cavity, pharynx, and larynx. Structures are that are fundamental to identity and communications, swallowing, breathing, and social interactions. The face is not merely anatomy, it is a personality. Speech is not merely
Dr. J.K. Singh,
function.
sorry to interrupt you. I
Yeah,
think your slide is we are not able to, slide. It's
slide
not.
I will put it just after 2 minutes.
Sure, sure, sure.
Slide, yes.
Okay.
I'm just giving the introductory part. The face is not merely anatomy, it is personality. Speech is not merely function, it is dignity. And treatment, while pertaining potentiality, life-saving, can be deformed and functional debilitating. Therefore, let us be very clear. A cure that leaves behind a mutilated, socially isolated, and psychologically devastated individual cannot be considered a true success. The management of head and neck cancer presents multifaceted challenge. It demands a multidisciplinary approach also, involving many oncologists of different specialty. No single discipline can claim ownership in this disease. The patient must remain at the center of an integrated care model. The principle of treatment in headache oncology are well established, and this is in three parts: eradication of cancer, preservation of physiological function, and achievement of socially accepted cause message. And now I will show you some of the slides which will give you some of the ideas, what is the present perspective and the future directions. So I'm showing you the slide. India versus global burden. India versus global burden. India stands today at a defining moment in its cancer journey. Cancer incidence in our country is rising steadily, with projections estimating more than 1.5 million new cancer cases annually by 2025. Among these, head and neck cancers account for nearly 26 to 30% of the total cancer burden, and translating to approximately 4 to 4.5 lakhs new cancer cases of head and neck every year. Tragically, we lose nearly 1.25 to 1.3 lakh individuals annually to head and neck cancers. Head and neck cancers are one of the most common cancers worldwide, ranking around 7th globally with nearly 9,40,000 new cases and 4,80,000 deaths annually in the year 2020 based on the recent estimates. India carries disproportionate burden, cultural habits, and it contributes significantly. Now coming to the epidemiology and trends. Rising incidence in younger age group. This is really very, very challenging. Earlier, it was not there. It was a cases known to be having in the elderly group. Urbanization and lifestyle changes. The phases of cancer is changing. It is becoming younger. And risk factors and molecular pathogenesis. Tobacco and epidemics, alcohol multiplies the risk, and HPV-associated cancer rising. Most causes are preventable, making every case a missed opportunity. Early signs doctor must not miss. Non-healing ulcers, more than 2 weeks, red and white patches, hoarseness, difficulty in swallowing, and 2 minutes of examination can save a life of the patient. This is important. So why patients turn up late? Because of fear and stigma, financial concerns, and rural access barriers. Delay is not ignorance. It is often helplessness also. Advances in multimodality treatment, organ preservation protocols, microvascular constructions, precision radiotherapy, targeted therapy, and immunotherapy having its emerging role. And today, we treat not just a disease, we restore function and dignity also. Survivalship and rehabilitation, speech and swallowing therapy, nutritional rehabilitation, and psychological support. Cure is incomplete without restoring quality of life. And my last slide is prevention and public health strategy. Tobacco control success stories, community awareness, school level education is very important, and And the greatest cancer treatment is prevention, particularly in head and neck cancers. And now I will conclude that behind every statistic, there is a human face. And a father who cannot no longer speak to his child, a mother who hides her smile because disease has not taken just her health, but her confidence also. A younger woman, worker in the prime of his life, who loses his livelihood because cancer has silenced his voice and weakened his body. Head and neck cancer doesn't simply invade tissues, it invades identity also. It alters speech, swallowing, appearance, and dignity. It affects family, fractures, confidences, and disrupts generations also. And eight, this is one cancer which we hold extraordinary power, the power to prevent, the power to direct early detection, the power to treat with precision, the power to respond functions in hope. If we strengthen prevention and if we examine every mouth, if we educate every family, if we educate if we advocate tobacco cessation and and conviction, and if we treat every patient with scientific excellence and compassion, we can change the story. I'm sure we can change the entire thing and the scenario will be changed. Head and neck cancer is not only a medical challenge, it's a social responsibility. If we act together, DC clinicians, institutions, policymakers, and the families and the communities also, we can prevent suffering before it begins and endures. That cure never comes at the cost of humanity. I'm sure if every person would like to have a make it as a movement, probably head and neck cancer, which is the biggest problem in India, particularly with the male patients, I think we can prevent it and it will change the entire scenario if we act accordingly. Thank you. Thank you so much.
Thanks, Dr. J.K. Singh, for sparing your precious time in early morning today. I just request from audience if you have any question related to head and neck cancer and related to the
Sure.
prevention of head and neck cancer, because Dr. J.K. Singh have decades of experience in treating cancer patients. He has a renowned radiation oncologist,
50
and
years.
he
50
worked
years.
extensively. Yes, yeah. How long, sir? Yes. So
50 years, 5 decades.
5 decades.
I have my
Yes.
oncology practice for the 50 years.
Yes, yes. So I'm just requesting anybody want to ask, because just sir has told that the prevention is the key actually, that we should examine every lesion in oral cavity scientifically and in with compassion and with full care and attention, so that we can prevent it in an early stage.
Yeah,
And
it's
sir is saying that cancer is not just
full simple.
taking the life, but is taking the
Full
dignity
simple.
and taking the, there is a stigma associated. So head and neck cancer is taking voice, speech, and the dignity in the society. So we should, as a oral cancer experts, as a dental surgeon, we should take extra care in examining oral cavity and any lesion, any which we are, any uncured lesion, any ulcer in the oral cavity is very crucial and very important to be thoroughly diagnosed. Anybody want to ask any question? Otherwise, we'll move to the next speakers. Anybody want to ask question, they can put on a chat box, and or they can email to us at support@ioccon.org. CO, and we can forward it to Dr. J.K. Singh, and you can get the answer. Thanks, sir, for giving your precious time. You're such a busy person, but
Thank
still
you.
you
Thank you,
have,
Dr. Nurul.
given us a time, and we are very privileged that.
Thank you, Dr. Nurul, from my
Yes.
side, because you have involved me most of the many previous conferences also.
Yes. Yes.
You have involved me, and I'm really, really very thankful to you for this.
Thanks.
Thank you.
Thanks, Dr. J.K. So with your permission, should we move to the next session, sir?
Yeah, sure, sure.
Yeah. Okay. Thanks. So our next speaker is Dr. Cheena Singh. Dr. Cheena she's also a regular speaker in our program. Let me formally introduce Dr. Cheena. Dr. Cheena Singh is an accomplished academician and clinician serving as a associate professor in Department of Oral Medicine and Radiology at the Postgraduate Institute of Dental Science, Rohtak, Haryana. She holds advanced training in orofacial pain, temporomandibular disorders, TMDs, and dental sleep medicine from Rutgers University, USA, and has completed a fellowship in forensic odontology from SDM College of Dental Sciences and Hospital. Additionally, she has earned a diploma in lasers in dentistry from University of San Francisco and diploma in facial aesthetics from Panchkula, India. She is also a certified tobacco cessation specialist from Gujarat University and is also pursuing her PhD at Desh Bhagat University with a strong clinical expertise in oral diagnosis, oral facial pain and management, TMDs, forensic odontology, and advanced dental therapeutics. Dr. Singh actively contributes to undergraduate and postgraduate teaching, clinical services, and research with several national and international scientific publications in her credit. If I am missing anything, Dr. Cheena, you can add on and you can start your presentation. Your slides are visible.
Thank you, sir. Thank you for this kind introduction. I need nothing is to add on, sir. First of all, proceeding to our main lecture, I would like to thank you, sir, again. Please, sir, thanks. With lot of regards for inviting me again on this platform, sir. So, a very warm good morning to one and all. The topic of my talk is nutrition in oral cancer patients. Definitely, it's a ray of hope. So, as sir has already given introduction, nothing is left. I'm going to cover my talk under these contents: introduction, epidemiology, risk of head and neck cancer, how cancer present clinically and radiologically. Being a oral medicine and maxillofacial specialist, I will little bit emphasize on this also. Diagnosis of malnutrition, cancer, cachexia, and malnutrition, side effects, and various nutrition components. In between, I will to discuss few of my cases. Starting with the introduction, as we all are aware, the incidence of oral cancer is increasing day by day. I would like to say it's a global burden. So it's in third in all the cancer. The head and neck cancer is third place all over the India. According to International Agency for Research on Cancer, which is a part of the World Health Organization, it estimated that worldwide the new cases in 2012 were 14.1 million. It was in 212 and now it is 225. I think it will be triple 10 times. Yes. It is because of the extensive use and the availability of tobacco alcohol. However, there is some restrictions under the COTPA 2008. The smoking is prohibited in the public places across the India under the COTPA. COTPA is Cigarette and Other Tobacco Products Act, in which we cannot sell the tobacco under the in between the public places. So here the nutrition come into the play. Nutrition status play an important role in the success of treatment and healing process in the cancer. Yes, definitely the few precancerous and precancerous lesion and conditions are habit related. So we have to treat the patient with the counseling and yes, with the empathy. An adequate diet has a negative effect on the immune status and tolerance of treatment, as well as on the various organ and the metabolic function. World Health Organization in 2012 gave a report in which cancer is the second most common disease worldwide. 8.2 million people worldwide died from the cancer in 2012. About 30% of cancer deaths are due to the 5 leading behavior and dietary risk. That is high body mass index, low fruit, vegetables intake and lack of physical activity, and tobacco use and alcohol use. Just a brief glimpse about the epidemiology. In all the area, we are covered from all the 4 sides of the India under this global burden. We can well appreciate in this picture here the female male ratio, and the common areas is the buccal mucosa. Everywhere is the buccal mucosa, tongue, and the risk factors are mainly the smoking, drinking. Synergistic is very now getting an incidence of increase in the malignant ulcer, and histopathology we can say yes, the carcinoma. What are the risk of head and neck cancer? There is a huge list of that. Few I have given this slide. The patients with the high risk of post-operative complication, increased rate of depression. Nowadays, our youth are under this category due to the lack of the parents, or maybe not. I'm not giving the 100% point out to the parents. It's from the sides of the kids. They are not interacting with the parents, so they remain alone either in the mobiles, so they are under the depressions, etc. Lower quality of life, definitely whenever anyone go under the depression, the quality of life definitely get hampered. Muscle weakness, heat and respiratory system malfunction, increased susceptibility to the infection, as in case of our oropharyngeal carcinomas, HPV plays a very important role. Increased risk for the death, that is the endpoint. That is the endpoint where we kick the bucket. If we talk about the India, and we can see here, I have highlighted with the red, or we can see the maroon color. There is an increase in the incidence of the cancer cases. Here it is 6 lakhs, 8 lakhs, 9 lakhs, and the 10 lakhs. It is the studies, or you can see the data of 2012. Now it has increased a lot. So there are the few other factors. One is our environmental factors, genetic factors, age, risk, and the epigenetic factors. If we talk about the environmental factors, as Dr. Singh or Dr. VK sir has discussed, the viral infections, fungal infections, occupational risk, and the poor oral health. And genetic factors plays a very important role. Age. Now, being an oral physician, I will more emphasize on the tobacco smoking, and the patients who are having the more deleterious habits like the tobacco smoking, they more suffer from the either the homogeneous leukoplakia, speckled leukoplakia, or we can say the precancerous lesion. Then, if my book, to whom I say is my Bible, the buckets, it has mentions that whenever the patient is taking the alcohol synergistic with the tobacco, there is increased incidence of conversion to the squamous cell carcinoma. Clinically, we can say the malignant ulcer. Beetle quit swimming leads to the oral submucous fibrosis, reduced mouth opening, and everything. I have pictures of a patient. We'll discuss. Then diet and nutrition. My today focus will be on the diet and nutrition, how we have to bring this into our daily routine, and the mouthwashes, how the mouthwashes can be harmful for us. Yes, there are the various type of mouthwashes nowadays present in the market, few having the alcohol and non-alcohol and alcohol. I would like to more comment on the alcohol one only. When the alcohol, it's 20 to 70% of the ethanol in it. Whenever the ethanol come in contact with our normal flora, that is the candida or the other flora present in our oral cavity, it directly converted to the acetaldehyde. So this acetaldehyde is the carcinogenic, so which causes the dryness, etc., and then leads to easy penetration of all the harmful products that we are getting, that is coming out from our smoking. And areca nut or the betel nut chewing, they can easily penetrate into the deeper layers, and this leads to the carcinoma. And what are the other possible risk factors? I have highlighted because today my main topic is the how the cancer and the nutrition are correlated, how they are balancing the human body. So diet lacking in the fresh foods and the vegetables, and there's a huge list of the other factors. So how the good cells go bad, that is the carcinogenesis came into the play. Different type of cells have different lifespans depending on their location and the function. New cells are produced by the process of mitosis. Two type of genes that cause cell growth and divisions are proto-oncogenes and the tumor suppressor genes. In this picture, you can see how good cells become a bad cells. Here, there is the normal cell and there is the normal genes regulate cell growth. But when it's become a cancerous due to the increased burden of our carcinogens, or you call it the oncogenes. So there is the alteration in the DNA, RNA of the body. How do I clinically see my cases? You can see, in this picture, you can well appreciate there is the ulcero-proliferative lesion present at the ventral surface of the tongue and the floor of the mouth. As the tongue has high lymphatic drainage and more vascular, so there is the more chances for the penetration to the deeper area of the floor, and thus as the other lymphatic areas can be involved easily. Here we can say the ulcero-proliferative lesions are present in relation to retrocommissural area, well appreciate of the well diagnosed, so we can diagnose it as a malignant ulcer. Similarly, in these pictures, we can see on the right posterior buccal mucosa, ulcero-proliferative lesion with well-defined margins. We can see it is the angiogenesis also because it is more erythematous. It's the malignant ulcer. Here is the salivary gland. Okay, here's again ulcero-proliferative lesions at the base of the tongue, ventral surface of the tongue, and here is the soft palate. So it is more to be a oropharyngeal carcinoma. So these all are the original cases that I see on the routine basis in my department. And there is another one more case of the oral submucous fibrosis. You can see well appreciated in this picture. There's the blanching on right and left buccal mucosa with few pigmentation, and you can see the reduced mouth opening is there. Blanching is present in the soft palate with bird-shaped uvula. These are the characteristic features of the oral submucous fibrosis clinically. So here the patient was having little bit of the bone loss also, or osteomyelitis we can say. I couldn't take the proper pictures because of the stiffness of the buccal mucosa, because of the bands present in that area. But I have taken the, these are the other precancerous lesions, the homogeneous leukoplakia. This is the, we can say, the speckle leukoplakia. This is the picture of that OSMF patient. So here you can well appreciate, this is the orthopentamogram of this. If we compare from this side to this side, there is the well aligned trabecular pattern. But if we see on the contralateral side, there is a bone loss, irregular bone pattern. And what we can see, one more thing I would like to add in this, we can see this is involving your inferior alveolar nerve. This patient definitely was complaining of the paresthesia 2 reason also, because inferior alveolar nerve up to the mental foramen was involved. You can see how the quality of life of the patient has reduced, has affected. So moreover, we can see the floating tooth, which is a characteristic, radiographic characteristic of our squamous cell carcinoma or a malignant ulcer. So how I treat my patient is a case of a right side homogeneous leukoplakia involving the right posterior buccal mucosa. So I go for the laser excision, laser ablation. So can you see how cleanly I have removed that homogeneous leukoplakia? So this is the photobiomodulations, and yes, I treat my patient mostly with the counseling, and very, very important part in whether I am treating my TMD patients or a facial pain patients. Empathy plays a very important role in my working. So, and it works definitely. Okay. Because already their patients are so depressed. Whenever I used to tell patient, you are suffering from the precancerous, so they will not listen the word pre, they will listen the only word cancer, because the peer pressure of their peer pressure, they mostly talk about the cancer, but they don't listen about the pre. So just they listen whatever they know. So cancer word, so they automatically decreases their quality of life. Here my empathy and my counseling plays an important role. Maybe by doing these two things, I may improve the quality of life. So how can we see clinically a malignant ulcers, or how does a malignancy clinically present into the oral cavity? Ulcers that do not heal more than 2 weeks, definitely we have to go for the biopsy in those cases. Persistent discomfort or pain in the mouth white and red patches in the mouth or the throat, that can be the precancerous lesion condition. Definitely, if it is involving your pharyngeal area, sorry, the patient will be having the difficulty in the swallowing. Speech problem, as in case of the OSMF, a lump in the neck, firm to hard lump, weight loss because the patient is not able to eat anything, and bad breath, halitosis, a lump or thickening on the lip, a lump in the mouth or the throat, and these are the few others. Okay. So what are the side effects of cancer treatment and the nutrition therapy? Always keep one thing in the brain. Every time you eat or drink, you are either feeding disease or fighting it. So in contrast to this line, I would like to say we should always eat healthy and according to the need of the body. So what are the common side effects that I have noticed in the cases? So here in my department is the oral medicine department. So we used to see a lot of cases of the oral cancer, whether it is precancer, precancerous, or the malignant ulcer. And a few cases also came to us from the radiotherapy or from the onco department who have already went under the radiotherapy and the chemotherapy. So I have seen in those cases, there is a patient complaints of the vomiting. So vomiting is stimulated by the sensory receptors in the stomach, including stretch receptors and the chemoreceptors. The emetic centers, the vomiting inducing center in the brain responds to these signals by causing a wave of reverse peristalsis. See, our peristalsis is maintained by the enteric system, right? That is a part of our peripheral nervous system. So in this, the central nervous system and the peripheral nervous system both will come into the play. So chemotherapy causes nausea by acting both on the brain and the stomach. See, brain is the central and stomach is the peripheral. So how do we manage it? So what are the medical nutritional therapy, that is MNT? Avoid eating 2 hours before or after the treatment. Eat small frequent meals. Do not drink a large amount of liquid with your meal. You have to be before. If you will drink during the meal, so you will have a dumping effect, or again you have to empty your stomach. Again you will become the malnourished. Do not take heavy foods or greasy foods because that will stick to your other stomach areas. Eat food that are easy to digest. Avoid raw or high fibrous food, because if you will eat uncooked food, that will be very difficult to chew and your belly will not able to handle that. It is recommended to use ginger as a complementary therapy in the management of chemotherapy-induced nausea and the vomiting, as said by the Muthia et al. In 2013. Ginger have the gingerols, which is good for your stomach, and it was mentioned in this article. When I went through this article, it inhibit the nausea. Then swallowing. It causes difficulty in how the swallowing is affected. A xerostomia. It causes difficulty in chewing. Some chemotherapeutic drugs contain bleomycin and the dictinomycin 5-fluorouracil that causes a temporary dryness of the mouth. Radiation may damage the salivary glands. The time period is the 180 days or 6 months. Surgery that removes salivary glands will reduce the secretion forever. So how will we proceed with this problem? We have to advise the patient to go for the TAR taste, that is little bit acid taste, because that will induce the receptors present in our salivary glands, that is the muscarinic receptors, that will induce the salivary flow. So the best is the lemon juice, or about 50 minutes before the meal time. If the patient is not able to drink something tingling sensation to the mucosa, then we ask the patient to use the tablet Limsi 500 milligram TDS. Always take small sips of water, and we can also advise a patient wet mouth, which is a methyl cellulose, that is the artificial saliva. Then we can advise ice cubes. Dry mouth can be breeding ground for the bacteria candidiasis. So saliva play a very important role in protecting our oral cavity. So we have to be a little bit judicial. How the taste sensation all altered, that is the dysgeusia. Stimulation of the taste bud result in the taste sensation. that we all aware. Since the taste buds are formed from the taste dividing epithelial tissue, which is particularly sensitive to the cancer therapy. So how can we treat them? Avoid eating favorite foods before chemotherapy. Why? Because it can change in the taste, may cause an unpleasant association with your favorite food. Depending on the tolerance, use the amount of salt and the sugar. Use herb species to increase the flavor. So herb species is tulsi, turmeric, ginger, and mint. So foods that are cold at the room temperature may be more palatable than the hotter one. Why? Because you can taste the things. Hot will again increase your pain and the cyclic pain. How does the zinc plays important role? Zinc supplements may increase the taste sensitivity because zinc binds to the typical receptors, special receptors in our taste buds, and reduces the dysgeusia. Then anorexia. How this come into the play, either by the toxic effect of the therapy, localized effect of the tumor, and the surgery. How is the toxic effect of the therapy is there? Side effect of treatment such as the nausea, sore mouth, stomach cramps, and taste change can all decrease the desire to eat. Tumors in the gastrointestinal tract that cause blockages can decrease the appetite. Some tumors produce chemicals that affect the endocrine system also, resulting in the under satiety. Early satiety may kill the appetite, making nutrition difficult to achieve. Surgical removal of any part of the GIT tract can decrease the ability to desire to the eat. How can we treat it? We should take 6 small meals a day instead of 3 large meals. Why? Because small, frequent meals improve tolerance, enhance calorie intake. Why? Because for more time it will stay into the stomach, so it will be beneficial for us. So it also stabilize blood glucose and reduce GIT discomfort in the cancer patient. Always provide to whenever you are hungry. Don't wait for the meal time. Give the most nutrient dense food first. Avoid drinking liquid with the meal because that causes your fullness of your belly, and we called it as a dumping effect. Nothing will stay in your stomach, nothing will absorb, and you will get the nutrition as required. Oral and esophageal mucositis, that is a very important side effects of your radiotherapy. So whenever the oral mucositis begins with the tissue feeling dry and looking red, we should think on it. Now it's a time to give the patient some oral supplements. The mouth and the throat are sore. This is followed by the swelling, ulceration, and the bleeding. So what are the common causes? We have already discussed the causes are chemotherapy and the radiotherapy. So we should give in these patients soft, non-irritating foods such as yogurt, oatmeal, vegetables, mashed potatoes, and the yams. Serve food lukewarm or the cold. We should not give patient the hot things because already it is ulcer. If you're giving more pain to the patient, that will decreases him or his or her quality of life. Avoid acidic, tart, or the spicy food. Avoid dry, rough food as toast because that may precipitate the ulcer. If sores are confined to the tongue, providing a straw to bypass them. And use vitamin C and vitamin E on the diet. Then chemotherapy or the radiation sometimes has a toxic effect on lining of the small intestine also, because small intestine play a very important role for the absorption, excretion, and everything. So some drugs can injure the villi and microvilli, preventing the absorption of some nutrients, decreasing absorption. In large intestine, some drugs increase the rate of peristalsis and the transit time through the colon, resulting in less time for water to be reabsorbed. Some temporary intolerance to the milk sugar because of the temporary absence of the lactase. So we call it the transient lactose intolerance. So what are the medical nutritional therapy for that? Hot food stimulate muscle movement and may cause the diarrhea. So always we should give the patient the cold food, or we can say the lukewarm. Cold or lukewarm, never hot. Avoid raw foods because muscles have already been tensed, so will not able to chew the raw food. Moreover, raw food is difficult to digest. Avoid food and other dairy products. Give food that are easily digestible or absorbed. The nutritional care process is the driving effective how the its driving and effective interventions plays an important role. So, what are the various steps in that? First, we should go for the nutritional assessment, nutritional diagnosis, nutritional intervention, and nutritional monitoring and the evaluation. Because we have to compare the pre and post of the patient to whom you are giving the treatment. So there are the different tumor sites on the basis of their percentage. So if we see in that, we have the head and neck with the 72%. So how the diagnosis of the malnutrition is there? How can we diagnose the malnutrition and cachexia cancer? So there are the few steps in that we will discuss later on. But right now, what is the malnutrition? Whenever the patient is going for the insufficient energy intake, that leads to the unintended weight loss of the muscle mass, and the patient undergo the cachexia or the anorexia. So, what I would like to say, malnutrition is a different thing, and cachexia secondary to some chronic disease. Here we are talking about the cancer is the chronic disease, not about anything. So it is the cachexia, cancer cachexia. Wait, it got stuck. Okay. Prognostic impact, sorry for the inconvenience. What are the prognostic impact of the malnutrition? Here is the malnutrition, you can say from the both sides. Morbidity increases, mortality also increases. Okay. Wound healing decreases, infection increases, complication increases, and convalescence decreases. All over, treatment increases, length of hospital stay increases. So that will have a very depressive psychological effect on the patient's brain. So cost increases. What is the important is the quality of life decreases. So cachexia and the malnutrition, they plays a very important role in the cancer nutrition. So what are the screening method for the malnutrition? It should be simple and easy to complete. You should daily able to record the routine data. It should be cost effective in identifying nutritional problems. It should be reliable and valid. So now it's the time for the cancer cachexia. Cachexia is a complex syndrome that involves weight loss of muscle, adipose tissue, anorexia, and the weakness. Recovery may be there, may not be there. But in case of the malnutrition, whenever the patient will take proper nutrition, depending upon the other investigation, the recovery is possible. The cause behind the malnutrition is the poverty, not taking the proper food. It is not like the chronic diseases or nothing else. But in case of the cachexia, it is related to some chronic disease. Okay. So the key clinical features of the cachexia is weight loss more than 10% of your whole body mass, systemic inflammation, reduced food intake. So what are the other clinical features for the cancer cachexia? Muscle wasting, yes, it is also known as a wasting disease. Weakness, edema, progressive involuntary weight loss, and remnant energy is a major determinant in the patients developing the cachexia. Impaired immune response and hormonals and the metabolic abnormalities and reduced food intake. So what is the resting energy expenditure? So the resting energy expenditure is what? So whenever the patient is ill or suffering from some chronic inflammation, So in that case, when the patient is lying in the bed, so some amount of energy is left in the body, because he or she has to handle the vital function also. So at that time, the REE, which is a major determinants, they comes into the play. So this is the picture that I have taken from the net purely. How does it look, the cachexic patient? You can say it's a no mass, no muscle mass, nothing is there. You can well appreciate the bones. So what are the stages of the cachexia? So pre-cachexia, cachexia, and refractory cachexia, and then leads to the death. So better is to control at the pre-cachexic stage only, before patient will kick the bucket. So how can we diagnose the cachexia? So if you see the weight loss of a patient is at least 5% in the 12 months, or BI is less than 20 kilogram per meter square, then we can think of cachexia. Decreased muscle strength, fatigue, anorexia, any 5 of 3 are present in the patients. You can see in any patient, and that you can see it as the cachexia. So what are the other intervention or assessments tools we require for the cachexia? It's a crucial element of providing quality of the nutrition care. So this is a questionnaire, a pre-questionnaire that requires to before proceeding for the assessment of a cachexic patient. How can we assess the nutrition in these cases? We have to evaluate the body weight. That should, if it is less than the 20 kilogram per meter square, directly it is a cachexic patient. How can we assess the physical performance? We have few scales, that is the WHO Eastern Cooperative Oncology Group Scale, that is the ECOG, Karnowski Performance Status Scale, and the functional assessment of the muscle mass by using the walking speed test. How we can assess the body composition? By the DEXA, MRI, and the hand grip dynamometry. What is the goal of nutrition and intervention? The goal of nutrition intervention should be improve quality of life, optimize the effect of treatment, limit adverse effect of treatment, prevent and treat the nutritional deficiency. So we have already discussed about the resting energy expenditure. The recommended energy intake is at least 30 kilocalorie per kilogram per day. So what is the normal requirement for the protein? For the normal kidney function, the dose up to and above 2 gram per kg per day is the safe. If it is more than that, our kidney function can be hampered. Acute or renal, in case of the acute or chronic renal failure, we should not exceed 1.0 to 1.5, 1 to 1.2 gram per kg per day, respectively. Now comes to the micronutrients, which includes the vitamin, minerals, and the other trace elements like selenium, magnesium. So according to the European Society for Clinical Nutrition and the Metabolism, that is ESPEN, all patients with cancer who assume less than 60% of their daily energy requirement for more than 7 to 10 days have an inadequate supply of the micronutrients. So they will suffer from the loss of appetite, repulsion to particular food as a result of the anorexia. So how the cancer and the nutrients? So I will not go much deep into, we will just brush up the things, right? How the carbohydrates and the cancer are related. So one of the purpose of the nutritional therapy for the cancer is to deny the growing tumor glucose while providing enough to feed the brain and to form the red blood cell. As nowadays we are going through this Instagram and everything, the videos everywhere, they are telling the glucose is not good for our body, because if we are taking the bulk of the glucose as by the recommended dose by the RDA, then it can increase the growth of our cells. So that may be some carcinogen or something. So this can be done in a crude way by keeping the blood sugar level even. Okay. One way is to eat food that have a low glycemic index. There is a huge list of the low glycemic index, like cereals, the dal, and palak, and some other, the dry fruits, almonds, and which having the high glycemic index, the watermelon. So these are the few fruits, and the other eatables we should keep always in the brain before eating that. Another way can be by the low carb diet. A low carb diet is usually one that get 40% of its calorie from the carbohydrates. Okay, one more, like I would say the low GI index is the 50 or 55. We should not eat the glycemic index which is more than this, so they can be harmful for us. According to Austin et al., positive calorie balance and the resulting accumulation of body fat during adult life also increases the risk of the important human cancers. So we should stay fit, because we have to be fine. Okay. Then how the protein and the cancer is related. Cancer cells change the metabolism of protein, that is the normal protein, so that more amino acids are available for the tumor growth. So that causes a lot of muscle tissue loss. So most of protein in the diet should come from the plant sources, as it comes with complete numerous cancer fighting nutrients and the phytochemicals. Nowadays phytochemicals in a trend. Okay. How the omega-3 fatty acids and the cancers are related. Omega-3, one thing is the omega-3 and one is the omega-6. I will discuss that also. The omega-3 fatty acid protects the cell from the cancer developing. The biological activity of both the lipid mobilizing factors and the protein mobilizing factor was shown to be attenuated by the eicosapentaenoic acid. So eicosapentaenoic acid is one of the important component of the omega-3. So the high intake of this omega-6 increase the development of the breast, uterus, prostate, and the colon cancer. That is the linoleic acid is the part of the omega-6 only. It's the main is the causative cancer for the cancer. What are the micronutrients that are how they are correlated with the cancer? Vitamin minerals is always on the good half of our cancer that have shown be a protective role in the cancer. Vitamins, they play a very important role, especially in the oral precancers and the cancers, because they help in the they have a anti-keratinolytic property. If we see if we are planning to give to the patient in some homogeneous leukoplakia, so it plays a very carotenoids, retinoids, they plays a very important role. A diet rich in the vitamin C gives a lower risk of developing the cancer of the stomach and the esophagus. Antioxidants and cancer, yes, definitely. Why it is known as the antioxidants? Because the free radical will come to play. There's increase the chances of the cancer. So they inhibit that free radicals. So epidemiological studies strongly suggest that high intake of food rich in beta carotenes as well as vitamin B and C decreases the risk of the cancer. I've already discussed the carotenoids. Vitamin E helps in the stabilize of most of the oil derived from the part. In cases of the oral submucous fibrosis, to inhibit the inflammation, we give the vitamin E. It also inhibits the formation of nitrosamines, especially at the low pH. So nitrosamines is again the carcinogenic. So here the antioxidants will play. In my all the patients, whenever we are treating some habit related and any of the malignant ulcer, we should add, I would like to add the patients on the antioxidant. The commercially available like Tomix, which is having the curcumin and the piperine, because black pepper is important for the absorption of the tongue. Otherwise, it will cause the stomach upset in few patients. Then we give it as the Oxytard available. It is a Ayurvedic property preparation. Then we give the B complex depending upon the pocket of the patient. Mostly patient except for the Tomix, Lycored. Lycored is little bit costly because here my is the tertiary center. So all the people from all the areas of the Haryana come to this area. So most people are poor, few are well established. So depending upon the pocket of the patient, I always advise them. I always ask before giving, आप afford कर सकते हैं या नहीं कर सकते हैं? Because I have to keep everything in my brain, because I am treating the patient whose quality of life has already deteriorated. I am here to treat them with empathy, with counseling. I am not there to letting them more down as already they have already. Okay, so there is a huge list of the antioxidants that comes to our daily use play. So this is the vitamin E that decreases the risk of oral and the pharyngeal cancers and the beta carotene. There is the table we showing the how much the plasma level should be of the each micronutrient should be there. So according to the International Cancer Research of America, it's a new American plate. I would like to say that the Indian should also include this into our daily. And yes, I have to include it. I was 110 kilograms. I have reduced a lot because I know if I will stay fit, my family will stay fit, and yes, it will be good for all of us. So what does this American plate tell? Here you can see there is the less animal protein and more veggies, fruits, grains, and beans. Okay. So thus to conclude, oral cancer incidence is high in our country, and I would like to say it's a global burden nowadays. Nutritional support provide patients with the energy and nutrients to maintain or improve their nutritional status and immune function, which can improve their quality of life. It's not about the cancer patients only. I would like to see who are the listeners, my seniors, my juniors, everyone. I would like to say nowadays we should be less on the carbs. We should eat more fruits, veggies as required. Okay. So we cannot enjoy our wealth if we are not in the good health, as our old people always says, health is wealth. If you will not having the health, how can you enjoy the wealth? So by stop smoking, areca nut, betel nut, alcohol, unnecessary medications, hookah, this alcohol and IV drugs, etc. These all will lead to you to the deathbed. Paradoxically, we should have a healthy thinking. We should go for the regular exercise. As very important is the healthy food. So these are my references. If we lose the, I would like to end with the simple quote. If we lose the battle against the tobacco, we will lose the war against the cancer. So we should treat the patient judicially with the empathy and with the counseling. Thank you. If you have any questions, I'm here to answer. Thanks. Thank you for the patient listening.
Thanks, Dr. Cheena, for giving your precious time and joining early part of this conference. I'm just requesting from the delegates who want to ask any question related to medical nutrition therapy for patients suffered with oral cancer, particularly, they can ask the question. Nutrition is playing very crucial role in the journey of a cancer patient, because apart from this surgical excision or chemotherapy or radiotherapy, nutrition plays a very important role in making, because patient getting cataxic and the patient is not having food, losing their weight, etc. So it's compromising their life, so that's why nutrition is very important. So any budding dental surgeon or oral health crusaders who are treating their patients and all, and they are complaining about their test buds, they are complaining their nutrition, low diet, etc., they can ask question to Dr. Cheena and she would be answering. You can also put the questions on the chat box and she can answer now or maybe in a later part of this conference. So there is no question right now, Dr. Cheena. If any questions arise, I will come to you. I'll request you to stay with us. And we are, lagging say 15 minutes, so we are rushing to our next session. So with your permission, Dr. Cheena, should we move to the next speaker now?
Yeah. Thank you, sir. Thank you, sir. Yeah, thank you, sir.
Thanks, Dr. Cheena. So we have our next speaker, Dr. Saurav Juneja. Dr. Saurav Juneja, we are fortunate that he is joining first time in this 6th edition of International Oral Cancer Congress. And He is a oral maxillofacial pathologist, and I just would give him a brief introduction, and then we'll take his session. Dr. Saurav Juneja is a professor and head of the Department of Oral Pathology and Microbiology in Sri Banke Bihari Dental College and Research Center, Ghaziabad. Dr. Juneja, can you unmute so that I can hear that you are? Yes.
Yes. Good morning, sir. Good morning.
Yeah,
Thank you, sir.
very good morning. Yeah, you are audible and you are
Thank you.
visible
Thank
too.
you.
Okay. So, presently working as a professor and head Department of Oral Pathology and Microbiology in Sri Banke Bihari Dental College, Ghaziabad, Uttar Pradesh. He did BDS in 2002 and then did his master's from MS Ramaiah Dental College in 2009 batch. He is fellow of PFO Card Academy USA, principal investigator, co-investigator in 6 funded projects from ICMR, Ministry of Health, Government of India for postgraduate research. He is principal investigator, co-investigator in 4 funded projects, STS from ICMR, Ministry of Health, Government of India for undergraduate research. He has 1 patent granted by Intellectual Property of India, Government of India, nearly 80 publications in indexed PubMed Scopus journals. He has he authored 5 textbooks and have also co-authored chapters in textbooks like Dental Pulse, 9th edition, and Manual of OPMDs by OPMD Hub, Lady Hardinge Medical College, Ministry of Health and Family Welfare, Government of India. He is very resource person in various conferences and workshops. He is editorial board member in index journals, many boards. He has also done advanced oral implantology course affiliated to UCAM Spain. He get award for best emerging forensic odontologist by CAFO in 2021. So over to you, Dr. Juneja. If I am missing anything, any recent award or any accreditation, you can add on and you can start your presentation.
Thank you so much for your kind words and introduction, sir. I'm very thankful to you for providing this opportunity to me and so that I can share my ideas on this platform. Thank you so much. Can I share my screen now?
Yeah, you can.
So is my PowerPoint visible?
Yeah, it's visible.
So once again, thank you so much to the organizers, Dr. Nurul, for providing me this opportunity. As the theme of your conference is the current perspectives in oral potentially malignant disorders from detection to intervention. So I have kept my presentation also following the same theme. And I am here to talk about the impact of oral cancer, especially in the Indian scenario, and what we need to do, what resources are available for us, as I would be highlighting the main reason why we are having such a high mortality rate in oral cancer. So I will be dealing with brushing up with the few etiological causes of oral cancer where we need to act, and what are the early diagnostic aids that are available to us or are going to be available in the near future with the advent of artificial intelligence and all the technology and information that we have with the help of the internet. And within the next few years, few things have already started to be available in the market, affordable. And what more few things which are going to be available within the next few years, immediately I feel, so within the next 3 to 5 years. And we should be aware of what is coming to us so that we also keep abreast with the latest technology, and we can advise our patients that these are the things which are available which can help you to early diagnosis, especially at the potentially malignant disorder stage. So I am coming from Sri Banke Bihari Dental College, where I'm heading the Department of Oral Pathology, where we are dealing with such kind of patients. And I have always this idea in my mind that whenever the patients are coming to you, how can you help them to avoid having oral cancer once the cancer is detected? then the treatment plan and the prognosis is totally in a different direction, where we are thinking of how the patient will survive minimum 5 years. But here, my point of view is that we should be targeting the patients when they are, we should take the history properly, when they have a habit of tobacco, areca nut, alcohol, all these factors which are pushing them towards a later stage of oral cancer. And we act at that point only, where we motivate them, we guide them, and we help them with diagnosis at the early stage. So these are the pointers under which I'll be covering my presentation. I'll be talking about the etiology, the current epidemiological scenario in the Indian perspective, what are the different types of smoke which we sometimes overlook around us, and the various diagnostic methods, chairside diagnostic methods, advanced diagnostic methods, and the newer methods which are going to be available within just the near future, as AI is coming in a big way in the healthcare sector as well. So just to start with, as all of us know, as the speaker before me also told, that oral cancer is a rampant form of cancer, especially in the Indian subcontinent. And the most important and dissatisfying part is that it has a very less 5-year survival rate of less than 50%. I've been studying this for the last 20 to 22 years, and this number is not improving at all. In fact, this number is decreasing. So that is something which is striking, which is always taking my attention. But luckily, these oral cancers are preceded by precursor lesions called as oral potentially malignant disorders, of which the most common ones are leukoplakia, the white patch which appears in the oral cavity, erythroplakia, the red patch mixed with sometimes the white patch, erythroleukoplakias, oral submucous fibrosis, which is very rampant in the Indian subcontinent, oral lichen planus, and some of the predisposing factors which are associated with nutritional deficiencies such as vitamin A deficiency, iron deficiency, zinc deficiency, which are important for maturation of the oral epithelium. So when the patient has these nutritional deficiencies, as the speaker before me, Dr. China, also told, then also he is predisposed to develop the oral cancer, because the effect of the carcinogen is even more. It is manifold when the patient's immunity, the nutrition is hampered. So oral squamous cell carcinoma is, in a broad term, is a malignancy which is arising from the oral epithelium, which is made up of squamous cells. So oral squamous cell carcinoma can involve any part of the oral cavity, right from the lip, perioral area, the tongue, the floor of the mouth, buccal mucosa, tonsils, and the oropharynx and the upper third of the esophagus. So all these combined together are included in the term of oral squamous cell carcinoma or oropharyngeal carcinoma. The 5-year survival rate is not at all improving, despite all the advances which we are going to talk about also. And our focus should be to improve the patient's well-being even after the treatment. Then the patient should be able to survive and have a healthy living, a well living after he has got the treatment. Now, this figure is not high, not because of the lack of treatment or the facilities. Yes,
Dr.
sir.
Saurav, sorry to interrupt you. Can you make your slides on a presentation mode?
Yes, it is on a presentation mode, sir. I'll do it again.
Yeah, please. We are on the title slide, first slide.
Is
Yes.
it moving?
It's moving. Now we are on several diagnostic technologies has been developed to facilitate.
Yes, sir. Yes, sir. Yes, sir.
Okay.
So several diagnostic technologies have been developed. Now, I was at the point that this survival rate is not improving not because we don't have sufficient treatment facilities, only because the patient is reporting late to us, because probably he's not knowing enough about what are the signs and symptoms of early oral cancer or OPMDs, and he's not able to report at the right time to the oral surgeon or the dental surgeon. So various diagnostic methodologies are available where the OPMDs can be diagnosed at an early stage, and we can prevent them from transforming into an oral cancer. So some of these have been translated from laboratory setup to clinical setup. So the translational research is already going on, where a lot of clinical trials are going on, in which how to utilize these diagnostic systems which are already developed after phase 2, phase 3 trials, and now they are being employed into the clinical setup for the welfare of the patient. Furthermore, these novel biomarkers, various electronic systems, along with incorporation of artificial intelligence, has helped us to go into a new era where OPMDs and oral cancer may be diagnosed at an early stage, and the mortality rate can be decreased. So now, just quickly brushing up the etiological agents, which are increasing day by day with the advent of all the things which are available around us. So as a developing nation, we are at the brink, we are at the crossroads where we have to fight not only addiction, but also the disease. So oral cancer and OPMDs, oral potentially malignant disorders, are slightly different from other forms of cancer in the body, where we have to fight the addiction part also. The patient is having this addiction, especially to tobacco, areca nut, alcohol, not for a few days or a few months or a few years. It is for many years that he is consuming these carcinogenic agents, and then he develops a disease. So we have a long time where we can act. So as we know that smoking is the common form which is associated with the oral cancer, tobacco is the major culprit. In Indian subcontinent, the smokeless form is also very common, where the patients are mixing the tobacco with another carcinogenic agent, class 1 carcinogenic agent, that is areca nut. So all these combined, they have a synergistic effect. Plus, some of these patients, they have a ill habit of alcohol use. Some of the patients who do not have any habit, they do not have a habit of smoking or alcohol, the female patients especially, there's an increasing evidence that human papilloma virus, the HPV, is associated with the development of oral cancer, especially the tongue oral carcinomas. They are associated with the infection of human papilloma virus. Weakened immunity, the patient's immunity is weakened. He is not able to fight or counter the carcinogenic effect of the ill products that he's using. Genetics, he would have inherited certain genes which are already mutant from the parents. And sun exposure, not so much in the Indian subcontinent, but in the Western countries, the middle third of the face, the tip of the nose, and the upper lip are more prone due to the actinic exposure. Now, we all are talking about the smoking and the ill effects of smoking, but there are also certain patients who are telling that they do not have any habit of smoking. So then also they are prone to develop cancer because there is something called as second-hand smoke or passive smoking. So we are always exposed to second-hand smoke or passive smoking around us, where people around us who have smoked in the environment, and we are inhaling. So when this smoke comes into contact with the air and the free radicals present in the air, then the carcinogenic agents become even more harmful. So there are various carcinogenic agents, more than 4,000 chemicals which are excreted out, such as chromium, arsenic, lead. All these are heavy metals, and they are highly hydrogen cyanide, carbon monoxide. All these are heavy carcinogenic agents, which in small doses, which we are inhaling day in, day out, are going to have a cumulative effect, dose response relationship, as the person is inhaling this. So there's a data given by the Johns Hopkins University in 2024, in which the exposure to the secondhand smoke, especially in the workplace, the public places such as restaurant, bus stops, is very high. And India is among the top 15 countries where the exposure to the secondhand smoke is very, very high in the workplace, restaurants, and even at home. There's something called as third-hand smoke, which is also to be taken note of, where when the person has already smoked, the smoke which is in the air then settles down onto the hard objects, onto the hard surfaces around us. For example, suppose a person has smoken in a room. The smoke will settle down onto hard objects such as a bed or a pillow cover, or where the toddlers and pets, when they come in contact with those surfaces, they are touching those surfaces, and then they're putting the hands in the mouth, or they're eating something. So then also, such a small toddler or a young children, they are also exposed to these kind of carcinogenic agents from tobacco due to the third hand smoke. Now, there's a recent WHO study which is published in the newspapers also, it has come, that we should be also wary of the preventable risk factors which are around us. So we know already about tobacco, alcohol, but there are other factors such as obesity, infections, and air pollution. Very important. Air pollution recently has been contributory factors to developing oral cancer. So we should take note of various things around us, and we should try to avoid it, such as obesity, physical inactivity, air pollution, and infection, as I told, HPV, Helicobacter pylori, and candidiasis, which are all commensals in our body. Candida is commensal in the oral cavity, H. pylori is commensal in the gastric cavity. Now, we should try to alter. My aim of the presentation is how do we prevent oral cancer at an early stage. So we should modify our lifestyle. Obviously, we should avoid exposure to tobacco, first-hand exposure to tobacco and alcohol, and we should modify our lifestyle so that we avoid obesity, unhealthy dietary patterns, sedentary behavior, and counter the air pollution around us. All these are contributing factors to various kind of cancers. Now, I would like to highlight few important points about oral cancer as we go ahead, that it is more common in males and as compared to females, but the number is increasing in females as well, as I told, due to the human papillomavirus infection. The age at which it is affecting the individuals is around 40 to 45 years, but this number is coming down very rapidly. We frequently now come across patients who are 25 to 30 years of age, and they do not have a habit for long duration. They are only 30-year-old, probably they have a habit of 5 to 10 years, and they are also developing cancer because of the, maybe, as I told, a lot of contributing factors other than tobacco also, which are making him more prone or predispose him to development of oral cancer. All forms of tobacco and alcohol are a major risk factor for oral cancer, and it is our duty to tell the patient that when these risk factors they combine, they are not additive, they are synergistic. So here 1 plus 1 is not 2, here 1 plus 1 is 11. So they have a synergistic effect. One increases the effect of the other manifold. So there is one person who is being killed by oral cancer every hour in America, which is a developed society. And the number is even more in Indian scenario. And these are the reported patients, and so many patients who are unreported. So the number is very high. So the health burden on us is already very high. So what should we do? We should tell the patients to undergo regular dental checkups. There are many signs and symptoms which a dentist can examine and tell the patient at an early stage. We should tell our patients any ulcers or any swellings in the mouth which are not getting treated within the next 14 days. He should report immediately to the dentist. So only way of improving the survival rate of patient apart from treatment is early diagnosis. That is the best chance of survival, and obviously avoiding the risk factors. Now, this is how to study the epidemiology of the oral cancer. So this is a global chart in which we can see the majority of the, if we see the population of the world, the majority of the population is the European and Asian population, with 60% of the population in the Asian continent. And that too in India and the Indian subcontinent, around 20% of the global population is residing. So if you can see here, this is the region-wise epidemiological rate of incidence of oral cancer in males. And you can see this brown area, the Indian subcontinent, India, Pakistan, Bangladesh, Sri Lanka, and all these areas are we can say the oral cancer capital of the world based on the incidence. And also the mortality rate, as the mortality rate is very, very high. The number of patients which are affected are more as per the global population. The mortality rate is also very, very high in the Indian population. Another way of studying oral cancer incidence can be based on the Human Development Index. So the countries in the world can be divided based on the Human Developmental Index, which is based on the education level, the GDP, the facilities which are available to the people of the country, and they can be divided into high, medium, and low HDI index. And you can say that the lip and oral cavity cancers, they have a very high proportion in the low and medium HDI group, where the Indian country or the Indian subcontinent falls. So we are facing a severe global health challenge where we have high number of incidents of lip and oral cavity cancers and associated with even higher mortality rate. That is the challenge that we are facing. So this is a newspaper cutout in which it is saying that already there are nearly 10% of the people who are suffering from cancer in India at around up to 75 years of age. But the lower data is very, very important, in which we can see that the number is going to increase manifold. So this is the prediction by IARC, in which they are telling the number is going to increase up to 77% in the next 22 years. So this is an alarming number, despite all the tools that we have and we know the extent of the disease around us. Now, coming to the Indian scenario, within India also, we have different presentations of the oral cancer based on the epidemiology. In the northern part of India, the common risk factors are the smokeless form of tobacco. It is very, very rampant in the northern part of India. In the western part of India, the alcohol along with tobacco is the rampant form. which is affecting the population. So depending on where you are practicing and from where the patient is coming to you, you have to take into account the risk factors of the patient. In the southern part of India, betel quid is highly rampant along with tobacco. People mix with betel quid with tobacco. In the eastern part of India, if you see this data, the age group is very strikingly lower. So age group in the eastern part of India, based on the epidemiology, is in the younger age group. As we go towards the eastern part of India, the females are affected more. So if you see the epidemiological chart of India, if we divide the Indian region into 5 zones, we can see that every zone is having different kind of epidemiological presentation and the factors which are affecting the people. Now, quickly coming on to the diagnostic methodologies. Obviously, the first and the foremost is the visual oral examination. It is the routine screening method. When the patient is coming to you, please devote ample time to examine the soft tissues other than the hard tissues also. So it depends on the physician's experience also, his expertise, so that he is able to differentiate benign lesions from OPMDs and malignant lesions. So in case of oral cancer, why it is unique? Because it is easily amenable to a visual examination by the physician, by the oral physician, as well as the patient as well. We should be able to tell the patient also what to look for. And there's a stage of OPMDs, which is totally preventable. Unlike any other cancer of the internal organs of the body where you cannot detect OPMDs because they are not visible. So in the oral cavity, we have the advantage that we have a stage from benign to OPMDs before it is turning into cancer. So that is where we should act. But there's a drawback with just visual oral examination, that it depends on the examiner's quality, knowledge, and experience. It requires frequent training and calibration of the screeners, and some lesions, they are ambiguous just by visual oral examination. So we need to differentiate benign lesions from OPMDs and oral cancer. So we need few more tests. So as we know that biopsy is the gold standard, this line everybody talks about. Biopsy is the gold standard, but it's a minor surgical procedure. So it's a well-established systemic examination of the tissue under the microscope for histopathological examination. But there may be certain condition in which the patient may not undergo a biopsy immediately. He has to undergo a pre-anesthetic clearance. He may be having certain other conditions which may prevent him from undergoing a biopsy immediately. The tissue, the lesion may be close to a vital structure also. Finally, he has to undergo a biopsy. But there are other things also which we can do before we reach the step of biopsy. So whenever we do a biopsy, if there are multiple lesions which are present, there are extensive lesions which are present, then probably we have to do more than one biopsy, as different lesions within the patient at different sites may present different severities. So when a patient is coming to you with a multifocal lesion at multiple sites, we need to do multiple biopsies to arrive at a final diagnosis depending on the presentation on that particular site. Now, coming on to the advanced diagnostic methods which are already available to us and few which are in the developing stage. So we have a common diagnostic tests which are available and used in clinical practice, chair side. There are newer development methods which are already under clinical trials, and new developing technologies with the help of artificial intelligence and lab-on-a-chip technologies, which is going to be available very soon to us in the clinical practice. So first is the intraoral vital staining. First is toluidine blue staining, which is a very simple test in which we apply a very simple dye called as toluidine blue. And we apply it onto the oral mucosa. And as you can see in the pictures, the lesional area will take up the toluidine blue stain. So as the severity of the lesion is increasing, the color of the dye taken up by the lesional cells will increase, because it is dependent on the number of dividing cells, the proliferating cells. The nucleic acids present within those cells, they take up the stain. So the more the number of the dividing cell pool, the load of the cancer cells, the more will be the dye which is being taken up by the lesional tissue. It has a very good sensitivity of 92%. The specificity is not so high, so it is used for a screening method or biopsy site selection. So if we have a lesion with multiple sites, or we are not knowing the boundary of the lesion, we can use this toluidine blue to highlight the boundary of the lesion the extent of the lesion, and to select the site of the biopsy. Site of biopsy selection is very important, because if you do not take a biopsy from the correct, most representative area, then you may underdiagnose the lesion. So if you can see the pictures here, you can see here that the stain is very clearly highlighting the extent and the boundary of the lesion. So the surgeon can take a biopsy, a wedge-shaped biopsy, including the marginal area and the lesion proper, the center of the lesion. Another dye, simple dye called as Lugol's iodine, similarly can be used, and it can also be used combined with toluidine blue. Both of them, when used together, they have increased sensitivity and specificity in diagnosing OPMDs as compared to just toluidine blue or just acetic acid. So combination of staining may yield a better result. Another simple chair-side, non-invasive, inexpensive method is exfoliative oral cytology. Exfoliative oral cytology is dependent on a principle in which we know that the oral cells are exfoliated into the mouth, and we can use a simple spatula, a wooden spatula or a steel spatula, or we can use a specialized brush called as a cyto brush. We scrape the layers of the epithelium with this brush. We transfer the scraping onto a slide, and we immediately fix it with 95% alcohol. And the advantage is that we can prepare multiple slides, and we can send the slides to the lab, and we can ask the lab to do multiple stainings on the slide. So for example, we can ask the lab to do a routine HND staining. We can ask the lab to do a PAP staining, which can tell us different colors of different layers of cell. And we can also ask the lab to do a PAS, periodic acid shift stain, which is a specific stain for Candida. As we know, Candida is also a risk factor for developing oral cancer. Now, the advantage of this is that immediately we get the result within 45 minutes to 1 hour. It is a very simple, rapid, inexpensive, and non-invasive method of screening. So suppose if we are organizing a oral cancer screening camp, so there may be hundreds of patients. You cannot do biopsy in all of those patients. So you can do a chair-side exfoliative cytology screening test. And based on the result, you can categorize your patient into high risk or low risk. So class 1 and class 2 smears are generally deemed to be safe. Class 3 is intermediate stage, and class 4 and class 5, those patients have to undergo a biopsy to confirm the diagnosis. So you can triage your patient in a way that some patients who may not require a biopsy and some patients who will require a biopsy. So this is a very useful chair-side screening method. Now, there are various other methods also which are now available based on the optical imaging systems. So these are light-based technologies which are available to us now, and for detecting the OPMDs. So my target is detection of OPMDs. So they are targeting the tumor cells or the cells which are showing more proliferative potential. So one of the principle is chemiluminescence, in which a fluorescent light is incident onto the oral cells, and there's an intraoral detector which is going to capture the images. So the color of the light which is reflected from the oral epithelium is used to assess the condition of the oral epithelium. So first is the chemiluminescence-based devices. Chemiluminescence refers to the emission of the visible range of light radiation after the electrons, when they are excited by a chemical exergonic reaction, they return from an excited to a ground state. So we all know that light is a form of energy. Photons are packets of energy. When this light is incident onto the cells, oral cells, they take up the energy and they get excited to a higher electronic shell. So when they come back to their neutral or the ground state, they emit the remaining energy which they have absorbed, and the change in the color of those cells, the reflectance phenomena of the cells, is what this test is based on. So there's a proprietary device called as Visilight, which is available, that is based on the reflectance phenomena that indicates the proportion of incident light onto the given surface. So this Visilight device is emitting a blue colored light in the range of 430 to 580 nanometers into the oral cavity after the patient is asked to do acetic acid wash, and abnormal oral mucosa is distinctively white in appearance, whereas normal oral mucosa will appear slightly bluish in color. So this is how the device is used. When the incident light is held onto close to the oral mucosal surface, the cells are absorbing the light energy, they are getting excited, and when the cells are coming back to their normal ground state, they are emitting a light which is being easily seen by the clinician. The next property, which is optical phenomena, which is used, is autofluorescence. What is autofluorescence? It is referring to the phenomena of light where a particular wavelength of light interacts with the cells and causes excitation and re-emission of light of different wavelengths. So the cells are absorbing the light, some portion of the light, and emitting the remaining energy pattern of the light. So the spectrum changes. Suppose there's a high energy wavelength light which is being incident, the cells will absorb certain portion of the light and emit the remaining. So the emission will have a different color. For example, if you see here, this is the lesion on the tongue. So we can see that there is an alteration in the mucosa on the tongue, but we cannot see the extent of the lesion because it is merging with the surrounding mucosa. So when this light is made incident, so you can see the change in the color of the lesional area, and there's a nice contrast. So the cells absorb the light and emit the remaining portion, and the lesion appears as dark area, contrast with the adjacent tissue. So you can very clearly see the highlighted area, and you can see the boundaries of lesion. So this can help us to differentiate a benign lesion from an early oral cancerous lesion, and especially the clinical margins to select the biopsy site. Now there are newer methods which are available to us, which are under process, under development, and they are already clinically validated and FDA approved. So these include the markers which are targeting the DNA, mRNA, or the protein. So there are biomarkers present in the DNA, RNA-based biomarkers, and protein-based biomarkers which are available. So one by one, we'll see them. So first is the DNA methylation biomarkers which are available. So the physician has to collect the oral exfoliated cells, just as I told in the previous slide. You just have to collect the oral exfoliated cells from the lesional area, suspected area, and the cells specimens are subjected to DNA extraction. So the oral mucosal cells, the exfoliated cells also have DNA, a good source of DNA, and the DNA is extracted from those cells, and there's a DNA bisulfite conversion which is carried out. After which the ratio of the unmethylated to methylated cytosine and uracil is calculated. So the ratio of unmethylated and methylated cytosine is calculated, and based on the ratio, we can predict, we can tell. Now this is more specific as we are targeting the DNA. A methylation specific PCR is carried out, and we can tell the amount of methylation which has happened. So methylation is a damaging kind of a epigenetic change which happens in the genes or the DNA, which is having a rampant effect on the cells. So one such example is ZNF582, which belongs to the transcriptional regulators of the zinc finger protein. And recent reports have told that ZNF582, specifically in relation to nasopharyngeal carcinoma, is a tumor suppressor gene. So if there is increased methylation which is occurring at the ZNF582 locus of the DNA, it means the tumor suppressive action of the gene is not functional, and there is a dysregulation of the transcription and expression of adenosine molecules, leading to hypermethylation and increased chances of metastasis of these carcinomas. So this is very useful. So if we have a patient who is having a carcinoma, how to predict whether this has a chance of metastasizing to a distant organ is one such example is that we detect the ZNF582 methylation pattern in that patient. Similarly, another gene or locus which is target is PAX1, which is a paired box domain and plays a very important role in crucial role in development during embryogenesis, as well as it also acts as a tumor suppressor gene. So again, high level of methylation of PAX1 leads to the suppression of the tumor suppressive action of the gene, leading to initiation and activation of the tumorigenesis, especially the oral cancer and the cervical cancer. Now coming on to the mRNA part of the target biomarkers, one such marker is ornithine decarboxylase antizyme, which is induced by a polyamine dependent mechanism, and it is related to DNA repair. So if it is not active or it is not able to do its function, the cells are not able to repair the DNA or the mutations occurring in the DNA, and therefore it is linked to increased metastatic potential of the human oral squamous cell carcinoma cell lines. DUSP is a subtype of cysteine-based protein tyrosine phosphatase and is involved in various signaling pathways. Salivary DUSP1 mRNA. Now this is present in the saliva, and saliva, as we know, is easily collectible, non-invasive method, and is significantly increased with OSCC patients compared with normal controls. Now coming on to the protein biomarker, CD44, cluster of differentiation 44, is a cell surface glycoprotein that is involved in many cell regulation pathways, including cell proliferation and migration. It is very importantly a initiating factor and a stem cell factor in the tumor cells, and its expression in oral cancer, overexpression in oral cancer is associated with initiation and stemness properties of the cells. So in normal epithelium, CD44 expression occurs primarily in the basal and the suprabasal layer, which is the dividing pool of the cell, which is normal. But when the dysplasia is progressing, the histological dysplasia is progressing, CD44 expression migrates into the superficial layer. So it means that one of the dysplastic features that the superficial cell layers are also incorporating features which are giving them a property of proliferation and stemness. So they acquire a mutation which is helping them to replicate even in the superficial layer. Now, there are various point of care in vitro devices which have been developed to detect CD44 in the saliva sample. So one such proprietary kit is B Vigilant TM Rapid Test, which is developed by the Vigilant Biosciences. It is an approved POC IVD in which qualitatively it can identify the soluble CD44 levels in the saliva and the total protein levels in the saliva and their ratio. And therefore, we can triage our patient based on the risk factor, based on the presence of increased level of CD44 in the saliva. Now, there's another protein called as S100A7, which is a calcium binding protein, and it is a member of the calcium modulated S100 family. It is expressed in the upper well-differentiated spinous layer of the normal epithelium. So overexpression of S100A7 is found in high-risk dysplastic oral lesion associated with cancer development. And again, a kit has been developed in which you just have to put the sample and it will tell you the S100A7 levels. Now, as we are stepping, or we have already stepped into the era of artificial intelligence, there are many future technologies which are being developed after machine learning and deep learning, in which the data is being continuously being fed into the machine learning and deep learning devices, and it is going to help us in improving our diagnosis, early diagnosis of oral cancer. So various smartphone-based probe imaging systems are being developed, which are combining all the risk factors. You have to feed in the risk factors associated with the patient, age, sex of the patient, habits of the patient, all those risk factors if you feed in, and it is going to provide you a triage guidance for the oral mucosa screening. And the algorithm is being designed in such a manner that it is going to help you to pair the patients who are coming to you into suspicious and not suspicious. That is what we want in early diagnosis. Patients who are in the suspicious category or in the not suspicious category. Basically high risk and low risk category with a high sensitivity, specificity and positive predictive value ranging from 81 to 95%, which is a good range. So in a study done by Wang et al., a partial least square and artificial neural network classification algorithm has been tested and utilized to discriminate the autofluorescence spectra of pre-malignant and malignant tissue arising from dysplasia and oral squamous cell carcinoma lines, and results have shown that a sensitivity of 81%, specificity, high specificity of 96%, and positive predictive value of 88% has been observed. And a lot of work is going on around the world. Now, there are lab-on-a-chip devices also which are available. These are unique micro-electromechanical systems which can be used to detect the protein and ribonucleic acid biomarkers, similar kind of biomarkers that I discussed just before these slides. And it applies a simple principle of microfluidics engineering. So, microfluidics engineering combined with the biotechnological advances, integrating all the aspects of range of lab procedures such as specimen preparation, separation of the saliva, serum, blood, or urine, signal amplification, and signal detection on a single chip in an automated manner. So we can take a sample of the patient. It can be a saliva, it can be blood, it can be urine. The biomarkers can be anything ranging from peptides, DNA, RNA, or proteins. And there are already molecular implanted polymers, C-allotrope, nanomaterials, antibodies, which are already incorporated within the chip. And it is going to utilize the principle of electrochemical, mass-based or optical phenomena, amplify the signal, process the signal, and give you a final result immediately. So the advantages of these lab-on-a-chip devices is that there is no specialized laboratory personnel which is required for analysis, and the analysis is quite objective. So it can be used on a large scale screening methodologies on a large number of patients. A wide range of molecular diagnostics, biochemical techniques, and immunoassays have been applied using these platforms, such as nucleic acid assays, protein assays, and cell sorting. The advantages also include reduced reagent consumption, decreasing the use of hazardous material and exposure to infectious agent, and also minimize the risk of specimen contamination. There is minimal handling of the specimen by the operator. These devices also increase the reproducibility and consistencies because the process is automated. It is not dependent on a person. So the results are also very reproducible and consistent, and because you can use it on a large scale, the cost is also relatively low. So all these tests which I have discussed today are all slowly coming into the clinical practice. So they're all becoming a part of translational research. So all these tests, when we were students, were all part of the in vitro laboratory setups. But luckily, as the era is advancing very fast, so we have these tests which are available to us in the clinical setup. Some are in the clinical trial stages and some are already out in the market. So the era of translational research has already come up, and there are many labs which are offering whole genome sequencing, all these kind of mutations which the patient can opt for before the cancer has already developed. So with this, I would like to conclude my presentation by saying that we are lucky that we are in an era in which we are seeing all the research and development in the field of oral cancer diagnostics. And we are already using some of these diagnostic methods in our clinical practice. Some are commercially already available, and some may be available within a span of few years. And there's a great effort which is being done by researchers around the world to optimize the clinical performance of these diagnostic methods, targeting the oral cancer at the OPMT stage so that they can be diagnosed at an early stage, so that we can give our patients a better life after the treatment. So I would like to thank the principal and dean of our college, Dr. Sunanda Roy Chaudhary and Dr. Sukant Sahu, and the faculty of my department who have helped me in conducting this presentation. Thank you so much again to the organizers, Dr. Nurul, for giving me this opportunity and helping me to share my ideas with such a lovely audience. Thank you so much. Any questions? If they are there, I'm happy to answer.
Any questions from any audience? If they want to ask any question related to detection of OPMD and oral cancer. Good comprehensive presentation, Dr. Juneja, and you will stay with us. Maybe if there is any question is coming from audience, we'll get back to you.
Thank you.
And we are having apology that we are lagging say half an hour, and we have in another half an hour we have start our paper presentation competition. So I would request all speakers as well that they would be ask question to the students basically who is doing PGs etc. So another 1.5 hour the PGs would join. We'll start with the Should we move to the next speaker, Dr. Juneja?
Sure, sir. Thank you so much, sir.
Yeah, thanks a lot for giving your precious time and joining us.
Thank you, sir. Thank you. My pleasure.
Yeah. So, Dr. Altaf, are you there? Could you just unmute and then we'll, yeah.
Yes. Good morning and assalamu alaikum.
Wa alaikum assalam and very good morning. Dr. Altaf, he is Associate Professor, Oral and Maxillofacial Surgery, Government Dental College, Srinagar. He is Fellow in International Board of Oral and Maxillofacial Surgery, Fellow International College of Dentists. He is a Diplomat of Association of Oral Implantology. He has more than 97 publications, and he is also fellow of AOCF, CMF. So with this note, I'm inviting Dr. Altaf to throw light of his presentation. His slide is yet to visible. Yes, yeah.
So is it visible?
Yeah, it's visible. Anti-resorptive osteonecrosis on jaws as complication of underlying malignancy. Yes, you can start your presentation.
Thank you, sir. Thank you very much, and good morning to one and all. We know the oral cancer is one of the leading causes of death in this part of the world, in Asian countries, and all the world. And as regards, most of us are here oral specialists. Like, we come across situations wherein the patients having systemic malignancies or oral malignancies or on anti-resorptive therapy to prevent osteonecrosis of the jaw. Situation.
There might be some internet connectivity issue for Dr. Altaf, and I think he's exited, and I think he's trying to re-enter into the Zoom. So sorry for the inconvenience. Wait for a while. As soon as he joins, he will start his presentation. Organizing committee member, could you check, please, that if Dr. Altaf can join? Otherwise, we'll start our paper presentation competition. So could you please check once that whether Dr. Altaf is joining again or not?
Please start paper presentation, if possible. Dr. Soumya is in the meeting room.
Okay, just wait.
Yes, sir, I'm here. Can you hear me, sir?
Yeah, you are audible.
Okay.
Before we start our paper presentation competition, let me introduce, and we have the privilege that we have very, very senior academician with us. He is also the judge of this papers presentation competition. There is two more judges who are supposed to join, but we are very close to Holi celebration, and there are people are traveling, so there is some connectivity issue. But we are privileged that we have Dr. Gopa Kumar R. Nair is with us. Dr. Gopa, could you please unmute, say hi, so that we can give you a formal introduction, and then we'll start the paper presentation. As a,
Hello, good afternoon, all of you. I'm available for your session now.
Yeah.
I think Dr. Altaf is not getting the connectivity. So if you're proceeding with the paper presentations from the postgraduates, I'm listening to it.
Okay. We'll start. We'll start. I think first there is some faculties, and then the PGs will join.
Fine.
So
No problem.
yeah. So I'm just giving you as a moderator's responsibility. I'm just introducing Dr. Gopa Kumar R. Nair. Till 2022, he worked as a professor and head of the Department of Oral Medicine and Radiology at KD Dental College and Hospital, Mathura, Uttar Pradesh, India. A native of Trivandrum city from Kerala state, he has a long career in Mangalore, where he finished his graduation BDS way back in 1990, and later postgraduate from MDS in Oral Medicine and Radiology in year 1993, both from Mangalore University. A proud alumnus of prestigious A.B. Shetty Memorial Institute of Dental Science in Mangalore, where he spent the first 15 years of his career in academics as well as teaching faculty there. His career as an active academician spans over 36 years. He has adorned the post of principal and dean at Mahatma Gandhi Dental College, Jaipur, Rajasthan, and also Maha Institute of Dental Science, Pondicherry State. He has also worked as a postgraduate guide and headed the Department of New Horizon Dental College, Chhattisgarh State, before joining Mathura 10 years back. He has been a life member of Indian Academy of Oral Medicine and Radiology since 1993. He is much sought after speakers in various dental conferences and platforms, and has won many best paper presentation awards. He has trained in CT-MRI and video fluoroscopy for Zurich University, Switzerland. He has also been a fellowship in dental implantology from University of Genoa, Italy. He trained in CBCT, and he served as the president of Indian Academy of Oral Medicine and Radiology too in year 2016, 10 years back. Till date, he has organized and have been with the advisor of many national level conference in IAOMR in both PG and UG level. His education, his editorial skills were applauded by all during his tenure as editor of chief of the Journal of Indian Academy of Oral Medicine and Radiology in years from 2006 to 8. He has 26 years of postgraduate teaching experience. He is FDI Dubai and Kuala Lumpur, Malaysia, and last year conducted a hands-on workshop on CVCT and delivered a lecture in TDE 2025, being of the Board of Studies External Examination in various universities, and a number of curriculum revision committees in Rajiv Gandhi University and Dental Council in India. He is also having good auditory skill, a pleasing persona with down-to-earth attitude, and Doctor is a senior professional in oral medicine and radiology, and in India to reckon with. If I would have missed anything, Dr. Gopa Kumar, you can add on, and you are our distinguished judge for this, faculties and PG's paper presentation. So you supposed to mark them from 0 to 10 scale of marks, and you can share on the later part of this conference. So over to you, Dr. Gopa Kumar and Dr. Soumya. Your slides
Good
are
afternoon.
visible. You can start your
Soumya
presentation.
for her title of the topic, Deep Learning Driven Detection of Basilar Hyperplasia in histopathological images of early malignant changes in oral submucous fibrosis. It's an interesting topic because now AI and machine learning are used in diagnostics, both in imaging and in histopathology. So I'm sure she'll be throwing some light onto this innovative aspect in oral and maxillofacial pathology. Over to you, Dr. Soumya. You can start your presentation.
Good afternoon, sir. Thank you for the sharing this session. I would like to share my research topic. This is basically on deep learning-driven detection of basilar hyperplasia and histopathological images for early malignant changes in oral submucous fibrosis. I think the slide is stuck. Just
go to the presentation mode.
Yes.
Right.
Yes. So these are my contents. To give a brief introduction to the topic, oral submucous fibrosis is a chronic progressive condition affecting the oral cavity characterized by fibrous tissue accumulation leading to stiffness and restricted mouth opening and tongue movement. The prevalence of oral submucous fibrosis is 0.03 to 6.4%. And transformation rate of around 3 to 10%. So what happens in case of routine histopathology? We try to miss out certain changes. So there are some early malignant changes which could be set in the oral submucous fibrosis, such as basilar hyperplasia, altered nuclear cytoplasmic ratio, nuclear hypochromatism, etc. Now, these changes in the routine histopathologic evaluation is difficult to identify because of significant morphological variability across the tissue samples, differences in the epithelial thickness, and variations in staining quality and tissue orientation. And this can lead to diagnostic subjectivity and limit the reproducibility of manual assessment even among experienced pathologists. Therefore, we would like to explore an objective method which is using deep learning models which can identify these subtle changes in the epithelium. And in this particular study, we have studied only the basal cell hyperplasia. Now, what is this basal cell hyperplasia? It is excessive thickening and enlargement of the basal cell layer within the oral epithelium. So the aim of this particular study was to develop and evaluate a robust deep learning-based framework for automated segmentation of basilar hyperplasia in OSMF histopathology images. The objectives were to develop a curated histopathologic image data set of OSMF with expert validated pixel-level annotation specifically targeting basilar hyperplasia. To implement and comparatively evaluate 3 deep learning architectures, that is UNIT, UNIT double plus, RES UNIT, for the accurate and targeted segmentation of oral epithelium in OSMF images. To design and integrate a morphological post-processing pipeline to refine the raw segmentation outputs. And finally, to explore the potential of automated epithelial segmentation in supporting early detection and improving the diagnostic consistency in OSMF through computational methods. So this is the workflow which we followed. First of all, the images, histopathological images were captured using a research microscope which is attached to a CCD camera and a computer system. So 100 such images were captured wherein we could identify basilar hyperplasia. And then the images were subjected to pre-processing, semantic segmentation, post-processing, followed by quantitative analysis. So the first step was image annotation. Regions exhibiting basilar hyperplasia, as you can see in this image, this is the basilar hyperplasia region which has been annotated using the Label Me annotation tool through polygon-based region marking generated JSON files, that is JavaScript object notation files. Now, the extended polygon coordinates were subsequently used to generate binary ground truth masks. So with this, we got these ground truth masks, which had only 2 components. That is, 0 means is the background and 1 determines the basilar hyperplasia. So this is how the annotated images looked once they were annotated. So we took 100 images. The image dimensions were 3840 into 2160 pixels. And the ratio of the training versus validation to the test data set samples was 60:20:20. And this is how the final images looked. Following this, we did a tile-based image decomposition and standardization process. Processing high-resolution histopathological images directly within the deep learning frameworks is computationally demanding and can adversely affect batch size, GPU memory utilization, and training stability. To overcome these challenges, a tile-based patch extraction strategy was adopted in which each image was decomposed into smaller, uniformly sized patches suitable for semantic segmentation. As you can see, this entire image has been segmented into 135 images because each of the segment contributed to 256 into 256 pixels. And the same thing was applied for both the RGB image as well as the ground truth image. Now, this was mainly done to ensure exact spatial correspondence between the input images and their annotation patches. And then the image post-processing was performed to segmentation refining. So this was employed mainly to refine the raw segmentation outputs and obtain anatomically coherent basilar hyperplasia regions from the predicted binary masks. The pipeline integrates full image morphological operations and connected component analysis to correct fragmentation, suppress noise, and enforce structural consistency in the final segmentation outputs. So this is how in the CNN model, these are the changes that the image will undergo so that you get a segmented image. So coming on to the results. So this is the performance accuracy and the loss that is visible between the between the three different segmentation models that were used. The same has been depicted here. So you can see the curves, the accuracy and the loss that has been found. And we found maximum accuracy in using these segmentation models as compared to the loss. So we analyze the performance using quantitative and qualitative analysis. So the quantitative performance of the segmentation models, that is UNet, UNet double plus, ResNet, were assessed using the dissimilarity coefficient and Jacob index, computed on a per image basis for both raw prediction and post-processed outputs. And the results are summarized in this table where you can see the mean and the standard deviation to capture both average accuracy and inter-image variability. Across all the architectures, post-processing consistency resulted in improved segmentation performance, and these gains indicate enhanced spatial overlap between predicted and ground truth regions, reflecting improved boundary coherence and reduced fragmentation following morphological refinement. So, refinement pipeline not only improves the segmentation accuracy but also reduces the inter-image variability, yielding more stable and reliable predictions across the heterogeneous histopathological images. Now, the same data has been depicted using the graphical representation. So moving on to the qualitative segmentation or analysis. So qualitative segmentation are mainly provided to visually assess the boundary discontinuity. As you can see, these pre-processed images, there are a lot of discontinuities in the image, which has been overcome using the post-processing techniques. So in the raw prediction, all the three architectures exhibited varying degrees of boundary fragmentation, small isolated false positive regions, and discontinuities along the basal cell layer. Following the application of proposed morphological post-processing pipeline, segmentation masks became noticeably more coherent and anatomically consistent. The refined continuity along the epithelial boundaries, substantial reduction of scattered noise and isolated regions, and smoother contours that more closely align with the expert annotated ground truth. So this is how the post-processed images looked. The same thing was seen even in the UNet double plus as well as the RES unit. So to conclude, the present study explores basilar hyperplasia as a histopathological parameter of interest and applies an AI-based segmentation framework to objectively delineate and analyze basal epithelial alterations in the OSMF tissues. Basilar hyperplasia therefore represents a key morphological manifestation of this altered epithelial kinetics and can serve as an early indicator of malignant potential. And we found that these three CNN segmentation models were beneficial in identifying and segmenting the basal cell hyperplasia. And these observations reinforce the notion that architectural feature representation and morphological refinement act as complementary components in achieving robust segmentation of subtle epithelial abnormalities. So mainly through this research, we have tried to develop a newer data set of histopathology images featuring basilar hyperplasia as an indicator, which was meticulously annotated under the supervision of pathologists. And we also developed and evaluated deep learning models for OSMF detection, which provided insights into their decision-making processes. And automated post-processing was done to enhance the deep learning models based segmentation outcome. So these were my references. Thank you.
Well,
Thanks.
thank you, Dr. Soumya, for a good presentation.
Yes, sir.
Do we take questions from the audience? Do we have provision for questions from the audience?
Yeah. The audience can ask question, but the evaluation is done by the judge only. Yes.
That's okay. But if there are any questions, the audience can type it or they can ask it immediately. We'll give
Sure.
2 minutes for that. Well, if there are no questions from the audience, I will congratulate Dr. Soumya for her excellent presentation.
Thank you,
Only
sir.
thing is, it's a very, nowadays with AI and deep learning in computers, machine
Yes.
learning is actually going to be a very useful tool, especially when there is a lot of subjectivity when we
Correct.
look at histopathology. Now,
Mhm.
oral submucous fibrosis, somehow we understand that it's an atrophy, epithelial
Yes.
atrophy. So that's why we get so-called a very flat basilar membrane,
Correct.
wherein there is no hyperplasia at all. There is no plasia. That's why there is atrophy.
Correct.
Now, in such a condition, as we know that epidemiologically, oral submucous fibrosis has very less chances when compared to the other oral potential malignant disorders in malignant conversion. That has been how it has been. The problem in oral submucous fibrosis is the representative sample. Now, it's a generalized condition. Now, you give a sample to the computer, the photomicrograph, and if it's not representative of that particular area, which is actually showing the changes towards malignancy, it becomes a little difficult issue for us to use any method. Even our human eyes are good enough to identify these things, but then it becomes a problem. Maybe, vital screen dyes or your toluene blue or etc. can actually make, or even a Visilite system, they can identify the clinical parameter of where to biopsy it and then go in for the histopathological section. That is fine. The only issue is the fundamental of oral submucous fibrosis is atrophy, whereas basilar hyperplasia is something which ranges from simple leukoplakia to verrucous carcinoma. So basilar hyperplasia, if it is seen in submucous fibrosis, very unlikely that it will be seen in submucous fibrosis, going by the fundamentals of oral submucous fibrosis. If at all changes have to be seen, we need to actually look at the other epithelial dysplasia parameters like cell alterations, nuclear cytoplasmic ratio, etc. If you can develop this model into that as the next step, I feel that will be more conclusive than just looking for a hyperplasia. Because hyperplasia, if it's there, you will look it under the microscope by yourself, if the representative sample is there. One good thing about this study is that any lesion which undergoes basilar hyperplasia, you can use this. Not only submucous fibrosis, an area where there is no discernible lesion in the mouth, if you suspect that there is epithelial dysplasia or hyperplasia to begin with, you can use this machine tool as a beginning, and it's a wonderful thing that you have done. So you have got that. Now you will have to refine it. I'm sure you'll have to refine it for applying this not only to oral submucous fibrosis, but to all discernible oral potential malignant disorders. And the next step would be to identify cytological changes individually. If there is individual cell keratinization, or if there is loss of adhesion between cells, there is size changes, or the so-called cellular, the so-called 11 or 12 criteria what we look for under histopathology. That has been always subjective. So that subjectivity, as you said correctly, It can be reduced by using a computer. And some things which we miss out, the computer will point it out to us if it is allowed to learn. Thank you, Doctor. It was a very good question. Where do you work, Doctor?
I would like to clarify, sir. So actually, when we see these changes, submucosal changes as fibrosis and epithelial atrophy in the advanced oral submucous fibrosis, as you rightly said. So what happens is, because of the decreased vascularity, and there will be some kind of epithelial changes which will lead to malignant transformation. And some of these early changes, what we have noted, we have come across many cases of oral submucous fibrosis which has transformed into oral cancer. And when we looked at those archival slides, we found that there were some changes, as you said, like nuclear cytoplasmic ratio, nuclear hyperchromatism, basal cell hyperplasia, all these were noted. So that is why we started evaluating this. As you said, in our future studies, we are looking at the other parameters as well. So as an initial step, we have taken this basilar hyperplasia, which can be seen in the cases where OSMF has transformed to OSCC. We have seen such changes. That is why we have taken this as one of the parameter for assessment, sir. Yeah.
Thanks, Dr. Somi.
Thank you, sir.
So with the permission of Dr. Gopa, we are moving to our next participant, Dr. Jigar Dhuwad. Dr. Jigar, are you there? Could you unmute and share your slide?
Yes, sir.
You just give your brief introduction of 20 seconds and then you can start your presentation. We have 10 minutes for all faculty. So try to conclude your sessions in 8 minutes so that we have 2 minutes of question and answer.
Yes, sir.
Slides are visible, Dr. Dhuwad.
Sir, yeah, just I would like to confirm that is the screen is visible?
Yeah,
And
it's visible
audible?
and it's in a presentation mode. So it's visible. You are audible. You can continue.
Yeah, thank you very much, sir. Good afternoon, respected chairpersons, distinguished speakers, and esteemed colleagues across the globe. First and foremost, I would like to sincerely thanks to International Oral Cancer Congress for this wonderful initiative and for the organizing a beautiful structured 4-day virtual academic program. Since morning, just I am observing all the presentations, and they were the multidisciplinary in the nature for the oral oncology. It is indeed an honor to be a part of the STEM platform. Yeah, myself, Dr. Jigar Dhuwad, Assistant Professor in Oral and Maxillofacial Surgery at the Government Dental College and Hospital, Ahmedabad, India. Today, I will be speaking on the artificial intelligence in the early detection and risk prediction of the oral cancer from the smartphone imaging to the survival model. Oral cancer remains the 6th most common cancer worldwide. Nearly 90% are the oral squamous cell carcinomas. 5-year survival remains the approximately 50 to 60%, and the more than 60% of these patients are diagnosed with the advanced stages. Why the early detection fails? The main reason is the central challenge is not the surgical capability. It is always a diagnostic delay. If early stage detections were consistent, survival outcomes would change dramatically. Screening depends upon the visual examination and the clinical experience. However, I would like to say that the inter-observer variability remains the higher, and how much the tissue has been taken in the biopsy and who has taken the biopsy, that remains always a subjective. So there is not a standardized data-driven risk screening model is available. Now coming to the AI versus the clinical accuracy. Systematic reviews have already shown in the Journal of 2023 by the EDOI and in the Lancet Digital Health in 2022 has published the 2 reviews, and in that they have mentioned that the deep learning models achieving the sensitivities between the 85 to 94%. In the image-based diagnosis, AI performs comparably to the specialist and often exceeds the general practitioner performance. However, the most data remains the retrospective. Defining that, what is the AI in the oral oncology? Artificial intelligence includes the machine learning, convolutional neural networks, radiometrics analytics, survival modeling, and the federal learning. At its core, AI enables the high-dimensional pattern recognition beyond the human perception. The same things has been mentioned here in this diagram, how the AI works in the oral cancer. Smart mode integrated AI enables the image capture, cloud-based analysis, risk scoring, and the referral guidance. This is a scalable and potentially transformative for the underserved population, mainly. After taking an image from the screenshot for the diagnosis and for the risk of the oral cancer, how it is the lower risk or moderate risk and the high risk that can be predicted by the AI. Models such as the ResNet, Inceptions, MobileNet, and the EfficientNet detects the vascular and the textural features invisible to the naked eye, which the AI can solve the problems. The clinical photographs, once captured using the smartphone data, has been processed and the feature extraction is done using the AI, and which helps in the risk probability scoring from the low grade to the high grade. The applications of the AI, mainly the leukoplakia grading, dysplasia prediction, OS of staging, and the malignant transformation risk estimations are there. Whole slide imaging with the deep learning enables the automated dysplasia grading, quantify the nuclear atypia, identify the mitotic activity, and predict the tumor grade, whether it is benign or the malignant. Similarly, the radiomimics extracts the quantitative imaging features which are taken from the CT scan, MRI, and the PET-CT, which helps in the tumor aggressiveness, lymph node metastasis prediction, and the margin involvement. After taking an image from the CT, MRI, and the PET scan, with the help of quantitative images, help to detect the tumor burden and the nodal risk. Thus, these models predict the lymph node metastasis, tumor aggressiveness, and the margin status, refining the surgical planning and adjuvant lesions. Now, coming to the survival modeling versus the beyond, which is beyond the traditional methods. That is, currently survival rates are closely linked to the accurate diagnosis, with the prognosis largely determined by the TNM staging and histological findings. Treatment decisions and the outcome depends on the routing these clinical parameters, while in the artificial intelligence enhances the prognostic precision by integrating the radiomimics, genomics, and the immune biomarkers, as well as the clinical data. Deep survival networks, in particular, demonstrate the superior predictive coordinates compared with the traditional regression models. Artificial intelligence enhances the prognostic decisions by integrating the radiomimics, genomics, immune biomarkers, and the clinical data into the unified predictive models. Deep survival networks outperform the traditional regression methods by capturing the complex nonlinear relationships, enabling the accurate risk satisfaction, personalized treatment planning, dynamic learning from the new data, and the improved reliability in the survival prediction. Now, when should the AI should be used? Community screening, mainly in the rural area, where the high-risk population is there, diagnostic area where the borderline dysplasia, suspicious stages of bruxism, and potentially malignant disorders. The classical machine using the should not predict the potential to improve cancer screening, treatment planning, and similarly, the other has in 2021 well, so
I think he's lost connectivity.
Yes, we'll request to the next participant, I think, because we have back-to-back 20 participants. So we are also
That is
lagging.
including the postgraduates.
Come again, sir?
Is that 20 including the postgraduates?
No, 10 is a faculty and 10 is a PG.
So together.
Yeah.
Fine. If Dr. Jigar can join us back, well and good. Just try to call him and find out, sir.
I'm calling Dr. Hajira Khatun. Dr. Hajira, you are there in the meeting room. Could you please unmute yourself, give your brief introduction, and share your slide? We have
Yes, sir. Very
8
good
minutes.
afternoon.
Yeah, we have 8 minutes for you, and 2 minutes we are keeping at the end for the Q&A session.
Yes, sir.
Yeah. So give your brief 20-second introduction, and then you can share your slide. Yes, your slides are visible.
Yeah, one second. Can you see my screen, sir?
Yeah, your screen is visible.
A very good afternoon to the judges and my dear colleagues and participants. I am Dr. Hajira Khatun, Assistant Professor from Faculty of Dental Sciences, Ramaya University of Applied Sciences. My presentation topic for today is transcriptomic profiling of verrucous carcinoma and its transformation into oral squamous cell carcinoma. It is a comparative RNA sequencing study. So as we know, verrucous carcinoma is a well-differentiated variant of oral squamous cell carcinoma, and it is characterized by slow growth, local invasiveness, and minimal metastatic potential. But there is a 20% transformation risk of VC into conventional OSCC, which makes it more aggressive and has a poorer prognosis. Now, differentiating these stable verrucous carcinoma lesions from the ones which have transformed into OSCC is a bit challenging, especially because we may sometimes miss out getting the representative tissue from the biopsy, and even the conventional histopathology, sometimes we fail to detect the early changes which are associated with transformation. And hence we try to explore a newer area in this case, where we could characterize some biomarkers and see if we can predict these changes earlier before even the transition is even visible in the histopathology. And when we tried to search, we found that the existing literature has a lack of highlights a lack of reliable biomarkers or molecular predictors for this transmission. In this context, we tried to explore and we did this study. And this brings me to the aim of my study. It is to identify differentially expressed genes associated with the transformation of verrucous carcinoma into oral squamous cell carcinoma using RNA sequencing. Now, my objectives follows the same. It is to identify the differentially expressed genes and the associated pathways involved in VC and the transformation of VC to OSCC cases, and to characterize these genes which are uniquely implicated in the pathogenesis. Coming to the methodology, it is a comparative observational study. So we had 4 balanced arms in our study. The group 1 is normal oral mucosa. Group 2 is verrucous carcinoma cases. Group 3 is VC cases which have transformed into OSCCs. And group 4 is de novo OSCC or the conventional OSCC cases. Now we collected 2 fresh tissue samples for each of the groups and immediately transformed them into RNA later. And we stored these tissue samples in -80 degrees Celsius until we went ahead for RNA extraction. The next step is RNA extraction, where we isolated the RNA from the fresh tissue samples using trizol and the DNase purification kit method. Now, this RNA was subjected to quality and integrity assessment. Now, the quantity of the RNA was checked using nanodrop and the qubit. Now, we got a very high yield of RNA, that is about 3000 for all of the samples, whereas only 1000 nanogram of the yield is more than sufficient to go ahead with the RNA studies. Next, we checked the integrity of the RNA using our Agilent RNA tape station. So we got RIN numbers, that is RNA integrity numbers, above 8 for all the 4 samples, whereas getting just above 7 was more than sufficient to go ahead with the RNA sequencing study. Now, since the RNA quality and quantity was sufficient, we went ahead and we did sequencing, that is the transcriptomic sequencing of this RNA was completed on the Illumina platform, and the transcripts which we obtained on sequencing this, they were aligned to the human reference genome, and we got very good alignment. I'll show you the results in the next section. Next, these transcripts were sent under feature counts tool software, which was used to estimate and calculate the transcript abundance. Here, transcript means the gene. So we estimated how much of each gene was present and how much quantity was it present. Next, these genes were subjected to DESEQ software, which calculated the differentially expressed transcripts between the groups. That is to show whether any gene is upregulated in one or downregulated in the groups. So in between groups, the assessment was done. Finally, we did the pathway analysis using the CAS server. So this is the results we obtained. All the results were exceptionally good. So we got around 28.5 million copies of the genes, and more than 98% of these had a Q30, more than Q30 score. So that means that the genes we obtained were of the good quality and were all belonging to the human genome. Now, almost over 97% of these transcripts were aligning with the human reference genome. So since we were satisfied with these, we went ahead and we did comparative analysis between the groups. So we found two genes, one which was upregulated and one which was downregulated between the VC group, that is the pure verrucous carcinoma group, and the one group which was VC and which was transforming into OSCC cases. So we got link 02582 gene which was upregulated, and FLG2, that is the filaggrin 2 gene, which was downregulated. Now what we did further was we tried to characterize what this link and FLG2 actually does. So we did the functional annotation, and we found out that the link gene is actually a long non-coding RNA. So it does not directly code for a protein, but it regulates the expression of these proteins. So in VC, what happens is it regulates the neighboring and the distal genes through chromatin remodeling. It has a role in transcriptional regulation and also in epigenetic regulation. Coming to the FLG2 gene, it is for epithelial differentiation and for the barrier decision of the tumor. So what we concluded was that the molecular changes will obviously precede clinical aggressiveness in verrucous carcinoma to OSCC transformation. So the gene, that is the upregulated link gene, correlates with early oncogenetic activation, and it has a role in epithelial to mesenchymal transition. And the downregulated FLG2 reflects that there is loss of epithelial differentiation and keratin integrity. Now these alterations will parallel the histologic dedifferentiation and invasion. So combining these markers with the histological examination will not only aid in early detection of the transformation, but also will help us in stratification of transforming this VC to OSCC lesions. So in our regular practice, if we do IHC for this, which will help us greatly in doing the risk stratification of these cases along with the biopsy or the regular HND reporting. So I would like to conclude that while histology identifies transformation when the invasion is evident, but identifying alterations with like link and FLG2, which may show loss of signal transformation at a pre-invasive molecular stage. So this will help the patient. This will help us treat the patient before he can undergo great radical treatment, and a simple treatment will help, like just excision at a verrucous carcinoma level. So this was my presentation, and these are my references. I thank you. I thank the judges and the organizing committee for giving me this opportunity.
Thank you, Dr. Hajira, for a good presentation. Both the gene upregulation and the one which is expressing during the molecular changes where there is invasion in verrucous carcinoma. The concept is good.
Yes.
What is the epidemiological data of verrucous carcinoma per se going into oral or frag invasive carcinoma?
So there was one article which said that there's 20% transformation rate of VC transforming into OSCC, sir.
Yeah. So when verrucous carcinoma itself is there,
yes, sir.
How is the regulation of these two genes? Have you checked it? Now we have got LINCO2582 and FLG expression you have done.
Yes, sir. Yes, sir.
Are these expressed otherwise in verrucous carcinoma? Have you done a baseline study on that?
Yes. We have done a baseline study. First, we characterized the genes separately for VC and then separately for this. And we found that these genes are present both in VC and in OSCC, but the expressivity increases as it goes towards OSCC, and the expressivity of G2 decreases.
And that is understandable. What I'm asking is, in oral frank carcinoma, oral squamous cell carcinoma, how is the expression of these?
We did that also. So that's why we had 4 groups. The first group was normal oral mucosa, and the
So
last
you
group was
found
OSCC.
that there is a progressive expressivity
increase.
change in these two. One is down regulated.
Yes. The same thing was applied for conventional OSCC, but the amount is even more greater there. The fold change was even more greater.
But immunohistochemistry to an extent helps us actually to avoid. This will be a very expensive study, I'm sure.
Yes, so this is our grant study.
Yeah, so you got a grant, that's why you could do this.
Yes, sir,
and if it is to be practically or clinically applied, how expensive it will be for us?
So it will be the same cost as doing any IHC, but the marker cost might be slightly, maybe say 500 rupees greater per case if we see like that. So it's so once it comes into practice, it will be feasible.
Fine, doctor. Thank you. And see, molecular biomarkers are, of course, going to be the final dictum in identifying progress and metastasis of cancers, for sure. Unfortunately, the polygenetic origin and much amount of epigenetics involved in oral cancer per se is the only deterrent for us to yet to get into a very authentic single test as of now.
Yes, that's true. So
the biomarkers, polygenic. Yeah. So maybe, we started from P53. We had so many of those epigenetic markers. We had epithelial studies wherein keratin binding, etc., was looked upon as promising markers, but none of them, unfortunately, in oral squamous cell carcinoma, has got a single individual identity. There are some of the lesions where there are markers. Now, prostate cancer, you have a marker. You have lung cancers, there are markers. But unfortunately, oral cancer, even today, we do not have. So this is a good step that you have taken in RNA sequencing as a study for at least identifying progress of a basal cell.
Correct.
I think I'm getting a call. 1 minute.
Yes.
Okay, Dr. Hajra, maybe Dr. Gopa get a call actually. So he rejoin again. It's a good presentation of yours, and we are moving to the next presenter, Dr. Swapna Amod. Yeah, Dr.
Yes,
Swapna.
sir.
Yeah, you are.
Shall I share my screen, sir?
Yeah, you can share your screen, but wait for a while. Let Dr. Gopa Kumar join again, and then you can start your presentation.
But shall I share the screen till the time?
You can share your screen. Dr. Swapna will wait for another 1 or 2 minutes. If anyhow Dr. Gopa is not able to get connectivity or join, you can continue your presentation and we'll share the recording to Dr. Gopa for evaluation, etc. So no worry.
Shall I wait, sir? Can you give me some time?
Yeah, he's joining again. Just no worry. He's joining.
I think I can wait, sir. My screen is visible because I can't see
Your
it
screen
right.
is very much visible. Yes, it's
But
visible.
I'm not able to see.
Sorry, I had gone out of it. So thank you. I think I could join back. Welcome, Dr. Swapna Patankar.
Yes, sir. Good
Ma'am,
afternoon,
you can
sir.
share your slides.
Yes, I'll share it, sir.
Yeah.
Yeah, your slides are visible, Dr. Swapna. Give your 20-second brief introduction and you can start your
Right.
presentation. We have 8 minutes and then 2 minutes for questions. Yeah.
Yes, sir. Very good afternoon. I'm Dr. Swapna Amod Patanka, Assistant Professor in the Department of Oral and Maxillofacial Pathology and Oral Microbiology at Bharati Vidyapeeth, deemed to be University, Dental College and Hospital, Pune, Maharashtra, India. Based on the theme of the World Cancer Day, celebrated on February 4th, 2026, United by Unique, this aptly applies to my today's topic of discussion, tumor microenvironment and head and neck squamous cell carcinomas. I will be covering my presentation under the following headings. According to National Cancer Institute, tumor microenvironment is defined as normal cells, molecules, and blood vessels that surround and feed the tumor cells. The tumors can influence the microenvironment by releasing extracellular signals, promoting tumor angiogenesis, and inducing peripheral immune tolerance, while the immune cells themselves in the microenvironment can affect the growth and evolution of cancer cells. With recent advancements in detection and treatment, the overall outlook towards cancer has changed dramatically. The tumor is no longer viewed as a bulk of malignant cells, but rather a complex tumor microenvironment in which we have the subpopulation of cells corrupted by the cancer cells, and together they exist as a self-sufficient biological structure. So these stromal cells are the cancer-associated fibroblasts, macrophages, neutrophils, regulatory T cells, myeloid-derived suppressor cells, natural killer cells, platelets, and mast cells. Let's see their functions. Cancer-associated fibroblasts. They lead to cancer invasion by causing matrix remodeling. They interfere with the T cell function, thus affecting the immune response. They promote the tumor growth by having metabolic effects. At the same time, they will lead to macrophage and endothelial crosstalks, which will further promote to the growth of the tumor. As tumor-associated macrophages, these lead to tumor metastasis, they lead to tumor migration and invasion, they cause inactivation of the T cells, thus affecting the immune response, they lead to angiogenesis, and they promote the tumor growth. The tumor-associated neutrophils, their role in cancer progression is still unclear, but research is going on. They are of two types. Type 1, that is N1 anti-tumor, and N2, that is pro-tumor. Now, these pro-tumor lead to tumor growth, angiogenesis, invasion, metastasis, and immune suppression in cancer. Regulatory T cells, according to Vignali et al., they have four modes of action: by suppression of the inhibitory cytokines, suppression of cytolysis, suppression of effector T cells, and suppression of dendritic maturation and function. Myeloid-derived suppressor cells, they suppress activity of the T cells in cancer. They are also linked to processes such as promotion of tumor angiogenesis, degradation of extracellular matrix, and formation of pre-metastatic niches. Platelets, they act via three secretory granules, the dense granules, which have lysosomal associated membrane proteins, lysosomes, which degrade and remodel the extracellular matrix and vasculature, and alpha granules, which stimulate the tumor cell growth and angiogenesis. Tumor-associated mast cells have dual function, tumor and anti-tumor. The pro-tumor actions, they have effect on angiogenesis, they cause extracellular matrix degradation and have direct and indirect immune suppression effect. The natural killer cells, they are subset, that is the invariant natural killer T cells. Their levels are found to be low in the peripheral blood smears of head and neck squamous cell carcinoma patient, indicating poor prognosis. Now let's see the role of extracellular matrix in tumor progression. The proteins of the extracellular matrix, namely the collagen, elastin, fibronectin, laminin, tenascin, they cause cell adhesion, they influence the cell adhesion and proliferation, which leads to cell migration out of and into the tumor microenvironment. They elevate the stiffness of the tumor, they activate the oncogenic intracellular signaling, they inhibit the tumor suppressor gene, and ultimately lead to tumor progression. This is the matrix stiffness caused because of the tumor microenvironment. The fibronectin will further provide binding site and interaction sites for certain molecules such as integrins, fibrins, heparins, and so on. All of them lead to tumor progression, migration, invasion, and reduce responsiveness to the treatment, and thus leading to directional migration of the cancer cells. Now let's see the role of metabolic reprogramming of the tumor microenvironment. In a rapidly growing solid tumor, the intratumoral hypoxia is seen because of insufficient oxygen supply to the tissue. This stimulates the upregulation of pro-angiogenic factors, which lead to formation of new blood vessels. These newly formed blood vessels have high leakage tendency and have irregular structure, which affects their function. And hypoxic microenvironment also has been implicated as a crucial contributor to radio and multi-drug resistance. This also leads to upregulation of hypoxia-inducible factor 1, which will mediate the adaptive cellular response. It also promotes cellular growth, survival, and proliferation of tumor cells. It is also responsible for Weber effect seen in the tumor cells, and all of this promotes the creation of a more advantageous tumor microenvironment, cancer cell proliferation, survival, and invasion. Now let's see the actual role of tumor microenvironment in pathogenesis of head and neck squamous cell carcinoma. They will lead to epithelial mesenchymal transition, invasion into the tumor microenvironment, metastasis through the blood and the lymphatics. It will cause resistance to the anoikis. It will promote angiogenesis. It will evade the immune response. It will create a metastatic niche. It will create a therapeutic resistance and ultimately lead to a sustained proliferation of the tumor cells, leading to the secondary tumors. So, oral potentially malignant disorders, if untreated, can progress to squamous cell carcinoma. Here we can see a mediated direction of growth of the tumor cells into the underlying connective tissue, where the tumor microenvironment will have create a solid stiffness of the tissue. At the same time, all these subcell population, which I have discussed earlier, will create an environment which will promote the growth of the primary tumor, ultimately leading to the epithelial mesenchymal transmission. It will cause intravasation into the blood vessels or the lymphatics, ultimately causing extravasation, micrometastasis, mesenchymal epithelial transition, causing macrometastasis and formation of the secondary tumor. Thus, to summarize, the emerging evidence of fundamental role of the tumor microenvironment in providing a supportive niche, thus promoting development and metastasis of head and neck squamous cell carcinoma. In-depth understanding of the stromal compositions of the tumor microenvironment will definitely aid in better understanding of the mechanisms behind the different responses to therapies and possible targets for the clinical intervention. Thank you. Actually, tumor microenvironment is a very vast topic. In-depth research has been done on every aspect that I have discussed right now. Because of time constraints, I could just touch the iceberg named tumor microenvironment. Thank you.
Thank you, Dr. Swapna Mood. It was a quite an elaborate review on tumor
Thank you, sir.
microenvironment. As you rightly pointed out at the end, it's a very vast ocean because
Yes, sir.
right from the cellular molecular microbiology to the genetics to the various factors of immunity and the factors which include angiogenetic factors,
Yes, sir.
etc., and tumor growth factors and suppressor factors. That's a big interaction of immunity and tumor-associated genes.
Yes, sir.
The microenvironment specifically has a very big role in oral cancer because the oral epithelial microenvironment is very special when compared to other areas.
Yes, sir.
Now,
Definitely.
our kind of epithelium and the connective tissue stroma that we have in the oral mucosa, that promotes, we have a very prominent term in your oral pathology where we say field cancerization.
Yes,
So
sir.
other than de novo and cancer occurring in field cancerization, especially in oral potentially malignant disorders, all these factors do play a vital role, whether
Yes,
it's
sir.
progressing
Definitely.
into cancer or whether it is remaining as a oral potentially malignant lesion. And oral cancer also, how invasive it is or how destructive it is going to be is also going to be related to all these factors parameters.
Yes, sir.
So,
Definitely.
especially we understand that there are certain which undergo only local metastasis. Some of them undergo distant metastasis.
Yes, sir.
So these catharins and other microenvironment molecules do help them
Yes, sir.
in micrometastasis, etc. So it's a very good thing. If a postgraduate is interested in, if they are listening, you should take a clue and then work on one of these factors and then find out how they can help in determining the treatment planning of the patient and also preventing a spread of cancer when it is not yet cancer.
We can
So
also
thank you,
have
Doctor. It was a
targeted
very nice
therapeutic,
presentation.
like targeted therapeutics for
Yes,
cancers.
we have already. We have already.
Yes,
We have
sir.
already. We have, especially
So
in
there is something
immunotherapy.
called as ferroptosis also. I think people are working on this ferroptosis where they can bringing an iron dependent cell. Yes,
binded
for the tumor
protein.
cells. Yes, I think 2 years back, I think Agarkar Institute, they have developed a kind of a drug. I think it is still undergoing trials where they are targeting the tumor cells by ferroptosis.
In fact, that way, even today, other than the conventional surgery and radiotherapy and post-operative chemo, today immunotherapy has got a major role in.
Yes, sir.
And they are
Definitely.
targeted therapies. So
Yes, sir.
targeting a cancer cell by locating it and then identifying the correct protein for binding, that will be a task and a challenge for some more years before we get the wonder medicine for cancer.
Yes, sir. Definitely.
Thank you, madam.
Thank you, sir. Thank you so much, sir.
Thanks, Dr. Swapna, giving your precious time and giving a nice presentation.
Thank you, sir.
Yeah, with your permission, Dr. Gopa and Dr. Swapna, we are moving to our next presenter, Dr. Khadija Mohidan. Dr. Khadija, are you there? Yeah, please share your slides, give your 20-second introduction and try to conclude in 8 minutes so that we would be on time. Yeah, Dr. Khadija, your slides are visible, but not in presentation mode. Could you make it?
Yeah, I will do it. Is it visible, sir?
Yeah, it's a visible and it's a presentation mode also. You are audible. You can continue.
Yeah, thank you. Thank you, doctor. Thank you, sir. Very good afternoon, respected judges and distinct colleagues. I'm Dr. Khadija Mohideen from the Faculty of Dentistry, Najran University, Saudi Arabia. Today, I'll be presenting our study titled Assessment of Immunohistochemical Expression of Lipid Peroxidation Marker 4-hydroxynonenal in Oral Lichen Planus, a retrospective study. Oral lichen planus is a chronic immune-mediated mucocutaneous disorder with a global prevalence of approximately 1 to 4%. It predominantly affects females and is most commonly observed between the 3rd and 6th decades of life. Importantly, oral lichen planus is classified as an oral potentially malignant disorder with reported malignant transformation rates ranging from 0 to 12.5%. The pathogenesis is largely attributed to T-cell mediated cytotoxic response directed against basal keratinocytes, resulting in apoptosis and chronic inflammation. However, exact molecular mechanism contributing to disease progression and malignant transformation remain incompletely understood. Emerging evidence indicates that oxidative stress plays a significant role in autoimmune and inflammatory disorders. Mechanistically, chronic inflammatory infiltrate in oral lichen planus generates reactive oxygen species during respiratory burst. The accumulation of reactive oxygen species results in oxidative stress during chronic inflammation, which can induce DNA damage, protein oxidation, and lipid peroxidation. Lipid peroxidation of polyunsaturated fatty acid generates reactive aldehydes, among which 4-hydroxynonenal is considered one of the most biologically active and cytotoxic end products. 4-hydroxynonenal is electrophilic, forms adducts with DNA and proteins, modulates nuclear kappa factor B signaling, and promotes the release of additional cytokines, thereby creating vicious cycle of inflammation and oxidative injury, which has been implicated in carcinogenesis. Although oxidative stress markers have been evaluated in serum and saliva of oral lichen planus patients, very few studies have assessed the tissue level of 4-hydroxynonenal expression in oral lichen planus. So the aim of our study was to evaluate and compare the oxidative stress levels in oral lichen planus by assessing the immunohistochemical expression of lipid peroxidation marker 4-hydroxynonenal in oral lichen planus tissues versus normal mucosa. The present study actually was a retrospective observational study. We analyzed 30 histophysiologically confirmed oral lichen planus cases along with 10 normal oral mucosal samples as negative controls, whereas oral squamous cell carcinoma samples served as positive controls. The OLP cases included 26 reticular and 4 erosive variants. Formalin-fixed paraffin-embedded archival tissue blocks were retrieved following ethical approval. Our inclusion criteria ensured a definitive diagnosis, while our exclusion criteria excluded patients below 28 or above 70 years and patients on immunosuppressive or antioxidant therapy or those with prior treatment history. 2 consecutive 5-micron sections were prepared for immunohistochemical staining. 2 blinded oral pathologists independently evaluated the staining intensity. Inter-observer agreement was excellent with a coherence kappa value of 0.81 and staining intensity was categorized as 0 is none, 1 is mild, and 2 is moderate, and 3 is intense. Statistical analysis was performed using FIS's exact test with probability value of less than 0.05 considered significant. Our results, actually the mean age of oral lichen planus patients was 43.5 plus or minus 5 years. Among the controls, 90% showed no detectable staining and 10% showed mild staining. This is the normal tissue with no detectable staining, only it shows keratin layer, and the adjacent tissue is positive control, which showed intense staining. In contrast, oral lichen planus cases showed 53.3% showed mild staining and 46.6% showed moderate staining, and none were negative. Cytoplasmic expression of 4-hydroxynonenal was predominantly observed in basal third of the epithelium, and there was a statistically significant increase in 4-hydroxynonenal expression in oral lichen planus tissues compared to normal controls with a probability value of less than 0.01. The elevated expression of 4-hydroxynonenal in oral lichen planus tissues indicates increased lipid peroxidation and oxidative damage within the lesional epithelium. 4-hydroxynonenal forms stable adducts with DNA and proteins contributing to mutagenesis and cytotoxicity, which was described by Euler et al. In 2014. Barto and colleagues demonstrated elevated oxidative stress markers in patients with oral lichen planus. Similarly, Sander et al. In 2004 reported increased 4-hydroxynonenal expression in vulvar lichen planus tissues. Mithran et al. In 2019 further reported elevated levels of reactive carbonyl species in patients with lichen planus, reinforcing the oxidative stress hypothesis. Our findings also align with these observations, as we also identified increased cytoplasmic 4-hydroxynonenal expression, particularly at the basal third of the epithelium. Persistent oxidative DNA damage, if unrepaired, may contribute to genetic instability and potentiate malignant transformation. Thus, oxidative stress may represent a critical molecular link between chronic inflammation and carcinogenesis. Our study has certain limitations. It was a retrospective design, there was a limited sample size, and we did not go for subtype stratification. Further research should incorporate larger cohorts and other molecular markers to better elucidate the mechanistic pathways involved. 4-hydroxynonenal represents a measurable molecular footprint of oxidative tissue injury. It serves as a potential biomarker for disease monitoring. To conclude, oxidative stress in oral lichen planus is not merely a bystander. It is the molecular trigger that may determine whether chronic inflammation remains benign or progresses towards malignancy. So, earlier intervention at the oxidative stage may reduce the cancer risk. Thank you. I thank the organizing committee and honorable judge for this opportunity, and thank you all for your attention. I'd be happy to take any questions.
Thank you, Dr. Khadija. It is a very clear-cut presentation on the specific biomarker that you have tried to evaluate in reducing or measuring the oxidative stress in lichen planus patients. Thank you.
Thank you, sir. Thank you, sir. Thank you very much.
We can move on to the next.
After the assessment of Dr. Gopa, moving on to the next paper presenter, I would like to invite Dr. Vishwas Kadam. I'd request them to turn their mics on and give a brief introduction. Dr. Vishwas?
Sir, I am here.
Yeah, please continue with your brief introduction.
Okay, sir. I am Dr. Vishwas Kadam. Currently, I am working as a professor at CSMS's Dental College, Sambhajinagar, previously Aurangabad in Maharashtra state. And also, I am pursuing my PhD in the same subject.
Dr. Vishwas,
Yes.
have you shared your slides, please? Can you share slides, please?
Yes, sir. I'll just share my slides, sir.
Thank you.
Okay, we can see you now. You kindly share your screen, sir.
Yes, sir. Yes, sir. So, can you see my slide?
Not yet.
Not yet.
Your screens aren't visible, Dr. Vishwas.
Yes, sir. I have shared it, but it's not opening.
It's not visible, Dr. Vishwas.
Sorry, sir. I'm trying, but I don't know.
You can take your time. I think probably the next participant, the presenter, if he's ready, we can continue with that and you can come back.
Sure. That
Yes.
is better. I think.
Yes, sir. Sure. Okay, sir.
So, Dr. Monal, are you there? Dr. Monal? Could you please unmute Dr. Monal?
Yes, I'm there.
Yeah. Yeah, your slides are visible. Could you make it in the presentation mode?
Yeah.
Yes.
Yeah, good afternoon, esteemed judges, all the delegates. I'm presenting the functional assessment of free flaps. Basically, the functional assessment of free anterolateral thigh flap versus radial forearm flap reconstructions for hemiglossectomy defects. Now, as we know that the tongue cancer is one of the most common intraoral malignancies in India. Even though the in the anterolateral border, that is 2/3 anterior of the tongue, is one of the most common site for CA tongue, we have seen it to be present in tongue abdomen, base of tongue, and tip of the tongue as well. Now, the standard treatment for CA tongue patients, it is hemiglossectomy with immediate reconstructions. Now, the reconstructions, we have few goals of reconstruction. That is, we have to restore the speech and swallowing. We have to maintain the tongue appearance. We have to minimize the donor site morbidity. That is very important. So the important options that we have is one of them is free radial forearm flap and one is free anterolateral thigh flap. In our study, we have incorporated around 46 patients with diagnosis of CA tongue lesions between T2 and T3. and we studied from January 23 to April 2025. This study was conducted at a rural hospital in India, in central Maharashtra. We had around 30 patients who had CA tongue were male and 16 were female. All of them, except one female, all were having the habits. Age range was between 47 and 80 years. The mean age was around 64 years. All the patients, they underwent hemiglossectomies with immediate reconstructions. The ALT flap we had incorporated was around 12 patients, and free radial forearm were 34 patients. We had evaluated and we had followed these patients 3 months after the surgery. The outcome measures we had seen, one was the vascular complications with any vascular crisis, the speech functions, the swallowing functions, and the donor side morbidity as well. The student t-test was used with the version of 13 SPSS, and p-value was considered significant, less than 0.05. Institutional ethical committee approval was taken, and all the patients were informed about this study as well. In the ALT flap, that is anterolateral thigh flap, the flap was based on the descending branch of lateral circumflex femoral artery. The perforator dissection was done as subcutaneous and musculocutaneous. We had preserved the muscle curve of around 0.5 centimeters around the vessel, and the fascia and the fat curve was around 1 to 1.5 centimeters around the perforator. It was a bit thin flap that we had incorporated here. And the donor side, it was closed as primary closure. In free radial forearm, the dissection was deep to the antebrachial fascia. The vascular control, we had taken the radial artery, which we usually take, that radial artery, and vena comitatus. It was ligated distally and divided distally. We raised the flap from distal to proximal. We had taken enough care to avoid the injury to the dorsal branch of the radial nerve, which is usually we see. The additional component here was cephalic vein was included with the flap, and the donor site, we had covered it with split thickness skin grafting. All these flaps, they were anastomosed to the neck veins. Now, after these procedures, after the 3 months, we had evaluated for the functional functionings now. So the swallowing assessment was done. We had taken around 175 ml of water at room temperature, and we had measured the number of swallows that was taken by the patient. The total time was taken by the patient to have that bolus volume. So we calculated the bolus volume, the duration per swallow, and the ingestion rate as well. And the speech assessment, it was done with the software. It was recorded in a silent room with microphone, evaluated by speech pathologist, and the parameters studied were the vowels, that is A, I, and U, with the 3 formants that we had taken, that is F1, F2, and F3. F1 based more on the tongue height, F2 was based for the tongue positioning, and F3 was oral cavity resonance. Now, the results were with ALT flap, the anterolateral thigh flap, there was 100% success rate. Even though we had taken this thin flap, which was around 4 millimeters of the thick flap, the rate of success was
Dr.
100%.
Monal, your screens aren't visible. I think, you might have shared your screen and not your slides. Yeah, it's back to normal. Yeah, continue, please.
Yeah, thank you, sir. Thank you, sir. So with the anterolateral flap, we had 100% success with only one patient with vascular crisis, but later it was salvaged. We had to reoperate, but the case was salvaged. But with the case of free radial forearm, one flap underwent necrosis. One flap we could not salvage, but success rate was around 97% with this volume of 34 patients. There was vascular crisis in 3 cases, but it was managed. No major survival difference was found in both these flaps. Now, with this donor site outcomes, ALT flap, there were no complications. But with free radial, 4 patients, we had partial loss of the graft that we had placed. And most important was the finger numbness, which was seen in 9 cases, which was not acceptable for us also. So the functional outcome, there was no statistical significant difference between the swallowing function. So the flap were working better in both of them. When we come to the acoustic analysis, even though there was no statistical difference, but we could see that the intelligibility was better with ALT flap in these patients, even though there was no statistical difference found. the advantages of free radial, even after these cases, the advantages of free radial forearm is it is easier to harvest, one thing, and it definitely allows two-team approach. We can get a very thin and pliable graft here with long vascular pedicle, which is better for anastomosis here. But the limitations are very important here, that we have to sacrifice the radial artery, which can cause the injuries to the forearm. Poor donor set aesthetics are there, and there is definitely risk of nerve injury and dysfunction and tendon exposures as well. But with anterolateral thigh flap, as we had taken very thin flap here, the thinness, it was better as compared to the free radial forearm, because we can adjust the thickness and the volume of flap in anterolateral thigh. We had a good donor site outcomes also, with linear scar, primary closure was good, and no functional deficit was there. So we had seen that there is better tongue palate contact after this flap, and swallowing efficiency was also a bit better. So even though we can see that both these flaps, they don't have any significant difference between the parameters that we had seen, that was speech, swallowing, and the formant values, but they had acceptable functional outcomes. Interpretation from our study, what we can take is, even though none of these flaps restore the normal function what a normal tongue has, but they can both provide a clinically acceptable outcome.
Thank you,
And
Doctor.
the
I think
evidence
your
is
interpretation and your results are already set. We accept that.
Sir?
I think lack of time will be one feature. You have driven the point straight to us, saying that both of these
Sir.
are comparable flaps.
Yes.
And both are good ways of how to reconstruct the tongue, especially in case of hemiglossectomy. One question.
Sir.
Is that how difficult was it, especially in cases where hemiglossectomy is done? Was there a lot of aspiration, lung aspiration while swallowing?
Yes,
and how do you
yes, sir. Yes,
tackle
sir.
that part?
Sir. Yes, sir. Actually, we had tracheostomized a few patients, sir, in this, not all. But that whenever the patient had that issue with the swallowing, sir, we had maintained a permanent tracheostomy in this patient, sir, and we had given them rice tube and the option of PEG also.
All right. Thank you so much for your good presentation. A very
Thank you,
useful
sir. Thank you, sir,
presentation.
for the
Thank you.
opportunity, sir.
Thank you, Dr. Monal, for your paper presentation. Now I would like to invite Dr. Shipra Deshpande. She is within us. I'd request her to turn their mic on and give her brief introduction. Dr. Shipra?
Sir, good afternoon, one and all. Myself, Dr. Kshipra Deshpande. I am a professor at Hedegewar Dental College, Hingoli. I am a faculty of oral pathology and microbiology. Should I start sharing screen?
Yeah, please do
Yeah,
that.
please. Please.
I'm MDS oral pathology and I'm pursuing my PhD at Government Dental College, Nagpur. Sir, so
Yeah,
can you
your
able
slides
to
are
see my
visible.
slides?
Yes,
Yeah,
ma'am.
your
You
slides
can
are
go to the
visible.
slideshow mode.
Actually, I myself is not able to see slides.
Ma'am, you can use Alt plus Tab if you are on laptop.
Yes, sir.
You can use Alt plus Tab to switch between different windows.
So sorry, sir, but it's not visible. Sir, can you able to see the slides?
Yeah, ma'am.
We are able to see the slides, madam. You proceed.
Okay, sir. Then I will start from my desktop only then. Because on this Zoom, I can't able to see slides. Sir, shall I
Fine.
start?
It's fine. You can start.
Okay. A very good afternoon to one and all. Today's my presentation topic is keratotic lesions of the oral cavity, how to distinguish the benign from the deadly. These are the my contents for presentation. White lesions of the oral cavity are commonly encountered during clinical dental practice. Many of them are harmless and do not require any treatment other than reassurance from the side of the clinicians. But still, a small minority, roughly 4%, are potentially dangerous if left unattended. This emphasizes the need for an efficient chairside workup for finding out whether a particular white lesion can turn problematic later or soon. For the clinician, you should be knowing the category wise this distribution for the white lesions in the decreasing order. They may be inflammatory, reactive, dysplastic, neoplastic, oral manifestations of common dermatologic diseases, oral manifestations of systemic diseases, and developmental. This is a detailed classification based on the etiology of the commonly occurring white lesions, oral white lesions. There are some lesions which are potentially malignant. The chances of a patient with a keratotic lesion developing a carcinoma are much higher than in patients without such lesions. Indeed, a so-called leukoplakia, which is a clinical term which has more valued clinical sign of malignancy. If we take biopsy, you may get the different grades of dysplasias in these lesions. In the classical study by Waldron and Schaefer, keratotic white lesions on the floor of the mouth had a 50% probability of being either severe dysplasia or worse, and keratotic lesions of the lateral border of the tongue had approximately 37% chance of being dysplastic. I mentioned this because when you the clinician come across such lesions in that particular area, we should be suspicious of any pre-malignant or malignant changes. Apart from the site or location of the lesion, other important parameters to be considered include the age of the patient, history of tobacco or alcohol use, presence or absence of pain, and clear demarcation from the surrounding mucosa. Prevention and early detection of such potentially malignant disorders have the potential of not only decreasing the incidence but also in improving the survival of those who develop oral cancer. Keratotic white lesions of the oral mucosa are often present problems for differential diagnosis, which are of primary importance when assessing precancerous changes in the mouth. According to the classification or category wise, first is the genokeratotic lesion, in which leukomed edema, which is most commonly seen in the buccal mucosa, and histologically it shows the hydropic degeneration of cells and eventual spongiosis of the stratum spinosum. Next is a white sponge nevus, in which spongy plaques on the buccal mucosa, and histologically you may get the epithelial thickening, parakeratosis, and vacuolization of the superficial keratinocytes. Hereditary benign intraepithelial dyskeratosis is the next common lesion, which is seen as a row of plaques on the buccal mucosa, and histologically it shows the cell within cell pattern. Keratotic folliculosis is also evident on the as a white lesion on the buccal mucosa. Dyskeratotic crop prone cells. This is the characteristic feature histologically. Pachyonychia congenita, in which you get acanthosis, parakeratosis, and ballooning of the epithelial cells. That's why it clinically appears as hyperkeratotic plaques on the oral mucosa. Dyskeratosis congenita and focal epithelial aplasia are the other genodermic lesions, which clinically shows as the white lesions. Whenever a clinician comes across such type of white lesions, they have to categorize, and once it is according to proper history, if it is genetic disorder, then you have to see for other lesions like other areas like conjunctiva, anus, or the nail, skin. All these have to be ruled out, and then that definitive white lesion has to be categorized as a genetic white lesion. The most common entity regarding the pre-neoplastic and neoplastic is the leukoplakia. These are the pictures showing the clinical forms of different types of leukoplakia. There is homogeneous type, hairy leukoplakia, speckled leukoplakia, exophytic or verrucous leukoplakia. The next benign epithelial white lesions of oral cavity are the actinic cheilosis, squamous papilloma, keratoconthoma. Then coming to the next variety that is most common is the
malignancies, that is squamous cell carcinoma, which shows the proliferative growth on the mucosa, and histologically it is graded as a well, moderately, and severe. This poorly differentiated. Varicose carcinoma is again a proliferative varicose growth by tissue growth, which is showing hyperkeratotic keratin plugging, but the hallmark of invasion is absent in such cases. Next category is the immunologically mediated diseases. These are the slides depicting the different clinical forms of the lichen planus, that is the reticular, plaque-like, erosive, annular, linear with the pigmentation. If these lichen planus have the characteristic clinical features, so that we can diagnose the case and treatment plan can be planned for the such cases. Histologically, this lichen planus shows the hyperkeratotic epithelium and subepithelial lymphohistiocytic infiltrate. When we are suspicious of lichen planus, then definitely we should go for the biopsy. Next region is the lupus erythematosus, in which you get the perivascular lymphocytic infiltration and hyperplastic spinous layer. The next common lesions are the reactive lesions, in which most commonly encountered clinically are the frictional keratosis, in which you get the hyperkeratotic surface epithelium. In such cases, if the patient is complaining of lip bite, cheek bite, in such cases, you're just in one sitting or in the first sitting initially, you will not need to go for biopsy. You just assure the patient, keep patient under observation, and remove the irritating cause or that is causing keratosis. Then in Indian scenario, most common is the tobacco-associated keratotic lesions, in which nicotinostoma, that is black hairy tongue, hairy leukoplakia, tobacco pouch keratosis, lichenoid lesions are most common. If we have to keep the patient under observation, counsel for the tobacco cessation, and if it is not resolving, then you can go for biopsy and see the epithelial changes if they are seen. Then in candidate infection, that is chronic hyperplasia candidiasis, you may get the white plaques on the buccal mucosa, hard palate, or the dorsum of tongue, and on clinical exam, this microscopic examination, you may get the candidal hyphae. So this decision tree is important to understand by the clinician, because it will lead you to categorize the lesion, and accordingly investigation and the planning for the treatment can be done, which will be important. In conclusion, I can say that the process of clinical diagnosis and treatment planning in the case of white lesions of the oral cavity is of great concern to the patient, as it determines the nature of future follow-up. This can be in the form of a reassurance that the lesion need not be concerned, or in the form of a follow-up advice after eliminating all possible local irritants. In a few cases, it can be an immediate biopsy followed by definitive treatment. The path to be taken or the strategy to be adopted depends on the judgment-making capacity of the dental diagnostician. Clinical diagnostic skills and good judgment forms the key to successful management of white lesions of the oral cavity. It is important that underdiagnosing followed by the dismissal of the suspicious early lesions, or overdiagnosing and instituting aggressive management strategies is deplorable and should be avoided in the interest of the patient community. A careful, observant eye and sensible judgment can add to the diagnostic skills of the clinician and are considered important for proper patient care. These are my references. Thank you. At the white lesions are more common, and just through this paper I want to share that all are not having malignant potential, but if you suspect it is malignant potential, then and only you can ask for the biopsy for that particular case. Thank you very much. Thank you the organizing team to give me this opportunity to present my work.
Thank you, Dr. Kshipra Deshpande, madam, for your. I was almost feeling like I'm attending another lecture on white lesions. Thank you. So it's very difficult to cover all of them together, and I understand that, but that's why you are hurrying it up. Keratotic white lesions still form a major cause of concern. And any keratosis, wherein when you say keratosis, we are talking about keratinization at places where it's normally not there. So that way, keratosis, if it occurs, whether it's a cheek bite or whether it is a frictional keratosis or a pouch keratosis caused due to a habit, it has to be taken seriously. And there should be efforts at a community level where a self-examination of the mouth by the patient, and he finds that there is a white patch inside, should drive him to the clinician as early as possible. It's better to overdiagnose rather than underdiagnose. We do that. So thank you very much, Madam, for bringing light to the right patients.
Thank you, sir. Thank you very much.
Thank you, Dr. Shipra. Now, coming on to the
Thank
next
you,
paper
sir.
presenter, I would like to invite Dr. Mrunal Meshram. Dr. Mrunal?
Yes, sir. Is my screen visible?
Yeah, they are. Please put them on presentation mode and you can continue.
Okay.
You can start your presentation, Madam.
So is it visible now?
Yes, ma'am. It is visible and you are also audible.
Okay. Respected judges and all the dignitaries present here on this virtual platform, a very good afternoon to all. Myself, Dr. Mrunal Mishram, I am working as a in the Department of Oral Medicine and Radiology, Sharad Pawar Dental College and Hospital, Wardha. It has been rightly said that first we make our habits and then our habits make us. Here I am presenting a study based on the habit of school going children. The title of my study is Rapid Upsurge of Ericanet related products habit in the pediatric age group. Now time to think. It is the analysis of 23 cases and a cross-sectional study. Coming to the introduction, the chewing ericanet and phenyl, which is commonly called as soft, is cultural and religiously accepted habit in Indian population, which makes it easily accessible to the kids. It is easily available and can be consumed in the raw form or with the spices and condiments such as with or without tobacco, and it is packed in the small polythene papers. Now, ericanet and tobacco-induced lesions are precancerous lesion and conditions like OSMF, lichen planus, and tobacco-induced lesion. Some carry the malignant potential. Sir, am I audible? And my slides are visible?
Everything
Yes,
is
ma'am.
good. Go ahead.
Yes, sir. Thank you, sir. So these are the sites of cancer. If you see the global scenario, HNN cancers are sixth most common form of cancer globally, and in South Central Asia, it is third most common type of cancer. If you see the Indian scenario, it takes ranks among top three types of the cancer in the country. Now coming to the OSMF, with which we have conducted a study, often present with the common symptom of burning while having hot and spicy food, then the fibrosis all over oral mucosa, and yes, significant reduced mouth opening, which bring patient to the OPD. We conducted this study with the aim of evaluate the pattern of OSMF in betel nut and fennel chewer children with the objectives to correlate the age of starting habit with the occurrence of OSMF, to correlate the duration of habit with the range of interincisal distance, and to correlate the amount of betel nut and tobacco with the occurrence of OSMF. We have taken 23 children in the age group of 17 to 15 years and evaluated with the betel nut and fennel habit and its correlation with all these symptoms.
Somebody
Now,
else
when we
is
interacted with the school children,
screen sharing is seen.
जी sir.
नहीं जो एक और screen sharing is coming. Your screen share is not seen.
Acha, sir, here like, shall I share it again?
Problem, ma'am. You can continue now.
Okay,
Sorry
I'll
for
just
the.
share it again.
Okay, sure.
No,
You
sir.
can do it.
So is it visible now?
Yes, ma'am.
Yeah, now it's come back. Fine.
Okay. So when we interacted with the school kids, the reasons of their consumption were mood elevation, relief from the toothache, improvement in the oral hygiene, as they said it, and the reasons like craving, relief from boredom, just aids in the concentration, they said. Then good taste, it refreshes the breath, and like the custom or to look just mature were the reasons given by some kids. So the results were in the first age group, that is 7 to 9 years, the age of starting habit was 0 to 5 years. In second group of 10 to 12 years, age of starting habit was 6 to 10 years, and in the third age group, that is 13 to 15 years, it was more than 10 years. The frequency was ranges in the frequency of 3 to 8 times per day. So the initially phenyl cheers were 16 children. Initially, only betel nut chews were 7 children, and initial betel nut and fennel chewing, which was followed by the tobacco chewing, were 19 children, that is 82.60%. See, so out of 23 children, around 48% adopted the habit of tobacco chewing. Around 60% of the children presented with the introincisal opening up to 20 mm. 83% of the children started the habit of fennel chewing and switched over the combination of betel nut and fennel. So the present study shows analysis of these 23 children with the basis of frequency and duration of chewing erica nut in different forms with their progression of the disease of OSMF. Now, 83% of the children started with the habit of fennel chewing and switched over the combination of betel nut and fennel. Out of 23 children, 48% approximately adopted the habit of tobacco chewing, and 68% of the children presented with the interincisal mouth opening up to 20%. Now, what is the need of this study analysis? We all know the bad and side effects of erica nut and tobacco chewing. Even patients in the OPD says that ma'am मुंह नहीं खुल रहा क्योंकि मैं सुपारी खाता हूँ. So what is the need of conducting this study? Because childhood habits are most difficult to get rid of. The evaluation of the factors which are responsible for the initiation of these habits in the children, which result in the chronic habit of kharra and tobacco chewing. So to emphasize the need of early psychological counseling, education and prevention, which seems to the only way to reduce the risk of OSMF, because many, like in our cases, 20 kids were school going kids, they were not even aware of the side effects or the effects of this habit. So the adoption of habit from childhood to adult was just with the fennel, then to the lal supari, then to the combination of this, and then to kharra, and then the pouches which were available over the counter. Coming to the discussion, now these betel nut and tobacco pockets, these contain 4 alkaloids which result into the initiation and progression of OSMF. Also, betel nut contain aflatoxin. Now, this aflatoxin is considered as number 1 hepatotoxin by WHO, which is responsible for the initiation of hepatic disorder, and that is the reason there are many studies which are conducted on the level of iron in the patients of OSMF, because it reduces the capacity of liver as well as it initiate the anemia. These both result in the DNA damage. Now coming to the fennel, which is commonly called as soft and which is considered as harmless by many patients. Okay, but it is not, because it contains the content estragol, which is chemically have the compound of methyl shavicol. Now this estragol is responsible for both carcinogenesis and hepatotoxicity. How? If we see the carcinogenic activity of estragol, it get metabolically activated with the formation of unstable molecules and active radicals. It adds with the nucleic acid and result to the DNA damage. If we see the hepatic toxicity of phenyl, 1-hydroxyestragol compound metabolized by the liver result into 1-hydroxyestragol, which get conjugated with the sulfur, forming sulfuric acid ester compound, which readily binds with the DNA.
Can you just come back to your title part and then summarize? Because you said about the pediatric upsurge. So come to that part.
The rapid upsurge of erica nut and related products in the habits
get
of
to the results of that. Get to the result slides of that.
Okay, results. Okay, sir. Okay, sir.
Yeah, this is
so the aim of this study was just see the reasons of initiation of this habit, because the family members were one of the very important person by seeing whom the students initiated with the reason. So we shall do some things which will ban it. Government agency have already come forward for banning the advertisement on print media and putting the warnings of packings also. But as when we say that, we all know that how useless this is, as just by even if they see the dangerous sign on the package, they continue to buy it. So there are very strong things should be there. So, with the conclusion, I can say only this, that it is mandatory to motivate the children not to initiate the habit and enable the adolescent children to realize the potential health risk of areca nut and tobacco related products. Phenyl and betylent are responsible for the hepatic damage and occurrence of OSMF and other habits-induced lesion in the lesions. Also, in the previous study, role of betylent has been enlightened, but phenyl, which is the main culprit for the initiation of disease, because in the pan supari plate there is always phenyl which is consumed by the children, and this is responsible for the initiation of habit, as the estragol, which is the content of phenyl, which is demonstrated as
Thank you,
genotoxic as
Dr.
well as
Manal. Your
carcinogenesis and
point is driven
advertising.
well.
So,
Would
yes.
you tell us why there is an upsurge, as according to how you? What do you
Yes, sir.
think is the cause of the upsurge?
Yes, because they are there is the activation of in the brain system there is activation of CNS.
Yeah, because these people are more exposed to these products, so children have got better accessibility to buy it over the counter in shops. That's the reason why they are getting
Right, sir.
these habits. Okay. As you said, a
Yes,
habit
sir.
developed not only in the childhood, even in the adulthood. Habit is very difficult to
Right, sir.
break. So, just by counseling or by governmental agencies displaying photographs is not the way, as you said. So, habit is something which,
Right.
even from the family members, as you said, they should be able to break the habit, and then self motivation by good knowledge of all that carcinogenic potential and the hepatotoxicity of all those products and its byproducts has to be taught in school. Catch them young before they get into the habit. So
Right, sir.
H in the habit, if you remove, a bit remains. A you remain, bit remains. The B you remain, it remains. So
Right,
that's why
sir.
the habit is very difficult to break. So good that you have noticed.
Right.
In the last 25, 30 years, we have all noticed that there is a pediatric age group which are more succumbed to getting into these habits.
Right.
Now, much more than this, substance abuse, drug abuse. They don't drink, they do not smoke, but they are into drugs. So that's the kind of attitude that the children are getting into. So as a parent, every one of us will be worried. And I'm sure every one of us have to take steps necessarily in the family itself to make sure that these people
Yes.
do not fall prey to such habits. There is an
Right.
interesting study, if any one of you are listening, there is an interesting study amongst the fisher folk in Kerala. Now it's called
Okay.
Kerala. So that place, they have done a study on children who are accompanying the adults for fishing for 3 to 4 nights out in the deeper sea. They get to these habits much earlier, by around 6 to 7 years when they're going there to be in the boat along with them. They used to keep the fun. So if you can quote Dr. Babu Matthew, Dr. Zakaria Joseph, and people who have worked on those, especially in the preventive oncology department of regional cancer center. You can have a look at that paper. You'll
Yes,
get more inputs of why these people are getting addicted at their very younger age. Thank you, doctor.
sure, sir. Thank you, sir. Thanks a lot. Yes.
Thank you, Dr. Mrinal. And it appears that Dr. Vishwas has came back. So
Yes, sir. I just share my screen.
Slides, doctor.
yeah, doctor, please share.
Yes, sir. Is it visible, sir?
Sorry, doctor, they aren't visible.
Not yet come. अभी आ रहा है उल्टा. Yes, it's come, doctor.
Dr. Vishwas, your slides are visible. You can continue now. Dr. Vishwas, can you unmute yourself?
Am I audible now?
Yeah, you are audible, Dr. Vishwas.
Sorry, sir. The aim of the study was to use digital panoramic radiographs to check the fractal dimensions and lacunarity of the trabecular bone pattern in the mandibular bone specially, and to identify any early osteoporotic alterations in patients who had the habit of smokeless tobacco chewing, and identify any differences compared to the non-chewers. Osteoporosis, it is characterized by decreased bone strength with susceptibility to fractures. Either it is secondary to a minor trauma or sometimes without any trauma as well. Osteoporosis, it diminishes two things. That is, one is thickness and number of trabeculae, which we call fractal dimension. And on the contrary, it increases the trabecular partition, that is amongst the trabeculae, which is called as lacunarity. And in the study, we are going to study both these parameters, that is fractal dimension and the lacunarity. Amongst the substances included in etiology of osteoporosis, tobacco plays a very vital role. Panoramic radiography is highlighted in this setting since it is regularly available in dental office or dental institutions. It is quick, low cost, and with some low amount of radiation, and we have a large amount of stored data in our institutions. Now, design, prospective cross-sectional case control, descriptive observational study. What we did, we took 90 scans of dentulous patients within the age of 20 to 50 years, in which 45 cases were of smokeless tobacco quid chewers who had habit of chewing tobacco for more than 2 years, and the other group was 45 control group with no such habits. The digital images were taken and they were exported to JPEG image format by Dowcom software. Now, this is the image evaluation that we did. All the OPGs were collectively assessed by a processor, that is image J scanner program. Now, the box that you can see in the image, it is a square shaped box of 168 by 168 pixel size, which was taken. Now, initially, it was blurred by a Gaussian blur filter, after which a subtraction was done of the blurred image, and to that blurred image, 128 grayscale was added, followed by binarization and erosion of the image. The eroded image was then dilated. After dilatation, the image was inversed. That is, there was reversal of the bone marrow and the trabecular spaces, and then final was the skeletization of the image. This we did for each and every image that we had acquired. And the image J is a public domain software that facilitates image processing. So this is the window through which we could do all the analysis of the image. A statistical analysis was done by the SPSS software, and these were the results. So when we considered the mean age group and the gender, there was no any significant difference. But when we came to the fractal dimension and lacunarity analysis, the fractal dimension was significantly lower in case group, that is tobacco chewers group, compared to that of the non-chewers, which was in accordance with previous studies. And in contrary, the lacunarity, it is a measure of structural inhomogeneity of the bone, which was significantly higher as compared to that of the control group. That is, in control group, it was lower and higher in case of tobacco chewers. So we found that fractal dimension and lacunarity showed significant differences amongst both the groups. Now, coming to the topic, relevance of tobacco related to bone loss. The tobacco constituents, especially nicotine and nitrosamines, they promote osteoclastogenesis and impair calcium absorption, which is results in reduced bone mineral density and increased fracture susceptibility. This is the flowchart that gives both the direct and indirect effects of tobacco, which eventually lead to decreased BMD and leading to osteoporosis. Now, clinical research and implications, which we could do with the help of this study. This finding underscores the clinical utility of panoramic radiographs in the routine dental practice as screening modality. Given the widespread availability and low cost of these imaging tools, their integration with FD and lacunarity analysis could serve as an effective non-invasive strategy for early detection and monitoring of bone changes. Moreover, since osteoporosis is often asymptomatic until fracture, early identification of compromised bone architecture using panoramic radiograph will help us. Now, concluding my topic, as the today's platform primarily deals with tobacco and oral cancer, so why not use digital OPGs as an aid for educating the patients for quitting the tobacco habit, to motivate them for tobacco cessation, and also for early diagnosis of osteoporosis. It is well said that a stitch in time saves 9. With this, I conclude my topic. Thank you so much.
Thank you, Dr. Vikas.
Thank you so much.
Vishwas, you're
Yes,
an
sir,
oral
yes,
medicine
sir.
faculty because you've done your digital panoramic. Okay, great. So
Right, sir, right.
Your point is well driven. Osteoporosis, if it is identified early by routine panoramic radiography itself, it's a very vital point that you've driven. Thank you for the presentation, Doctor.
Thank you so much, sir. Thank you so much.
Thank you, Dr. Vishwas. Now coming on to the next paper presenter, we have Dr. Hafida. Dr. Hafida, I request you to turn your mic on and continue with the presentation.
Yes. So, am I audible, sir?
Yes, ma'am, you're audible.
Okay.
Kindly share your PowerPoint screen.
Your screens are visible. Kindly, yes, now it is in presentation mode. Kindly continue, ma'am.
Yes, sir. Thank you, sir. Good afternoon, respected chairperson and judges. I'm Dr. Hafida Punyabdullah, a full-time research scholar from the Department of Oral Pathology, Yenapur Dental College, Yenapur deemed to be University, Karnataka. Today, I will briefly present our work on region-specific genomic architecture of oral squamous cell carcinoma from tumor normal paired whole exome sequencing approach. Oral squamous cell carcinoma accounts for more than 90% of oral cancer in India. However, most genomic reference data sets are derived from Western populations, and data from our region, that is the southwest coast of Karnataka region, remain limited. Hence, we hypothesize that oral squamous cell carcinoma in our population may exhibit a distinct genomic feature that are not fully captured in global datasets. We analyzed tumor normal paired formalin fixed paraffin embedded samples from surgically treated oral squamous cell carcinoma patients. A paired design was specifically chosen to reduce background germline noise and improve confidence in true somatic alterations. Whole exome sequencing was performed, findings were validated using fresh biopsy samples, and comparisons were made with TCGA and Indian oral cancer datasets. We also estimated polygenic risk score using South Asian reference genome. Our analysis revealed a distinct mutational landscape with marked interpatient variability. A predominance of missense mutation was observed, suggesting functional disruption rather than a complete gene loss. Mutational patterns involving TP53 and CDKN2A patterns align with the expected OSSE biology. XRCC1 involvement is noteworthy due to its role in cisplatin response, thereby causing a therapeutic relevance. We have also observed a high recurrence of shared mutation, suggesting a non-random mutational pattern. The tumor normal pairing confirms these are the true somatic events and are not baseline variation. We have also observed that certain genes appear to be consistently altered across the cohort, signifying a possible regional signature. Our notable finding was the presence of a TLR1 variant in all the tumor samples, while it was absent in the control tissues. This consistent tumor-specific signal suggests a potential region-specific somatic marker in South Indian oral squamous cell carcinoma, highlighting the population-enriched genomic signature. In order to understand the inherited susceptibility and the genetic predisposition beyond the environmental exposure, we calculated the polygenic risk score. Polygenic risk score analysis revealed that majority of the patient clustered in the highest risk quartile. This suggests that inherent genetic susceptibility contributes significantly to oral squamous cell carcinoma risk in this population alongside the somatic alterations. When we compared if there is any functional impact and whether there are any biological pathways related to these recurrent mutated genes, we observed that these genes were involved in hormone-regulated signaling, cell cycle, and cell cycle proliferation. Also, there is a role in DNA repair pathway, where the relevance of XRCC1 causing cisplatin relevance. And when we correlated our findings clinically, we came to know that most of these genes have mapped to recurrence patterns, genomic imbalance that is showing a very aggressive behavior, and most of the mutated genes can be used as a potential marker for the prognosis. And all this data has been available with the routine FFP, indicating the robustness of using FFP in the routine diagnostic NGS analysis. Further, we compared our FFP data with that of the fresh biopsy data, following the same methodology, undergoing sequencing and data analysis and bioinformatic analysis, and we came to know that most of the genes are in concordance with that of the fresh biopsy samples, and also indicating the robustness and reproducibility of FFP-based whole exome sequencing for genomic profiling. To highlight my study, we observed mutation account about 80% in XRCC1, ITPKB accounting 95%, which align with the previous reports of XRCC1 missense variant. Additionally, we have also observed a region-specific mutation in certain genes such as CHD8, ITPKB, and HNF1, and also one single nucleotide variant which is linked to chemotherapy response. We have also observed there is a loss of heterogeneity involving EGFR, CDKN2A, and CMYC, which was associated with the recurrence and very poor clinical outcomes. We have also identified 40 genes which is frequently mutated, that is accounting for the 94% of the patient in tumor, and also with the DBGenVoc databases. So I could say that it's one of the first tumor normal OSSE genomic studies from the southwest coast of Karnataka. We have observed a distinct somatic signatures and high PRS signal patterns and a potential marker for recurrence prediction. Polygenic risk score highlighting the inherited susceptibility in this understudied population, and DNA repair findings which is linked to treatment response. Hence, we could say that this study can be used as a foundation for region-specific mutational pattern to advance personal therapeutic approaches and refinement in the management of OSSE patients. These are my references. And thank you for the patient hearing. I am paying my deep gratitude to my guide, Dr. Riaz Abdullah, Professor, Department of Oral Pathology, Yenapur Dental College, my co-guide, Dr. Ranjit Das, Associate Professor, Department of Bioinformatics and Structural Biology, Yenapur Research Center. My gratitude to my university, Yenapur Deemed to be University and Yenapur Dental College, for providing all the necessary arrangement for my research work. And my work is funded by ICMR, giving me the fellowship of ICMR DHR Women Scientist Day. And thank you, IOCCON 2026, for giving me an opportunity for this presentation. Thank you for your attention. I'll be happy to take the questions.
Thank you, Dr. Hafida. It was a comprehensive presentation of gene mutations and alterations. And then, as you said, the problem remains because 40 of them you have identified. If you understand the practical feasibility of this going on for, as screening, it is a little impossible as at present, because you got a study grant, so you could do this. But when it comes to practical feasibility, which one of these have to be tested for in a patient as a biological marker is a question. Otherwise, of course, people will have to now select these and take one of those markers and then try to identify if there are any major changes which occur in these gene expressions and mutations in specific cancer cases in oral cancer. Thank you.
Yes, sir.
Thank you for the good presentation.
Thank you, Dr. Hafida. Now coming on to the next paper presenter, Dr. Kavya RK. I'd request them to turn their mics on.
Yeah, yes, sir.
Thank you.
Can I share the screen?
Yes,
This
ma'am,
is again a
please.
faculty presentation.
No, actually, the faculty presentation are done. The last faculty, Dr. Priyanka Lasune, will be taken after all the PGs
Dr.
and
Mrinal Meshuram and Dr. Hafida is also faculty.
no, no, Dr. Hafida is PG.
Is it so? Okay, fine. So we have come to the postgraduate presentations now.
Dr. Kavya, I think you are muted.
Yeah.
Your slides are visible. Please continue.
Am I audible, sir?
Yes, ma'am, you're audible.
Mrinal, you're a faculty analyst.
Imagine keeping a virtual mirror of your mouth that spots trouble before it even shows up. That's the power of digital twin technology in catching oral pre-malignant disorders and cancer early. A very good afternoon, everyone. Today, I'm speaking about digital twin technology for prediction of OPMDs and oral cancers. Moving on to the introduction. Oral cancer is often diagnosed at advanced stages, leading to poor prognosis. Malignant transformation of OPMDs remains difficult to predict. Current diagnostic methods lack personalized risk assessment. Digital twin technology creates a dynamic virtual model using real-time clinical imaging and biomarker data. It enables predictive modeling and individualized risk stratification in oral oncology. So, what exactly is digital twin technology? Digital twin technology refers to a dynamic virtual model that mirrors real world changes using clinical and biological data. In dentistry, it creates a continuously updated virtual replica of a patient's oral structures, enabling predictive simulation and personalized decision making. So, these are the 6 components of digital twin system. First is clinical examination data, radiographic and 3D imaging data, histopathological grading, molecular and salivary biomarkers, artificial intelligence algorithm, and cloud-based data integration platform. With these all 6 components, we can predict the oral pre-malignant disorders and oral cancer early. So how this functions? First, clinical plus imaging biomarker data is taken, then AI-based integration, virtual oral vision twin is taken, which predicts malignant transformation risk. So, what are the applications in oral oncology? Are early identification of higher risk OPMDs, optimization of biopsy timing, prediction of malignant transformation, simulation of treatment outcomes, personalized follow-up scheduling, precision-based therapeutic planning. So, what are the advantages in cancer care? In advantages in cancer care, early risk prediction, personalized treatment planning, AI supported clinical decision making, real time monitoring, and disease progression. Despite this, there are challenges also: data privacy in cancer prediction, psychological impact of risk labeling, high cost of implementation, need for multi-centric validation studies. Despite these challenges, the future potential is promising. AI-driven oncologic predictive models are the integration with genomic profiling, real-time salivary biomarker monitor, and integration with AR or VR for oncologic surgery planning. To conclude, I'd like to say early detection is the key to reducing oral cancer mortality. Digital twin technology offers a promising predictive tool, potential to transform oral oncology into a precision-based discipline, a step forward to closing the care gap in oral cancer. Lastly, digital twins are poised to transform oral oncology, turning data into foresight and care into cure. Let's pioneer the future together. These are my references, and thank you.
Thank you, Dr. Kavya, for giving an insight into the use of digital technology and use of data That's the key word. The data has to be actually now collected, compiled, and then you need to use it for by documenting it.
Yes.
Thank you.
Thank you, Dr. Kavya. Now coming on to the next paper presenter, we have Dr. Tuba Fatima. I'd like to request them to take the spotlight.
Yes, sir. Just a second, sir.
Dr. Kavya, can you please stop sharing your screen so that Dr. Tuba can share her screen?
Yes, doctor.
Thank you.
Is the screen visible?
There is a white screen with a blue border. I think, yeah, I think your screens are visible. It is just loading. Yeah, now it's visible.
Yeah.
Yeah, it is visible. Please continue.
One second, sir. I'm not able to change the slide. Just give me a second. Let's start the presentation, sir.
Yes, please continue.
Good afternoon, respected judges and faculty and my fellow presenters. I'm Dr. Tuba Fatima, an undergraduate student from M.R. Ambedkar Dental College and Hospital, Bengaluru. Today I'll be presenting a narrative review on the paper, on the topic Advanced Diagnostic Techniques and AI in Early Detection of Oral Cancer, a critical appraisal of clinical utility and limitations. So why does early detection matter? Oral cancer continues to have high global burden, and unfortunately, many cases are diagnosed at advanced stages. And most of these cases are diagnosed at advanced stages, and because of which there is a drastic drop in the survival rates once the disease progresses. Therefore, improving early detection strategies is essential to enhance the prognosis and reduce morbidity. So here are some advanced diagnostic techniques like optical coherence tomography. It is a non-invasive imaging modality that provides high-resolution cross-sectional images of the oral tissues. It enables early visualization of the epithelial and subepithelial alterations in real time. However, despite its imaging capabilities, it cannot provide definitive histological confirmation, and it is relatively expensive. Next, we have autofluorescence. Autofluorescence imaging, such as Bellscope, it detects metabolic changes in the tissues by assessing the fluorescence patterns. It is a quick chairside adjunctive screening tool. However, its major limitation is that high false positive rates are seen, especially in inflammatory conditions. Next, we have salivary biomarkers, which allow detection of DNA and microRNA, exosomes, etc., through non-invasive sampling. This offers potential for early molecular diagnosis before clinical changes are even visible. However, lack of standardized protocols limit this routine application. Lastly, we have liquid biopsy.
which enables detection of circulating tumor DNA and other tumor-derived biomarkers from saliva or blood. It provides molecular insight and allows minimally invasive early detection. Yet the high cost and need for large-scale validation remains challenging. AI in oral cancer detection, it enhances the diagnostic performance by analyzing large data sets. Deep learning and CNN models are used for clinical image analysis and digital histopathology. Studies report high sensitivity and improved lesion recognition. AI functions as an analytical tool that processes images and pathological data to support the clinical decision making. Here is a critical appraisal of the advanced techniques. Advanced diagnostic techniques are valuable because they are largely non-invasive and capable of detecting early molecular or vascular changes. They assist in biopsy site selection and also improve screening. However, the high cost, lack of standardization, and variable diagnostic accuracy limit their standalone use. Very importantly, they cannot replace histopathology. We have critical appraisal for the artificial intelligence. So AI improves diagnostic accuracy and reduces the inter-observer variability. It allows rapid image processing and may also support mass screenings in the future. Nevertheless, AI requires large validated data sets. It also carries risk for algorithm bias and raises ethical and medical legal concerns. Currently, it serves just as an adjunct rather than a replacement for clinical expertise. To conclude, advanced diagnostic techniques and artificial intelligence holds transformative potential in oral oncology. However, they are not ready to function as standalone replacement for biopsy. Their future lies in responsible integration with conventional diagnostic methods to achieve earlier and more precise detection. Thank you.
Dr. Fatima, thank you for your presentation. You said you are an undergraduate student.
Yes, sir.
Okay, you're in which year?
I'm doing my internship right now, sir.
Okay, fine. So, good presentation. All these, let us remember one thing, that in clinical oncology, the gold standard is always histopathology. Unless we see histopathologically proven cancer, and histopathologically it is proven once it is, then we can say it is cancer.
Yes.
All the rest of the things what we mentioned, whether it is optical coherence or whether it is autofluorescence by using xylite, etc., are only screening tests. They all cannot replace a biopsy and a histopathology. Now, when you apply AI to histopathology, let us not forget that the histopathological technique is very important. The biopsy specimen should be representative. The histopathology specimen should be properly processed, and a good photomicrograph has to be taken, which has to be fed into the AI-enabled system. Then those are again subjective factors. So AI cannot replace that histology, and it has to be when performed with maintained techniques of histopathology processing and a good photomicrograph fed into a very high level computer. The AI softwares can detect, and then you can't say that AI is improved diagnostic. It's only enabled the diagnostics.
It's just an adjunctive, sir.
Yeah.
Thank you.
Thank you, Dr. Fatima. Moving on to the next paper presenter, we have Dr. Shravani. Dr. Shravani?
Yes, sir. Yes, sir. Good afternoon, everyone. I am Shravani, an undergraduate from MR Ambedkar Dental College, Bengaluru. Give me a minute, sir. I would like to share my presentation. Good afternoon, everyone. Today, my topic is on circulatory biomarkers in early detection and prognosis of oral cancer. This presentation will focus on how circulatory biomarkers help in early diagnosis and disease monitoring and predicting prognosis in oral cancer patients. Oral cancer is one of the most common cancers worldwide and is a major public health concern, especially in developing countries. Despite advancement in treatments, the survival rate remains low due to late diagnosis. Early detection is crucial to improve patient outcomes and reduce mortality. Need for early detection. Most of the oral cancer cases are diagnosed at advanced stages, which leads to poor prognosis and limited treatment success. Conventional diagnostic methods like biopsy are invasive and often detect cancer only after visible lesions appear. Therefore, there is a need for invasive, sensitive, and reliable diagnostic tools for early detection. This is where circulatory biomarkers play a vital role. So, a biomarker is a key indicators for biological process and health conditions. So it is a biological molecule found in blood, saliva, or tissues that indicate a normal or abnormal process in the body. So next, let's see what the circulatory biomarkers are. Circulatory biomarkers are those present in body fluids, especially in blood and saliva, making them easy to detect through non-invasive methods. Some of the circulatory biomarkers are majorly divided as circular biomarkers, nucleic biomarkers, and protein biomarkers. In cellular biomarkers, mainly primary circulating tumor cells and nucleic acid ctDNA, circulating tumor cells DNA, and microRNAs and circular RNAs. In protein biomarkers, it is SSC antigen, CIFRA 21-1, and P53 protein. So, circulating tumor DNA cells are the cells that detach from primary tumor and enter the bloodstream. Their presence indicates tumor spread and metastasis. Next, we'll go on to microRNAs. MicroRNAs are small non-coding RNA molecules that regulate gene expression. Specific microRNAs are found to be dysregulated in oral cancer patients. For example, increased levels of certain microRNAs in blood and saliva can act as an early diagnostic markers and indication of tumor aggressiveness. Protein biomarkers such as P53, CIFRA 21-1, and SCC antigen are commonly studied in oral cancer. These markers help in assessing tumor stage, progression, and response to therapy. Now, their role in early detection. So, circulatory biomarkers enable early detection of oral cancer before visible clinical symptoms appear. Liquid biopsy techniques using blood or saliva samples are minimally invasive and patient friendly. This approach improves screening, especially in high risk individuals such as tobacco and alcohol users. So we can see the flow chart in a high risk patient such as a smoker or a alcohol consuming patient. When goes under a liquid biopsy, we can see a biomarker detection. If biomarkers are detected, early tumor identification can be done and treatment according to the diagnosis and better prognosis can be seen in early detection of oral cancers. Next, we'll see about the prognosis. Uh, circulatory biomarkers are useful in predicting prognosis also, and hence good survival outcomes are also seen. Higher levels of ctDNA, PTCs, or specific microRNAs are often associated with poor prognosis and higher recurrence rate. They also help in monitoring treatment response and detecting relapse at an early stage. So when there is elevated circulatory biomarkers like interleukin 6, SCC antigen, ctDNA, and CTC or microRNAs, this indicates tumor in activity, which in turn assessment of tumor aggressiveness is indicated. Such cases prognosis can be predicted as poor, moderate, or good survival rate. Um, so we can monitor a treatment according to the prognosis, and if this can be done, early recurrence rate and relapse also can also be detected in such patients after treatment. Um, Despite their potential, they have their limitations. Before that, I would like to present the values in circulatory biomarker values in oral cancer. Um, Interleukin 6 has its normal value of less than 5 kilogram per milliliter. In case of oral cancer level, it is more than 10 to 50 kilogram per milliliter, which indicates inflammation and tumor cell progression. SCC antigen less than 2 ng per ml, which is normal, considered normal. In case of oral cancer, it is more than 2 to 5 ng per ml. This is a marker for squamous cell carcinoma and prognosis. CIFRA is less than 3.3 ng per nl in normal cases. It
You can
is
go to the next slide.
okay. So I would like to discuss about the limitation and challenges. Limited, despite their potential, circulatory biomarkers have some limitations. These include lack of standardization and high cost of advanced detection techniques and variability among patients. Further, large-scale clinical studies are required to validate their clinical applications.
Thank you, Dr. Shravani. You're Shravani, right?
Yes, sir.
You're an intern, and I appreciate both of you, Dr. Tuba and Dr. Shravani, both of you are interns, and then you have tried to present a paper. But my only request is next time when you present a paper like that, please put your guide teacher's name as co-author. Second thing is you need to also be very sure of what you're speaking because you should practice. If mortality cannot be morality, and you cannot say pilogram for picogram. Ng is nanogram. So identify whatever presentation. So a few slides are there. You should be pakka about it. Okay. All the best, and then it is a good presentation.
Thank you, sir. Thank you so much. I would like to correct my things in the next presentation.
Thank you, Dr. Shravani. Moving on to the next paper presenter, we have Dr. Divya. Dr. Shravani, can you please close your...
Yes, sir. Yes.
Thank you. Dr. Divya?
Yes, sir.
Yeah, please continue with your brief introduction and sharing your slides.
Yes, sir. Is my screen visible, sir?
Yes, they are, ma'am. They are visible.
Yes. Despite advances in imaging, oral cancer is still diagnosed late. What if we could predict malignant transformation before a lesion even becomes visible? Good afternoon, everyone. Today I'll be presenting a futuristic zero radiation imaging concept aimed at predictive oral oncology. That is, neutrino-based oral lesion detection, a subatomic zero radiation imaging concept for future dentistry. Moving on to the introduction. Neutrino-based oral lesion detection is a futuristic zero radiation imaging concept for advanced dental diagnostics. Neutrinos have extremely high penetrative power with minimal interaction with biological tissues. This technique aims for ultra-early detection of oral lesions at molecular as well as cellular levels.
It eliminates the risk associated with conventional ionizing radiations, that is X-rays. With advancement in particle physics, it may revolutionize future dental imaging technology. Moving on to the current imaging modalities in dentistry, these are extraoral and intraoral. Intraoral include periapical, bite wing, and occlusal X-rays, whereas extraoral include panoramic, CBCT, cephalometric, and cyelogram. Moving on to the neutrinos. What are neutrinos? Neutrinos are subatomic and neutrally charged particles. They have extremely small mass, zero radiation potential, weak interaction with the matter, and high penetration power. Moving on to the neutrino imaging modalities, they have extremely weak interaction, that is, interacts only via weak nuclear forces. No electromagnetic interaction due to zero charge. Very small interaction cross-section, that is, collision probability is extremely low. Billions of neutrinos pass through human body without any effect. They have deep tissue penetration, passes through bone and soft tissue easily. Rare detectable collisions is observed. Occasional interaction with atomic nuclei, it may produce secondary particles requiring sensitive detectors. Moving on to the proposed concept, when a controlled low energy neutrino source is applied, neutrino beam directed to oral cavity, neutrinos pass through tissues. Rare neutrino nucleus interactions occur. There is a production of secondary signals through which ultrasensitive detector captures, then digital image reconstruction is done. With this, the oral lesion is detected. Moving on to the advantages over conventional imaging. Zero ionizing radiation, it is safe for repeated imaging and has deep tissue penetration, minimal tissue interaction, and reduced imaging artifacts. Moving on to the challenges and limitations, they have extremely low interaction probability and need for advanced detectors. The large infrastructure and high cost is required, and it is currently theoretical. Moving on to the future scope in dentistry, potential application in pediatric and pregnant patients due to radiation-free nature, and zero radiation imaging for routine dental screening, early detection of oral pre-malignant and malignant lesions, advanced soft tissue visualization without any biological risk, and integration with AI-based image reconstruction system. To conclude, neutrino-based imaging is a zero-ionizing futuristic diagnostic concept in dentistry. It offers theoretical advantages such as deep tissue penetration and biological safety. Major technological and infrastructural limitations currently restrict clinical application. Future research and advancement are required to translate this concept into practical dental imaging. These are my references.
Dr. Divya, you are a postgraduate or an intern?
Sir, undergraduate third years.
Third year, very good. From where?
Sir, STM Dental College, Dharwad.
STM Dharwad.
Yes.
A good presentation. You have put a very futuristic imaging modality. Did you ever check that any field neutrino imaging is used other than medical field?
No, sir. I don't have any ideas.
Okay. And did you find out if there are any machines available with this technology?
Machines are available, sir. Except medical field, I didn't check in any other fields.
Okay. Thank you for the good presentation.
Thank you, sir. Thank you.
Did you prepare for this? Are you presenting it from the department or college or home?
Home, sir.
You have made a nice new curtain behind you.
Thank you, sir.
Okay. Thank you.
Thank you.
Thank you, Dr. Divya, for your presentation.
Thank you so much.
Coming to the next paper presenter, Dr. Shubhangi Dubey.
Yes, sir. Good afternoon, sir.
Good afternoon, ma'am. Dr. Divya, can you? Yeah, thank you, please. Dr. Shubhangi, please continue with your paper presentation.
Is my slide visible? Good afternoon, everyone. I am Shubhangi Dubey, second year PG of Rural Dental College. So the title for my presentation is Salivary Biomarkers as Predictive and Monitoring Tools in OPMDs toward Precision Oral Oncology. As we know, OPMDs are clinical presentations that carry a risk of cancer development in oral cavity, whether a clinically definable precursor lesion or in clinically normal mucosa. Some common OPMDs are leukoplakia, OSMF, oral lichen planus, and erythroplakia. A malignant transformation of these OPMDs is a multi-step process involving genetic, epigenetic, inflammatory, and metabolic alterations that precede clinical and histopathological carcinoma. Conventional diagnostic methods that detect the structural changes but fail to identify early molecular events. So we need some non-invasive biomarkers or methods that are present in saliva containing tumor-derived cytokines, DNA, RNA, proteins, and metabolites that serve as a potential for early detection of cancer. As we know, OSCC accounts for 90% of oral malignancies, and with the highest rate of in Southeast Asian countries such as India, due to widespread use of tobacco, areca nut, and alcohol. The malignant transformations of OPMDs varies according to lesion type, degree of epithelial dysplasia, and associated risk factors, being highest at oral erythroplakia at 30%, OSMF at 18.6, leukoplakia at 15.6, and lichen planus 1.4%. So the pathogenesis as the risk factors, tobacco, areca nut, and alcohol cause chronic inflammation and increase in oxidative stress, cause DNA damage and epigenetic alterations in the molecules. They carry out a oncogenic pathway activation as JK stat, NF kappa B activation, and cause cell proliferation, angiogenesis, and invasion. These lead to metabolic reprogramming and malignant transformation converted to OSCC. The limitations are that, as we know, the gold standard for diagnostic method is incisional biopsy with histopathological examination. But it has some limitations, like it is invasive, painful procedure, and it is not suitable for repeated monitoring. Even sometimes there is patient non-compliance. So we can say that saliva acts as a diagnostic biofluid for OPMD detection. So in OPMD lesion, epithelial dysplasia and molecular changes bring out release of tumor-associated molecules in saliva like cytokines, enzymes, like lactate dehydrogenase, glycoproteins, and genetic markers. So categories of these salivary biomarkers in OPMDs are cytokines like interleukin 6, 8, and TNF alpha, enzyme like lactate dehydrogenase, glycoproteins like sialic acid, microRNAs 21 and 184, metabolites, antioxidants, and proteins. What exactly interleukin 6 does is activates JK stat pathway, which leads to transcription of gene promoting tumor proliferation, survival, and resistance of the apoptosis. Interleukin 8 is the most useful cytokine that promotes angiogenesis, enhances tumor invasion and metastasis, and contributes to the aggressive tumor behavior. TNF alpha maintains chronic inflammatory microenvironment, activates NF kappa B pathway, and promotes tumor progression and cellular survival. Enzymatic biomarker is lactate dehydrogenase, which carries out cellular necrosis, and elevated levels indicates increased glycolysis. That is Warburg effect, in which even in the presence of oxygen, there is production of lactate. Enhanced tumor metabolism. In OPMDs, dysplastic cells undergo metabolic reprogramming, leading to increased LDH release into saliva, which are significantly elevated in OPMDs and OSCC. Genetic and epigenetic alterations occur during the malignant transformation and can be detected in saliva, like microRNAs 21 and 84. These regulate gene expression post-transcriptionally and are useful for early detection and risk prediction. They also show the hypermethylation silences tumor suppressor genes and indicate early malignant transformation. Example: P16, MGMT, and TIMP3. Glycoprotein biomarker, it is one of the most important biomarker which is emerging nowadays, and it is a terminal component of glycoprotein present on the cell membrane and plays a role in cell-to-cell interaction. Its functions are that it regulates cell adhesion, facilitates tumor invasion and metastasis, and modulates immune responses. In OPMDs, altered glycosylation and increased membrane turnover lead to elevated salivary salicylic acid levels, and it is very important. With this, we can see that it correlates with the disease progression, and it has very high specificity and sensitivity. Metabolomic biomarkers are mainly increased lactate and decreased amino acid in protein, kallikrein, and MMP. These include extracellular matrix degradation and tumor invasion metastasis. Role in detection and risk assessment. Generally, these biomarkers enable early molecular detection before clinical malignancy or becomes even evident. They help in early detection, identification of high-risk dysplastic lesions, detection of malignant transformation, differentiation between benign and malignant lesions. So the role in clinical management is monitoring the disease progression, assessing the treatment response, predicting the risk of malignant transformation, and clinical decision-making guide. So advantages of these salivary biomarkers are that it is non-invasive, cost-effective, easy sample collection method, real-time monitoring, and the high patient compliance. The easiest and the most convenient best method for salivary biomarkers collection is dueling method by saliva. Limitations that it lacks standardized biomarker panels, variability in biomarkers levels, limited large-scale validation studies, and need for further trials. So it is important to develop more biomarker panels. Point of care diagnostic devices should be developed, integration with AI, and precision and personalized oral cancer management. To conclude, salivary biomarkers provide a reliable, non-invasive tool for early detection and risk assessment of OFPMDs. Inflammatory, metabolic, genetic, and epigenetic alterations in saliva reflect ongoing malignant transformation. These biomarkers levels correlate with the severity of the dysplasia and tumor progression. So, saliva offers promising application in screening, monitoring, and personalized management towards patient prognosis. These are my references.
Thank you, Dr. Shubhangi Dubey, for giving a review on potential biomarkers at all levels, including an emphasis on saliva. If saliva emerges as with the so-called advent of standardized panel of biomarkers, that will be the best thing to happen, because that's the most non-invasive way by which you can identify markers in a cancer patient or a patient who's in the disease stage of oral potentially malignant disorders.
Yes.
Thank you, doctor, for the presentation.
Thank you, Dr. Shubhangi. Now coming on to the next paper presenter, we have Aishwarya Kadam.
Yes, sir. So my topic is platelet-rich concentrates, a novel biological-driven therapeutic approach in the management of the oral potential malignant disorders. Oral cancer is a critical health issue due to its life-threatening potential. WHO has anticipated a rise in the incidence of the oral cancer in the coming decades. Oral cancer does not develop abruptly. It evolves through identifiable pre-malignant stages, making early diagnosis of these pre-malignant stages crucially and in preventing malignant transformation. So what are OPMDs? That carries a risk of the cancer development either within the lesion itself or elsewhere in the oral cavity. European physicians originally introduced OPMDs in 1805
So the common example of OPMDs are leukoplakia, erythroplakia, OSMF, and oral lichen planus. This is a progression chart from normal mucosa to the hyperplasia, to the dysplasia, to carcinoma in situ, and that leads to oral cancer. So etiological, the factor that causes the OPMDs are tobacco, alcohol, uh, cigarettes, HPV, diet, oral health, immunity, UV exposures, genetics. The inner circle indicates the types of the OPMDs that leads. The standard management of OPMDs are habit cessation, nutritional supplementation, chemo prevention, like antioxidant, corticosteroid therapy, antifibrotics, immunomodulators, and the surgical excision, laser ablation, cryosurgery, electrocautery, and long-term follow-up needed. Why platelet rich concentrate? Because some OPMDs are recurrent, some OPMDs are refractory to the corticosteroid, and some of them causes fibrosis after the surgery. Long-term use of the corticosteroid give rise to the secondary lesion like candidiasis. What are the platelet rich concentrates? It is derived from the patient's own blood and holds activated platelets in the fibrin matrix. Its regeneration role has increased popularity in dentistry since 1998. Its cell proliferation and differentiation are possible due to its release of cytokines and growth factors such as platelet derived growth factor, vascular endothelial growth factor, and transforming beta factor. The platelet content platelet above their baseline concentrates and aids in the tissue repair by regulating cellular event and angiogenesis. The platelet rich concentrates are classified in PRP and PRF. The PRP is differentiated from PRF by, like in PRP, we do, it is the first generation and it is rapid in process. It shows immediate growth burst and it needs anticoagulant before the centrifusion and it need activator after the centrifusion. But PRF is totally natural process, it doesn't need any ingredient, and it's a slow sustained process. After that it is divided into LPRP, PRP, PRF, and LPRF. Now L is the leukocyte rich and P is the leukocyte poor. L we get after the after a single centrifusion cycle with a high force, and in that the buffy coat layer is formed that is rich in leukocyte, and in leukocyte poor, that is P, we get no buffy coat layer and we have to centrifuge twice for it. Then the main composition difference is PRF contains growth factors, leukocyte, fibrin matrix, mesenchymal stem cells, and platelets that are 10 times higher than the normal. And in PRP, we have platelets 4 to 8 times higher than the normal, and it contains only growth factors primarily. So the general application is wound healing, knee arthrosis, disc degeneration disease, skin rejuvenation, and cyclopecia. In application for dental uses, it is used for oral lesions, sinus elevation, extraction, socket management, wound regeneration, and improving the attachment loss. The clinical relevance in OPMDs, IPRF is mostly used in OLP and OSMF. LPRF is mostly used after the surgical excision of leukoplakia and erythroplakia. PRP is less oftenly used due to its need for the anticoagulant and rapid growth factor release. The mechanism is PRC contain the growth factor that activates the cell proliferation, angiogenesis, and it also contains antibacterial properties. How it is prepared: the blood is withdrawn from the cuboidal fossa, then it is forwarded to the centrifusion process, and there are various of the centrifusion process, and according to that the PRP and PRF types are divided. These are the short summary of the studies in which the article has shown different types of OPMDs treated with the platelet-rich concentrates, and all of these have given the positive results. So the limitation of platelet-rich concentrates in OPMDs are lack of standardization preparation protocol, technique-sensitive procedures, equipment is required in this, not always superior to the corticosteroids, limited evidence for direct lesion treatment. The future scope of PRC in the OPMDs are the standardization of the PRC protocol, multicentric RCTs, and long-term follow-up studies are required. Direct lesion treatment instead of only post-excision application, and composition therapy, combining therapy with PRF and biomaterials. Conclusion, the PRF shows promising regenerative and anti-inflammatory effects in the management of OPMDs. It demonstrates the comparable efficacy to the corticosteroid in the management of OLP and OSMF. Enhanced wound healing after the surgical excision in the leukoplakia and erythroplakia, reduced pain and recurrent rates. Although not yet a standard, PRC is emerging as a safe biological active and regenerative alternative in the management of the oral potential malignant disorder. I would like to end with this quote: autologous biology today may shape the standard of care tomorrow. These are my references. Thank you.
Thank you, Dr. Aishwarya, for the presentation. What are you? None of you are actually introducing yourselves. You're a postgraduate, you're undergraduate.
I am a first year postgraduate student from Department of Oral Medicine and Radiology from the college Rural Dental, Pravra Institute Medicine.
Pravra, okay. Thank you.
Thank you,
Good
sir.
presentation.
Thank you, sir.
Thank you, Dr. Aishwarya. Now moving on to the next paper presenter, Dr. Shivani. Dr. Shivani?
Dr. Aishwarya should remove her screen sharing.
Dr. Shivani? She is present in the meeting, but
Good afternoon, sir.
yeah, good afternoon. Dr. Shivani, I request you to start with your brief introduction, moving on to the paper presentation. Okay, thank you.
Good afternoon, sir. So myself, Dr. Shivani Nasai, first year MDS student from Department of Oral Medicine and Radiology from College Rural Dental College, Loni. Today, I'm presenting a review titled Contemporary Non-Surgical Management Strategies for Oral Potentially Malignant Disorders. So OPMDs, they represent as a window of opportunity where early intervention of these lesions can prevent the malignant transformation. So for the next few minutes, I'll be briefly discussing about the strategies which can be used for early detection of these lesions, early detection and intervention of these lesions. So oral potentially malignant disorders and oral squamous cell carcinomas, they represent a significant global health burden due to challenges which are associated with their diagnosis and treatment planning. OPMDs, they are characterized by the tissue changes that are more likely to transform into oral cancer than the normal tissues. The most common type of oral cancer is oral squamous cell carcinoma and makes about 90% of the oral tumors, malignant tumors of the oral cavity. Not all the OPMDs are going to be transformed into oral cancer, but it is estimated that 7% of the time they are preceded by this type of lesions. So the OPMDs, they are the spectrum of precancerous lesion. They include oral leukoplakia, erythroplakia, lichen planus, oral submucous fibrosis, actinic cheilitis, and which precede the clinical manifestation of OSCCs. So the traditional treatment approaches which has been used are topical or systemic retinoids, adenovirus containing mouthwashes, photodynamic therapy, surgeries along with chemotherapy if needed. But due to the malignant transformation rate and high recurrence rate, non-surgical management has got tremendous attention in last few years. So why non-surgical management? Because high recurrence rates after surgical excision of oral leukoplakia, 5 years survival of OSCC remains almost about 50%. Surgery, radiotherapy, and chemotherapy, it impacts the quality of life of the patient, and there are growing evidences supporting the chemo prevention and pharmacological modulation. So the contemporary non-surgical management included chemopreventive agents, nutritional intervention and topical formulation, laser ablations, regular follow-up and surveillance, habit cessation, and lifestyle modification, with the cornerstone still remaining chemopreventive agents. So the what is chemopreventive agents? Basically, they are the natural or synthetic compounds which are applied topically or systemically, or which can be used to preclude the advancement or genesis of oral cancer. There are phases of chemoprevention where there is primary phase of chemoprevention where it focuses on the healthy individuals with the high probability of developing cancer. Secondary, where it targets the individual with established premalignancies. Tertiary, where it aims to prevent the reoccurrence and emergence of these tumors which has been previously diagnosed and treated for cancer. So how does chemoprevention work? At the initiation stage, it blocks the DNA damage, whereas at the tumor promotion and progression stage, it can reverse or suppress the proliferation of these premalignant cells. So these are the charts which are briefly describing the chemopreventive agents which has been used for the OPMDs, which include certain antioxidants such as beta carotene, vitamin A, or retinoids, vitamin E, which has been used systemically or topically for the longer period of time, out of which the retinoids has been used as a potent antioxidant which normalizes the differentiation of the cells, inhibit the proliferation, and promote the apoptosis, but can be limited due to the systemic toxicity. There are some natural compounds which includes lycopene, curcumin, which is a turmeric extract, green tea polyphenols, and resveratrols, which can be used for the longer run safely, but can be limited due to their bioavailability. There are drugs which are targeting certain molecular agents such as ginseng-ping, erlitonib, which targets EGFR pathway, Baumannburg inhibitor, and COX-2 inhibitor, oxyzolpeptide mouthwash, which targets certain molecular agent to prevent the further proliferation of oncogenic cells. Then there are certain compounds which are used as a topical agents to increase the bioavailability, such as dried black raspberry gel and bleomycin. And then chemopreventive agents which are loaded on the nanoparticles. There are some studies which has shown the effects of these chemopreventive agents which are loaded onto the nanoparticles such as mucoadhesive gels, which improves the mucosal penetration and cellular uptake, which increases the apoptosis and reduces the tumor cell viability. So it enhances the efficacy of the traditional chemopreventive agent, but large scale clinical validation is still required. The laser ablation has emerged as an advanced modality in management of OPMDs, particularly leukoplakia and oral lichen planus. There are some lasers which has been used for this. It is advantageous over conventional scalpel surgery due to its precise removal of dysplastic epithelium, excellent hemostasis. It reduces the intraoperative bleeding and improves the wound healing, but is limited due to destruction of excised tissue, which may compromise detailed histopathological evaluation. These are the charts which are showing the contemporary non-surgical management of OSMF. In cases of OSMF, the antioxidant and micronutrient plays a supportive role, though fibrosis reversal remains challenging. In cases of oral leukoplakia, the antioxidant, retinoids, and laser therapy shows the lesion regression, but reoccurrence rate persists. In case of oral lichen planus, the first line treatment still remains topical corticosteroids. Low level laser therapy and antioxidants are effective alternatives for the corticosteroids, which are in the selected cases. So the key result after this review, where the vitamins, carotenoids, and phytochemicals show the partial to complete regression in many of the studies. Antioxidants, they reduce the lesion size, dysplasia, and oxidative stress. Retinoids show the good efficacy, but in longer run can show the systemic side effects. The natural agents are safer for prolonged use, but their bioavailability is comparatively low. So non-surgical chemoprevention is effective as an adjunct, but reoccurrence risk remains, requiring ongoing follow-up. Low-level laser therapy is an effective alternative to corticosteroids in the OPMD cases. So to conclude, the chemoprevention represent a promising non-invasive strategy for managing most of the OPMDs and preventing their malignant transformation rate. but combined with the lifestyle modification, habituation, and regular monitoring can enhance the long-term outcome. So in the future, the large-scale randomized clinical trials are needed. So to establish the standardized dosage and duration for the chemopreventive agents, the exploration of combined or synergistic formulas, for example, antioxidant blends, could enhance the clinical efficacy. Integration of biomarker-based risk assessment may help personalize the chemopreventive therapy for high-risk patient. So this is the QR code for my references which I have used for this review. Thank you for the patient listening.
Thank you, Dr. Shivani Mursale, for elaborating and giving a review of all chemopreventive agents and the other non-invasive management procedures for OPMDs. Thank you. We may go to the next presenter.
Thank you, Dr. Shivani. Now I would like to invite Dr. Alicia to
Yes,
present.
sir. Yes, sir.
Please introduce yourself and continue with your presentation. Please kindly
Yeah.
share your slides also.
Yeah, good afternoon to all. I'm Alicia, a final year UG student from STM Dental College. As we know, the dangers of tobacco and its deadly effects, which is spreading like an epidemic, runs a major concern for the public to know about it. The fight against this silent, outrageous mass killer is the need for the hour, as it is a major threat to health and healthy living. When you light a cigarette, your life burns with it. It is these thoughts which have paved the way for my study depicted in the paper titled. Moving forward, India being the second largest consumer of tobacco in the world, along with the highest number of oral cancer cases, contributes nearly 1.35 million deaths every year. In spite of all tobacco prevention and cessation programs in India, it's yet far from achieving the goal of tobacco free India. It is in this juncture that the role of an oral physician becomes inevitable. Moving on to why is the need for study? According to Demographic Health Survey, known as National Family Health Survey, reported in the year 2019 to 2020, the prevalence use of tobacco in males was found to be 27.1% and 8.5% in females of Karnataka. As oral cavity acts as a mirror to overall health, oral mucosal lesions can be predecessor to malignancy. What was the aim of the study? It was to evaluate the prevalence of tobacco-associated mucosal lesions, both malignant and pre-malignant, its association with the type, frequency, and duration of tobacco use in patients who visited a dental hospital and the various symptoms experienced by them. Study participants were the patients who visited our college from December till Jan were included in this. They total 54 participants were there, 47 out of them were male and 7 were females. It was a cross-sectional study. Studied variables included personal details, age, sex, economic status. In evaluation of habits, we had a number, tobacco use might be single, multiple, smoking or smokeless, duration and frequency. The signs and symptoms noticed were burning sensation, difficulty in opening mouth, reduced salivation, dysgeusia, halitosis, bleeding and ulcers. Lesions associated were tobacco-induced lichen reactions, Cheever's mucosa, tobacco pouch keratosis, leukoplakia, lichen planus, OSMF, and malignancies. Moving forward to materials and method, data collected were the patients aged more than 15 or 15 years who currently smoked, chewed tobacco, consumed alcohol, or a combination of these habits for a minimum of 12 months and had any lesions on examination entered into the study. First, we had routine examination followed with detailed habit history, then recording of associated symptoms, and if there is a presence of lesions, we would measurement of the lesion, and then we had a habit counseling. Then we used data was analyzed by using SPSS software, and it was a descriptive analysis. Moving on to the result, we found that 26 of the patients used conventional method, that was use of betel quid, and 23 patients used conventional along with pan masala with gutka. Retaining quid in the mouth increases the chances of oral mucosal lesions. In associated symptoms, we found that burning mouth sensation was the highest noted symptom, that was 31 of them, followed by difficulty in mouth opening, followed by decreased salivation, pain, ulcers, and halitosis. In the result of associated Most common lesion present were highest was OSMF, followed by Chewers mucosa, then with leukoplakia and malignancies. Moving on to discussion, tobacco usage pattern in India varies significantly by location and culture. The prevalence of adverse effect was found to be much higher in males as compared to females. Illiterate or less education shows the lack of awareness, harmful effects of consumption of tobacco products. As income was low, they tend to compromise on healthy and nutritious diet, as these groups of people will be more prone of developing mucosal lesions. As men with occupations such as laborer, daily wages, tea stall, shopkeepers, etc., need substantial amount of energy to do work, and they tend to chew tobacco. In the present study, the most prevalent lesion was found to be OSMF, which was similar with the Prashant B. et al. Study, and the buccal mucosa was the most affected side of the lesion, which was similar to Archana Yadav et al. Study. Burning mouth sensation was the most prevalent symptom. We found that most of the subjects were devoid of any symptoms. To conclude, I would emphasize on this result of this study provide further evidence that there is a critical need for tobacco cessation, along with clinical interventions with awareness programs regarding harmful effects of tobacco use, screening and early detection in population are at the risk of mandatory to decrease morbidity and mortality rates of oral cancer. Educational programs should be conducted by health professionals with implications of dentists, Anganwadi workers, and allied medical science professionals who can be trained for dental treatments. This study is concluded with the hope that the results from this study will act as a foundation for state-based tobacco research, along with statewide screening program for detection and treatment of several tobacco-associated oral mucosal lesions. These were my references, and thank you.
Thank you, Dr. Naruna. And
Yes, sir.
you're not a doctor, of course, you're a final year student.
Yeah.
Appreciate your presentation. And is the study done by you, or is it done in accordance with your tobacco?
No, sir, it's a study done by me, sir.
Okay, very good. So continue and follow up these patients. Probably once you get into a post-graduation, you can continue it as a dissertation topic.
Yeah, sure, sir. Thank you.
Thank you. Now coming on to the next paper presenter, Dr. Pratik Parkarwar. I request them to. Good afternoon, Dr. Pratik.
Good afternoon, sir.
Good afternoon.
After this, how many more presentations are there?
Just two more.
Okay.
Two, including this one.
Myself, Dr. Pratik Parkarwar, PhD scholar from the Department of Oral Medicine from CSMS Dental College, Aurangabad, Sambhajinagar. The title of my presentation is The Review of Matrix Rhythm Therapy in the Treatment of Oral Submucous Fibrosis. Coming to the introduction, oral submucous fibrosis is an irreversible, predominantly potentially malignant disorder affecting the Indian population. It is a chronic progressive disorder which involves the oral mucosa and the pharynx and upper third of the esophagus. This is the classification mostly accepted by authors given by J.J. Pindberg. It is a irreversible, predominant potentially malignant disorder affecting the oral population. This condition is mostly found in the Indian subcontinent.
Dr. Pratik, your voice is actually echoing. Have you joined in with more than one devices?
Yes, sir.
Oh, if it is not important, I'd request you to exit the Zoom meeting from one of them so that your voice doesn't echo.
Yes, sir, I have left.
Yeah, thank you. Thank you. Please continue.
It was first invented in India by Joshi in 1953. It is one of the poorly understood disease and unsatisfactorily completed treated disease in India. The risk of malignant transformation of this disease is 3 to 6%. The primary etiological factor of this disease is areca nut, which is caused by the arecolin, chemical arecolin. The initial presentation of OSMF which is followed by hypervascularity, which causes blanching of the oral mucosa, which give like marble stone-like appearance. Blanching may be localized or generalized. In some cases, vesicle may develop and may rupture from erosion. Later in the stages, the disease shows fibrous band and there is restriction in the mouth opening, which is known as trismus. Trismus may causes difficulty in maintaining oral hygiene, speech, mastication, and swallowing. Medical management is a long-term therapy, so patient take the drug or sometimes take the drug irregularly, so the symptoms are reduced and the treatment remain incomplete, and the symptoms may recur after few months. Hence, non-invasive treatment therapy is the alternative option, which includes physiotherapy. It is non-invasive technique which includes ultrasound therapy, matrix therapy, low-level laser therapy, active physiotherapy exercises, and massage. The new physiotherapeutic approach, which is called as matrix therapy, is used in the treatment of oral submucous fibrosis patient. In this therapy, the principal work with the frequency of 8 to 12 hertz, which maintain the physiological function of the body. In matrix rhythm therapy restores good tissue resonance and the vibration produced by the instrument, which improves the venous and lymphatic circulation. This device produces oscillation with the frequency that is similar to the cellular oscillation and utilized for the therapeutic purpose in various musculoskeletal disorders and oral lesions. Coming to the history of it, in 1943, Dr. Herbert Rocha discovered that muscle constantly vibrate day and night with the frequency of 7 to 13 hertz, which is similar to brain alpha waves. The matrix rhythm concept was introduced in 1996, and matrix rhythm therapy was invented by Dr. Eugen Rogel in German. Later on, he invented the device called matrix roll, which was previously used. Then in India in 2009, matrix rhythm therapy was launched. This is the matrix machine with the applicator. Coming to the procedure, the patient is asked to lie down with supine position with head facing upward. Talcum powder was used as a medium to reduce friction between the skin and the oscillator. Matrix therapy was starting from the cervical region, spine, scalp, TMJ, and cheek region bilaterally. Treatment consists of 45 to 50 minutes, which is called as one session, which is given for 1 week, and the patient is recalled for second session after 1 week. It is a mechanism that when the matrix therapy is given, it causes physiological rhythmic oscillation of 18 and 17 hertz, which causes improvement in the microcirculation and oxygen supply, which leads to increase in the ATP production, repolarization, and relaxation of the tissue. This is a OSMF treated case in which one session of MRT is given. In second case, two session of MRT is given in grade 3 OSMF, and in third case, one session of MRT is given in grade 2 OSMF patient. These are the two studies done by Varun Naik et al. In 2020 and Ashwini et al. In 2021, which shows there is improvement in the mouth opening after the matrix therapy. Matrix therapy is also used in plantar facilities, lower back pain, and Bell's palsy. Now coming to the conclusion, matrix rhythm therapy is a modern technique in which mechanical vibration penetrates deep into the tissue. It also increases the peripheral blood flow. It is relatively new progress in the stream of physical therapy, which aids in the improvement performance in the range of motion and scar reduction. It is a new equipment which reduces pain to the patient without any side effects or medication. In brief, it is found that MRT is effective, which exists as a new development in the stream of physiotherapy and dentistry. MRT is a recent tool in rehabilitation, which is used in such conditions like chronic back and neck pain, frozen shoulder, stroke, plantar fasciitis, Bell's palsy, trigeminal neuralgia, deep foot ulcer, oral submucous fibrosis, lymphedema, and burn. These are my references. Thank you.
Thank you. Dr. Pratik, thank you for elaborating on matrix rhythm therapy. It's a vibratory physiotherapy, as you understand. I'm sure it will be a useful adjunct in patients who've got restricted mouth opening, which is not really trismus. Trismus is basically because of muscle contraction. So when you say trismus, we mean especially in infections, etc. We can call it as restricted mouth opening and submucous fibrosis due to fibrosis.
Yes.
Thank you for your study and good presentation. Thank you.
Thank you, sir.
Thanks, Dr. Patti.
Thank you, sir.
Yeah. So we are moving to our next presenter, Dr. Priyanka Lasune. Dr. Priyanka, could you please unmute yourself and share your slide?
Yes, sir.
I think you joined with some other device as well. Could you please share your slide, Dr. Priyanka?
Jane, she's not there.
Yes, sir. I will share.
Okay, come on, doctor. You can share your screen and your.
Very good afternoon to everyone. Myself, Dr. Priyanka, senior lecturer at MIDSR Dental College, Latur. Today, I'm going to present a study of crystallization test as a screening aid for oral malignancy. These are the content of my study. As we know, the cancer is 8th most common cancer in worldwide, and it is a major threat to public health in developed countries and in developing countries. In India, oral cancer is leading cancer in males and females, and it is the major risk factor for developing oral cancer includes oral tobacco smoking. The oral cancer remains a significant cause for mortality and morbidity with unaltered 5-year survival rate, and this survival rate can be improved if it is treated, detected, diagnosed at the early stage. There are growing demand in the recent years towards developing new non-invasive technique in early detection of oral cancer. Although there are many methods available for early detection, the need of R is the test ought to be simple, economic, reliable, and less time consuming and less invasive. As we have seen in the literature, the Prefers et al. Introduced a technique for detection of cancer by observing a crystal pattern of cupric chloride on admixed with blood of cancer patient. Even the Gruner et al. Has emphasized the role of colloidal protein in diluted form of blood, contributing to different forms of crystallization pattern forms with cupric chloride. So, thus the study has aim carried out with the aim to determine the efficacy of crystallization test as a screening aid for oral malignancy in smokers and non-smokers. These are the armament used. Coming to methodology, the patient who are visiting to oral medicine department, satisfying with inclusive criteria were included. The detailed case history was recorded and informed consent was obtained. The study was carried out in 50 healthy and 50 smoker patient, age group between 17 to 18, and the blood sample was collected from the patient by venipuncture with the usual aseptic precaution. The drop of blood from smoker patient and non-smoker patient was allowed to fall on the special filter paper at approximately 1 centimeter in the diameter, and the part of filter paper after drying it is diluted in the distilled water, and then these 4 drops of this blood solution was poured in the cupric chloride solution and placed in incubator for 12 to 12 hours. Coming to the inclusion criteria, the patient age between 17 to 65, smokers without having any clinical lesions, and the smokers smoked at least 2 to 4 cigarettes per day more than 3 years were selected. The subject exhibiting following condition or the habit were not included in the study. Known cases of acute and chronic systemic diseases, psychological disorders, salivary gland disorders, and the patient who has diagnosed with pre-malignant lesions and conditions. The statistical analysis was done with ESPSS version 21, and pair T test was used to compare the crystallization pattern in smokers and non-smokers. Coming to the results, the different patterns of crystallization form were observed in our study. Now, the figure 1 showing the meshy or muddy form and in the cupric chloride solution alone, and this figure 2 showing the crystallization pattern form in the healthy patient, and in figure 3 the crystallization pattern was formed in the patient who are prone for malignancy. So this table shows the patient who smokes cigarettes more than 16 to 20 cigarettes per day are positive, but the significant result were the result are not significant. In this table, we can see the comparison has happened between the duration of smoking and oral malignancy, in which the patient who smoke more than 10 to 30 are more prone or positive, but the result are non-significant. And even in this
table, we have seen the age group between 21 to 60 and the elder age group are more positive for oral malignancy as compared to the younger age group. And statistical, the significance is not, the result are not significant. But when the comparison done between control and study group, the results were significant. So this shows the crystal pattern are not influenced by age group or the number of the cigarettes and duration of the smoking. But the whole, there was a significant increase in crystallization pattern in study and control group. So this shows that this pattern in this study can be used to assess the risk factor for oral cancer in smokers. Coming to the discussion, why this crystal pattern has occurred is because the biological changes occurring in the blood bring about the change in molecular forces which governs the integrity of molecular structure, and which act as to maintain the cohesive molecule in the crystal pattern, so which is responsible for peculiar pattern formation. In the present study, the crystallization pattern from cupric chloride solution was found irregular, scattered, radiating, with overlapping crystals along with the brushy appearance. The same result were obtained in the study performed by Vijay Ingre in 2022 and Saprath William Surodi and Grishma Rawat in their study. The pattern of crystallization in the control and non-control group was the same pattern was found in the Bali et al.'s Rawat and Sachin Sarode in their studies. Crystallization pattern in malignancy of smoker patient shows the characteristic pattern of transverse bar in the related to radiating crystals of the basic pattern. And numerous such a transverse bar also shown in the study conducted by Vijay Ingve in 2022 by Bali et al. In 2018 and Ratna Kumari in 2017 in their study. In the present study, the 47 patients were positive and 4 were negative for crystallization test in the study group. The sensitivity and specificity of the crystallization test in the screening of oral malignancy is were found to be 88 and 96% respectively. The study conducted by Ratna Kumari in 2018 among 30 pre-malignant patients, 25 were positive and 5 were negative for crystallization test, and the sensitivity and specificity of crystallization test in the screening of oral malignancy found to be 83% and 86% respectively. Sensitivity and specificity of the test of oral cancer in Ratnakumari's study were 96 and 86% respectively. In Sarode et al. Study was 96% and 96% specificity respectively. In Bali et al. Study, according to the statistical evidence, the 90% is sensitivity and 99% specificity was found.
Go to
In
your
the
conclusion, doctor.
This study is concluded with the crystallization pattern is interesting, valuable, economic, and quick method for early detection of oral cancer. It is economically cheap and readily available, so it can be used as a mass screening. This test has a great value where the lesion is inaccessible for the routine biopsy and other procedure. These are my references. Thank you.
Thank you. It seems to be an alternative to other clinical dye staining, etc. So maybe, if they are willing to give us a few drops of blood, this can be a very vital screening method in larger populations.
Yes, sir.
Thank you for your presentation.
Thank you, sir.
So with this, Dr. Priyanka's presentation, we are done with this paper presentation competition, Dr. Gopa Kumar. And we are very privileged that you have,
Thank you.
really assessed them very well.
It is quite a pleasure to listen to postgraduates, PhD fellows, and then even faculty as senior as professors in one forum. And I was encouraged by the fact that some of the undergraduate students also took part very well. A special appreciation for their teachers and guides who have actually brought them also into the forefront in presentation. So I'm sure they will get a certificate of an international conference, that being the case. And it's not a competition. Basically, they will all learn from each other, because one platform like this gives a method by which you can take good points from others' presentations, and then they will grow in confidence. And many of them had very good studies presented. So it is a pleasure for mine to be a part of this entire process. Thank you for giving this opportunity.
Thanks, Dr. Gopakumar. Thanks. We are privileged as such a senior academician, because for a judge, for judging the students and the senior faculties, we are looking for a senior academician, and you're fortunate that you are available today. And
Yeah, I was not judging; I was enjoying their presentation.
yes, yeah. Okay, thanks. Yeah. So with this, presentation, we are moving to our speakers, sessions. Dr. Priti Jain is supposed to join now, but she is not able to join, some connectivity issue. So I am requesting Dr. Sujata. She is in a meeting room. Dr. Sujata, could you please share your slide and start your presentation?
Yeah, sure. I think you can see my slides.
No, yet to. Yeah, your slides are visible.
Okay. So I think post-lunch it is difficult to listen to the lectures, but I'll still try to make you people awake with my presentation. And this is related to the artificial intelligence-driven advances in the diagnosis and the management of oral potentially malignant disorders as an interprofessional collaborative approach. Myself, Dr. Sujata Bahati, professor, currently working in the Department of Oral Medicine and Radiology and in charge of Tobacco Cessation Cell at Maratha Mandirs Nataji Rao G. Halgekar Institute of Dental Sciences and Research Center, Belgaum. And currently I'm pursuing my fellowship from FAMER Mahe Philippi for the batch of 2025. So talking about my topic, and I have done a small short pilot study and taking a group of third year students and final year interns. I just would like to talk about what exactly I have done. So when you look into the artificial intelligence in oral medicine, it bridges the gap between innovation and practice. This pilot study on the readiness of dental workforce to adopt artificial intelligence for the oral potentially malignant disorders for the diagnosis purpose. So when you look into the clinical challenge, early detection is like a bottleneck. Oral potentially malignant disorders carry the life-threatening risk, but current manual detection methods struggle with the consistency and early stratification. So whenever we have the variable in the transformation risk, early detection and the stratification play a very important role. So the promise of artificial intelligence in diagnostic precision, it comes with a consistency which reduces inter-observer variability and data integration, which synthesizes multifactorial clinical data and efficiency, where we can see the streamlining of the diagnostic workflows. When you look into the availability of these AI-based histopathological platforms, we have Path AI, Roche, UPath, Procia, Page, and Ibex. When you look into the cost of these AIs, which are available for histopathological diagnosis, ranges from 5,000 to 5 crores. When you look into the clinical softwares, which are able to make us understand the clinical manifestation more in a better way, that includes Vericare, Cara Oral AI, Arogya Arohan, Muskan AI, AI radiographic suites, and Dental AI SaaS platforms. These softwares are available from 10,000 to almost around 50,000 rupees. When you look into the oral potentially malignant disorders, these constitutes a significant public health concern due to their variable risk of malignant transformation and the challenges associated with the early detection and the risk stratification. When you look into the recent advances in the artificial intelligence, particularly the machine learning and the deep learning techniques, have demonstrated promising applications in the diagnosis and the management of oral potentially malignant disorders. However, effective and ethical integration of AI into the clinical practice requires coordinated interprofessional collaboration. So for this, I took a sample of 68 responses taken for the study, and which is a questionnaire study basically, and the 30 questions were being introduced in the form of a Google form. The responses were collected and subjected for the statistical analysis. The contemporary evidence indicates that AI-based models can assist in automated analysis of clinical images, histopathological grading of epithelial dysplasia, risk prediction of malignant transformation, and the longitudinal monitoring of the lesion progression as such. These systems integrate multimodal data, including clinical, radiographic, histopathological, and the behavioral risk factors. Interprofessional collaboration among the oral medicine specialists, oral pathologists, oral radiologists, data scientists, public health professionals, and the behavior experts is essential to the development, validation, and the implementation of such AI tools. AI represents a powerful adjunct in the diagnosis and the management of oral potentially malignant disorders. However, its successful translation into the clinical practice depends on the structured interprofessional collaboration. Integrating AI with the team-based core models can enhance diagnostic precision, promote the patient-centered decision-making, and support the responsible innovations in the oral healthcare. AI-assisted diagnostic systems have shown improved accuracy, consistency, and efficacy compared with the conventional methods, with the potential to enhance early detection and the personalized management of oral potentially malignant disorders. Additionally, collaborative interprofessional frameworks facilitate shared decision-making, reduce the professional silos, and ensure ethical governance and data integrity and the clinical relevance of AI applications. So when we look into the educational implications of modernizing the curriculum, integrating, embedding this AI competency modules into the undergraduate curriculum, and which will act as a simulate, launching the interprofessional simulation-based training at the same time validation, which ensures the student exposure to validated diagnostic platforms. Looking into the clinical implications, which provides a patient data in detail, and we have an artificial intelligence risk stratification and the personalized management plan, which enhances early detection and the shared decision making. The present study evaluated the knowledge, attitudes, and the practices related to artificial intelligence driven diagnosis and the management of oral potentially malignant disorders within interprofessional collaborative framework among the dental students and the interns. The finding provides an important insights into the readiness of the future oral healthcare professionals to adopt AI-assisted diagnostic approaches and align with emerging global evidence on AI integration in oral oncology. This study, which included 68 undergraduate dental students which completed the survey, the sample comprised both the male and the female participants across third year BDS, final year, and also interns, indicating representation from mid and the late clinical training stages. So this is a graphical representation which mentions about 35% of the students were in the age of 22 years. This is the highest age group what we could see. At the same time, the participants, when we look into, the females were highly participated in the study group compared to that of the males. And when we look into the year of the participants, 57% of them were from the third years and the rest of them were from the final years and the interns. When we asked about the prior exposure to the AI in the dentistry, 55% of them told that they were not having any exposure, whereas 44% of them told they had some other form of exposure to the AI. This shows that there was no significant differences emerged in the knowledge scores by the gender, and which mentions about the p-value being less than 0.316 or 0.800, where the year of study, which also mentions of the p-value, which is being less than 0.421. Or the prior AI exposure, which mentions about the p-value being 0.857, which is consistent with the Indian surveys, showing the uniform baseline AI awareness across the demographics despite varying exposure. So this is a level of knowledge which has been depicted on the graphical representation and also mentions about the attitude among the students. When we wanted to know about the knowledge related to the AI, more than 75% of the students had a very good knowledge related to the AI which are used in dentistry related to the clinical examination. At the same time, when we wanted to look into the attitude of the students, it was at the moderate level and almost equivalent to 73.53%. Overall, the findings demonstrate high knowledge levels but predominantly moderate attitudes, highlighting the gap between cognitive awareness and the practical readiness for artificial intelligence integration in the oral potentially malignant care. So, when we look into the knowledge, more than 75% of them gave the correct responses, prevailed in 76.47 students with more than 80% accuracy in 4 items like oral potentially malignant disorder definitions with 91.18% and dysplasia diagnosis with 91.18% and interprofessional roles with 92.65%. This exceeds and averages from the systematic reviews and also aligns with the European final year students' proficiency in AI oral potentially malignant disorder diagnostics through gaps persist in identifying the specific oral potentially malignant disorders. Such strengths likely stem from the curriculum emphasis on the oral pathology, mirroring Indian studies where more than 90% recognize AI's potential for the soft tissue lesions. So the substantial proportion of the participants correctly identify the fundamental concepts which are related to the oral potentially malignant disorders and AI-assisted diagnostics with more than 80% accuracy across most knowledge items. Notably, 91.18% recognize the definition of oral potentially malignant disorders and the gold standard for the dysplastic diagnosis, reflecting the adequate foundational training in oral pathology. These results consistent with the prior studies reporting that dental students possess the sound theoretical awareness of oral potentially malignant disorders, but also demonstrate variable competency in the advanced diagnostic technology. For instance, Shwajiki et al. Also reported that dental trainees exhibit a good conceptual knowledge about AI applications in the diagnostics, yet often lack a deeper technical understanding of the algorithm functioning and the validation process. Similarly, another study which was conducted shows that high recognition of AI's role in the oral diagnosticians aligns with the findings by the Kangar et al. And who also observed that dental students show the favorable knowledge about AI-supported image analysis and the lesion detection, but remain uncertain regarding the clinical deployment. High awareness of interprofessional collaboration further supports the evolving paradigm shift that AI has taken into diagnosing the oral potentially malignant disorder management requires a coordinated input from the oral medicine specialists, oral pathologists, and the data scientists as emphasized in the contemporary precision dentistry framework. Despite these encouraging results, approximately 39.71% incorrectly identified the specific oral potentially malignant disorders, indicating the persistent gaps in the lesion level diagnostic differentiation. This discrepancy underscores the need for the integrating AI-assisted image-based training modules that enhances the pattern recognition and the early detection accuracy, as suggested by Arigi et al., who demonstrated improved diagnostic sensitivity for oral lesions using the deep learning-based imaging tools. So we did a comparison of the demographic characteristics with the mean knowledge of the scores, which mentions that majority of the patients who are belonging to the both the genders. And when we look into the year of the study, which shows about 38% of the individuals who are belonging to the final years. At the same time, when we asked about the AI exposure, that was very minimal. Attitude towards AI-assisted diagnosis. Students demonstrated a predominantly positive attitude towards AI integration in the oral diagnosis. The majority agreed or strongly agreed that AI should also function as an adjunct to the clinical expertise rather than a replacement for the clinician judgment. This reflects a balanced and ethically appropriate perception of AI, emphasizing its supportive role in enhancing diagnostic accuracy while preserving the clinical decision-making authority. When we look into this attitude towards AI integration, although knowledge levels were high, attitudes remained largely moderate and suggesting the cautious optimism towards the AI adoption. The majority agreed that AI could also improve the early detection, reflecting the positive perception of its adjunctive diagnostic value. This finding also corroborates the previous surveys showing the dental students perceive AI as a supportive clinical and rather than a replacement for the professional expertise. Importantly, 72% of the students endorsed AI as an adjunct rather than a substitute for the clinical judgment, indicating appropriate professional skepticism and alignment with the ethical guidelines, advocating the human AI collaborative decision making. Such perspectives are critical as AI models, despite high accuracy, may still produce false positive and the negatives when trained on the limited data sets. Studies on AI-based oral regions detection emphasizes that clinician oversight remains essential to ensure contextual interpretation and risk stratification. So when we look into the willingness to learn about AI tools reflects a strong readiness for the curriculum integration, consistent with the evidence that early exposure to AI training enhances an acceptance and competency among the undergraduate dental students. However, only 3.25% of the mean score for the exposure to the AI-based diagnostic tools indicate that limited hands-on experience mirroring the global trends where the curriculum incorporation of AI remains in its infancy. So when we look into the attitude profiles of these students, moderate attitudes dominated with a high agreement on AI enhancing early oral potentially malignant detection, adjunct use, and also the curriculum integration. Willingness to adopt AI tools scored highest, echoing the positive perceptions in 94% of the Indian students viewing AI as a transformative, though low practice scores, indicating a motivational gaps. Concerns over AI errors reflect the broader literature on the dataset limitation. When we look into the predominant barriers identified were the lack of knowledge training, limited access to the AI software, and insufficient interprofessional collaboration opportunities. These are the findings which echo the existing literature, demonstrating that infrastructural constraints and the curricular gaps have been also major obstacles to AI adoption in the dental education. Additionally, concerns regarding the reliability reflect the apprehension and also towards algorithmic transparency and the validation, an issue widely discussed in the medical AI ethics. The relatively high proportion citing lack of collaboration highlights the necessity of interprofessional education models that integrate dental, medical, and the data science perspectives. Such collaborative frameworks have been also shown to improve diagnostic accuracy and the clinical decision making in the AI-driven healthcare systems. The top barriers included the lack of AI training and the software access, followed by the reliability concerns and the collaboration gaps. This mirror Indian and the global findings where insufficient training and the resources hinder the adoption, with 59% of the citing the ethical unawareness. Infrastructure and the cost issues underscores the needs in the resource-limited settings like our country. So when we look into the predominant barriers which are identified were the lack of knowledge and the training, limited access to the AI software, and these findings, which also echo with the other literature, demonstrates that infrastructural constraints and the curricular gaps have been the major obstacles to the AI adoption in the dental education, which was given by the Kanagar et al. In the year 2021. Additionally, concerns regarding the reliability reflects apprehensions towards algorithmic transparency and the validation, an issue which is widely discussed in the medical AI ethics. So the relatively high proportion citing lack of collaboration highlights the necessity of interprofessional education models that also integrate the dental medical data science perspectives. Such collaborative frameworks have shown improving in the diagnostic accuracy and the clinical decision making in an AI-driven healthcare system. So when we look into the clinical practices which are related to the oral potentially malignant disorders, encouragingly, the most of the participants reported routine assessment of the tobacco and areca nut habits documentation through clinical photography and the referral for the biopsy when indicated. These behaviors align with the established oral potentially malignant disorder surveillance protocols and emphasizing the risk factor screening, standardized documentation, and early histopathological confirmation as given by Vernakula Surya et al. In the year 2021. So nevertheless, low participation in the screening camps reveals an inadequate community-based exposure. At the same time, given the high burden of oral potentially malignant disorders in the South Asian populations, experiential outreach programs have been also essential for the improvement in the early detection and fostering the translational application of AI tools in the real-world settings. Hence, we went through this, the plot, which is a diagram, which is a scatter diagram of correlation between the knowledge and the attitude, which mentions about as follows. This scatter analysis suggests that a positive correlation trend between the knowledge and the attitude scores supporting the theory that improved the cognitive understanding of the AI fosters a greater acceptance and the readiness for the implementation. This aligns with the technology acceptance models in the healthcare, which also emphasize the perceived usefulness and the ease of use as a key determinants of adoption. So there was no statistical significant difference were being observed in the knowledge and the attitude scores based upon the gender and the year of the study and the prior AI exposure, where it was p-value is noted to be less than 0.05, showing a statistical significant difference. And this suggests that uniform dissemination of the theory across the cohorts, yet limited experiential differentiation. Comparable findings were been also reported by Esguglu, who observed that there was no gender-based disparity in AI awareness among the dental students, indicating that educational exposure rather than demographic factors which primarily influences AI literacy. When we look into our data, although interns exhibited a slightly higher mean knowledge scores, the difference was not statistically significant, implying that clinical experience alone may not substantially enhance AI-related competence unless supplemented by structural training modules. When we look into the implications for the dental education and the interprofessional practice, the findings highlight the urgent need to incorporate structured AI training into the undergraduate dental curricula, particularly focusing on hands-on exposure to AI-based diagnostic software, image-based learning modules for the oral potentially malignant disorder detection, and at the same time, interprofessional collaborative case discussions, ethical and reliability considerations in the AI outputs. Such integration would also bridge the knowledge practice gap and also enhance preparedness for the precision oral medicine. Evidence also suggests that embedding AI literacy within the dental education significantly improves diagnostic confidence and also promotes an evidence-based decision-making in oral oncology screening. So when we look into the advantages of this AI, when it comes to the reduction of the diagnostic variability, majority of the participants identified the reduction of the inter-observer variability as a principal advantage of AI-assisted diagnosis. This perception aligns with the evidence from the computational pathology studies indicating that AI-based image analysis enhances diagnostic consistency, particularly in grading epithelial dysplasia. Ariji et al. Also demonstrated that deep learning models achieved high reproducibility in identifying suspicious oral lesions, thereby supporting the current findings. Moreover, 88.2% of the acknowledge that AI-based clinical decision supports systems integrate the both patient habits and the lesion characteristics, reflecting an understanding of the AI's capability to synthesize multifactorial clinical data for the risk stratification. This is in agreement with the studies highlighting that machine learning algorithms incorporating behavioral risk factors, clinical morphology, and imaging features can significantly improve early detection of the malignant transformation in the oral potentially malignant disorder. So when we look into the interprofessional collaboration in the AI-based oral potentially malignant disorder management, a notable strength of the present study is the emphasis on the collaborative practice. A substantial proportion of the respondents agreed that AI-assisted oral potentially malignant disorder management involves a coordinated efforts of the most of the general dentists, oral pathologists, oncologists, and the data scientists. This findings also strongly supports the growing paradigm of the interprofessional education in the digital healthcare. So where integration of the clinical expertise with the computational analytics is essential for effective AI implementation. So when we look into the comparable findings which have been also reported in validated interprofessional education module studies, which demonstrated the improved diagnostic consensus and enhanced clinical decision making when interdisciplinary teams were engaged. Such collaborative models have been also particularly relevant in the oral potentially malignant disorder management, where accurate interpretation of the AI outputs requires a correlation with the clinical examination and the histopathological findings. The present study also revealed a predominantly positive attitude towards AI-assisted early detection of the oral potentially malignant disorders, with the majority of them agreeing that AI can enhance our routine clinical examination. This aligns with the global surveys indicating that dental professionals perceive AI as a valuable adjunctive tool capable of improving diagnostic precision and facilitating early referral of suspicious lesions. However, concerns regarding algorithmic errors due to the limited training data sets were also reported by a considerable proportion of the respondents, reflecting the cautious optimism. Similar kind of an apprehensions have been also documented in previous research, emphasizing the need for the large diverse data sets and the robust external validation of AI models before clinical deployment. Importantly, most of the participants supported the inclusion of AI training within the undergraduate dental curricula and expressed willingness to learn AI-based diagnostic tools. This finding corroborates earlier studies advocating the curriculum reforms to incorporate the digital diagnostics and the machine learning literacy, which are essential competencies for the modern dental graduates. Despite of the favorable knowledge and the attitudes, practical implementation of AI remained quite limited, while more than half of the respondents reported that exposure to the AI-based diagnostic tools during the clinical training routine use in the patient assessment was not very universal. Similar discrepancies between the theoretical acceptance and the practical utilization have been widely reported in the dental AI research, indicating that infrastructural limitations and the lack of hands-on training impaired the clinical adoption. Additionally, interprofessional discussion of the suspicious oral potentially malignant disorder cases and the biopsy referral practices were moderate, suggesting that collaborative clinical decision making is evolving but not yet consistently practiced. These findings resonate with the previous reports, emphasizing the need for the structured interdisciplinary clinical pathways to optimize the early diagnosis and the management of potentially malignant oral lesions. When we look into the preventive practices such as participation in the screening camps and the provision of the habit cessation counseling were variable, highlighting an important gap between the awareness of the malignant transformation risk and the proactive preventive engagement. Evidence from the public health dentistry literature underscores that integration of AI-assisted screening in the outreach programs can significantly enhance early detection rates, especially in the high-risk populations with the tobacco exposure. Collectively, the results of the present study are in concordance with that of the existing literature, demonstrating that dental students possess the satisfactory baseline knowledge and the positive attitude towards AI in the oral diagnostics, yet exhibit a limited clinical exposure and the practical implementation. Prior studies evaluating AI-based classification of the oral lesions have reported that high sensitivity and specificity, supporting the perception that artificial intelligence can significantly enhance early detection and also reduce the diagnostic subjectivity. However, as echoed in the present findings, real-world clinical integration remains constrained by infrastructural and also educational limitation. So when we look into the implications for the clinical practice and the education, these findings highlight the necessity of integrating artificial intelligence competency modules into the undergraduate dental curricula, incorporating interprofessional simulating training, and also providing exposure to the validated AI diagnostic platforms. Such educational platforms also would bridge the gap between the theoretical knowledge and the clinical application, enabling the future clinicians to effectively collaborate with the data scientists and oncologists in AI-assisted oral potentially malignant disorder management. The study demonstrated that high number of the dental trainees exhibit the strong foundational knowledge related to the oral potentially malignant disorders and favorable perceptions towards AI-driven diagnostic tools within the interprofessional framework. These evidence indicating that increasing acceptance of the AI as an adjunct in the constraints and the concerns regarding the algorithm reliability continues to hinder the widespread clinical adoption. Strengthening professional education, enhancing the access to validated AI platforms and dental diagnostic training within the dental curricula are essential steps towards optimizing AI-assisted early detection and the management of oral potentially malignant disorders. When we look into the most of the respondents, they reported that routinely assessing the patients of the tobacco and the recurrent habits are been documenting the oral mucosal lesions using the standardized clinical photographs. Additionally, high proportion indicated the discussing about the suspicious lesions with the faculty or the specialists, reflecting an adoption of an interprofessional collaborative approach in the clinical training. So when we look into the biopsy referral practices were favorable, with the majority agreeing that they could consider biopsy referral when it is encountered lesions. Participation in the oral cancer or the oral potentially malignant disorder screening programs was also commonly reported, suggesting engagement in the community-oriented preventive oncology initiatives. Habit cessation counseling and the follow-up of the patients with the oral potentially malignant disorders were frequently practiced, though variability was noted in the consistency of counseling delivery. Course, the urgent need to integrate the AI-focused competencies within the dental and the medical curricula. Evidence also indicates that the formal training in the AI application significantly improves the students' confidence in the digital diagnostics and enhances their readiness to adopt the emerging technologies. Competency-based modules encompasses the fundamentals of the machine learning, ethical considerations, and the clinical interpretation of the AI outputs are essential for the preparing the future oral healthcare professionals. So when we look into the limitations of using this AI in and also the future directions, the interpretation of the study findings should also consider the certain methodological constraints, including the reliance on the self-reported person and limited exposure of the participants to real-world AI diagnostic system. Future research should also focus on longitudinal evaluation of AI in multicentric validation of diagnostic algorithms, and assessment of clinical outcomes following AI implementation in the routine practice. Are the couple of limitations and the future, where we see that most of the current study, which is used as a pilot study, which mentions most of the self-reported data, which is a single center sample, and it is having a limited real-world exposure. This study further, where longitudinal evaluation of the training can be conducted for the students, including one of the evaluated with a multicentric validation, the clinical outcome assessment of this kind of a AI application in the clinical diagnosis in the chair side. Increase the workforce to understand the oral potentially malignant disorders for the early diagnosis. Structured collaboration, validation, and the curricular integration are the critical for effective clinical translation. I want to say here is that AI application in dentistry, it is just spoken, but it is still not, it is implemented into the curriculum. I think future steps can be taken into the consideration that where curriculum can come up with lot of changes and the form of a modules where we can teach the students theoretically about how we can make the students understand about the applications of AI in understanding the clinical findings in a better way with a less amount of inter-observer and intra-observer variability. Thank you.
Thanks, Dr. Sujata, for throwing light on AI, how it helps in managing
Thank you,
oral
sir.
cancer. Anybody want to ask any question? Dr. Sujata is with us, so she can answer your queries. Or you can type the question on the chat box as well.
Either they have completely understood or they have not understood. One of them.
No, they So you, Dr. Sujata, stay with us. Maybe if there any question comes, maybe we can take this query
Sure,
after the next presentation,
Sure.
next session.
Okay. Thank
So
you.
may I request Dr. Efsun Somai to sign in again, and she is the organizing secretary of International Oral Cancer Congress, and she would be moderating the next session. So over to you, Dr. Efsun.
Hello.
Yeah.
Am I audible?
You are audible.
Thank you. So it's a great pleasure to attending and organizing this scientific program. Let me introduce Professor Erkan Topkan. It's a great honor to introduce Professor Erkan Topkan, an internationally distinguished scientist and a leading authority in radiation oncology. Professor Topkan has achieved exceptional global recognition for his scientific impact. According to Scholar GPS rankings, he has been ranked the world's top scientist in his field, a distinction that reflects both the quality and sustained influence of his scholarly work. He is widely known for developing original prognostic and inflammatory nutritional indices, which he personally conceptualized and validated through extensive clinical research. These indices have been adopted and cited internationally, contributing meaningfully to risk stratification, outcome prediction, and personalized treatment approaches in oncology. Professor Topkan's research portfolio is characterized by strong methodological rigor, high impact publications, and a clear translational vision that brings statistical innovation with real world clinical decision making. His work has significantly shaped contemporary thinking on treatment response, toxicity prediction, and survival modeling, particularly in head and neck and thoracic oncology. We are truly privileged to have Professor Topkan with us today. His scientific perceptive consistency challenges conventional frameworks and provides novel data-driven insights that advance our field. Please join me in welcoming Professor Erkan Topkan. Stage is yours.
Thank you very much, Dr. Somai. You are very nice. We are very kind. It's a pleasure to work with you. I have to say that you are at least as famous like me, and you are a hardworking, really professor in your discipline and also head and neck oncology. Thank you very much, dear President, my colleagues, and especially Dr. Nurul Anwar for his kind invitation to me, this well-known and prestigious Congress. The, last year we were talking, I am again was there and I was there and we were talking about the statistical problems in head and neck oncology, and again I am coming to you with another problem. Non-adherence to consensus sarcopenia definitions in head and neck cancer. You know, when definitions drift, evidence also fractures. What I call is a methodological fracture in sarcopenias and head and neck oncology, which is also relevant to all other sites of cancer. I have nothing to declare as a competing interest that may affect my presentation. Artificial intelligence was just used to figure stylization, visual metaphor illustrations, and layout optimizations, as well as color palette standardizations. All other intellectual, methodological positions, scientific conclusions were created by me by analyzing the solid evidences. Then let's go on. My presentation plan is, first we will go on with the definitions of current definitions of sarcopenia. Then we will bring the problem into the sunlight, and then I will bring some literature evidence, solid evidences, particularly to the sunlight. Then we will go on what is the problem. So is it have any clinical and research consequences, whatever, whether it is right or not. What is sarcopenia? My colleagues, my friends, when you read either a comprehensive meta-analysis, systematic review, a narrative review, or a research article, or even a case report, almost always the introduction section begins or involves sarcopenia is a progressive skeletal muscle disorder or syndrome characterized by reduced muscle strength, leading to impaired physical performance. Those mean dynapenia and keratopenia. With or without, generally without is not used. Maybe the main problem is that muscle quantity, which means myopenia. What is the prevalence of sarcopenia in head and neck cancer groups? It changed by definition. It is about below 15% up to 30%. Rarely exists this limit, but it jumps to 30 to 60% or over, as you will see later. Why is this? It seems that there is an apparent prevalence inflation that reflects the definitional broadening rather than increased biological burden, as the disease and the patients are the same in both contexts. In the last 15 years, compared to previous years, there is a great effort for refining the sarcopenia definition. First, European Working Group on sarcopenia in older patients set mass. If mass, skeletal muscle mass is reduced, then sarcopenia is suspected. Once strength is also reduced, it is confirmed. On that way, during this period, it became evident that strength was the main determinant of both the falls, hospitalization, patient survival, treatment, or any kind of treatment tolerance and related rates of the toxicities. So the strength became first and followed by mass. Then functional outcomes began to be questioned by the sarcopenia definition consortium and outcomes consortium. Then Gliss said this is a multidimensional construct. Neither of the components can totally or entirely reflect the sarcopenia positionally. But what is the real world practice? There is a real big gap. Mass is still dominant practice. Skeletal muscle index is the dominant surrogate marker. Muscle may remain the anchor in many studies, despite of the first definition. Function is almost always de-emphasized, and by day, the gap it widens because many studies or deny to shift to strength first, as emphasized by the consensus definitions. Quantity versus function disconnect is going on in a harsh manner, and multidimensional integration is rejected by many of the authors. This is an unfortunate condition. More importantly, as I said, that this is a three-component syndrome. Sarcopenia definition and outcomes consensus in 2020 declared that low muscle mass or myopenia is not required for the diagnosis of sarcopenia at all. A patient can be sarcopenic even there is no muscle mass reduction, that means. But still, real-world practice remains to be the same. Let's get some evidence for this condition. In high-impact journals and containing very large pooled cohorts, either specific to head and neck cancer or other side, we can test this situation. There are two important studies, both reported in 2026, namely a few days ago, Zhu and McNeese studies in Journal of Geriatric Oncology and American Journal of Otolaryngology journals. Let us examine. In the Journal of Geriatric Oncology, there were 9 studies. Only 4 of them followed the consensus aligned definitions, which corresponds to only 45% approximately. What about the American Journal of Otolaryngology? It was a larger study involving 17 meta-analysis involving 17 studies. Unfortunately, there were 0, namely no studies examining the functional assessments, so that consensus definitions were not applied, rejected in these studies involved this meta-analysis. These results show us that even in the major studies or the high-impact meta-analysis, the consensus definition is not still obeyed or aligned or followed. It seems that there is a de facto consensus that to not follow the consensus definition sarcopenia. This is really frustrating. If we then, we can say that if we say that radiological myopenia usually is T-based, is sarcopenia, then what will be the consequences of this condition? Let's go on one by one. If we equate these conditions, taking one component and equate the syndrome, three component syndrome, then what we are doing is imposing the diagnostic equivalence, although it is not, which creates a definitional conflation. There are inevitable consequences of equating isolated myopenia to sarcopenia. It may be seen to most of the authors or the audience now, it is an academic problem, not serious, but once this definition is applied in practice, in clinics, be sure that it stops being an academic problem. This is not an academic hair splitting. Be sure about it because it alters the risk stratification, treatment decisions, and related patient outcomes. What are those? If you use myopenia as an equivalent to the sarcopenia, then you have to face these conditions. Myopenia first is not mandatory for diagnosis, as sarcopenia definition and outcomes consortium said. A patient may be very fit but may have myopenia. You may say that this patient is sarcopenic and go on with this situation. All decisions will follow this definition. On the other hand, a patient may not have skeletal muscle index reduced, myopenia, but still may have some physiological problems, functional deficits, namely keratopenia, and or strength problems, dynapenia, but you neglect to call this patient sarcopenic. On the other hand, a patient may have a good condition and skeletal muscle index in the normal limits, but myosteatosis may be evident, which means that lipid mass between the skeletal muscles. Although he or she is sarcopenic, you will say that he is not sarcopenic. It is statistically well known that when you are examining one of three, the musts always, if you take one of them, you will inflate the prevalence. As I said, at the one end there is 15% when consensus-based sarcopenia is, at the other end more than 60% when CT-based surrogate definitions are used to define sarcopenia. This is a systematic inflation, not any unintentional inflation of the sarcopenia prevalence. At that point comes the nihilist penguin and says, this is the same disease, this is the same patient groups, but there is an up to fourfold of difference. But why? Is it a methodological problem, slide versus syndrome issue, or definition versus disease contradiction, or more importantly, is it biological? Be sure that it was biological. This slide shouldn't exist here. It is not biological. Let's confirm it by the evidence, recent evidence. One of them was hepatology communications report. Other one was, again, Journal of Geriatric Oncology report in 2025 and 26. These two studies, in the first study, Johnson et al. Demonstrated that in patients undergoing liver transplant, when you use the European group definition, the updated definition, sarcopenia prevalence is only 11%. When you use the older version, it jumps up to 22%, doubles. But if you use CT only measure or CT defined sarcopenia, it becomes 52%. It soars to 52%. What a big difference between three methodologies. Another larger study, oncological meta-analysis reported by Sen et al. In Journal of Geriatric Oncology, there were 52 studies enrolling more than 16,000 patients. In this study, you see that the mean value of sarcopenia prevalence was 33% across the studies, but the lower and the higher margins were 8 and 77%. It means that when prevalence range from 8 to 77%, basing solely on the definition, this is a methodological choice. Not the driver signal is never the biology, as I said before. Let's go on. The second one is when mass-centered definitions are used, you intentionally undervalue the strength and the function. As I said, that the definitions was changed as the studies, comprehensive study, so that it is the strength, not the muscle mass, that determines the outcomes. So that another important point of denying the strength and function is that you cannot stratify the patients. Updated European Working Group on older sarcopenia group on older patients, namely 2 second report, involves 3 and says that if both 2 are present and cryptopenia, namely functionality, is reduced, then this patient is severe sarcopenic. The prognosis of non-sarcopenic, sarcopenic, and severely sarcopenic patients are quite different, my colleagues. Either when you look at the spectrum of the treatment tolerabilities or the survival outcomes. Another one is the confusion of the sarcopenia with others, with other disease conditions. For example, malnutrition. It is an easy condition that you can feed patient better. Nutritional support will absolutely turn the patient to the normal values, but highly inflammatory that cancer cachexia will not get any benefits. Sarcopenia, on the other hand, is a neuromuscular disease of the skeletal muscle, which may be physiological by aging or secondary to cancer or other type of chronic diseases. If you say that muscle mass reduction is sarcopenia, then malnutrition also has muscle mass reduction. Cancer cachexia is also have muscle mass reduction, but what is different is all 3 have different drivers behind and as the causes, and their prognosis are quite different. A more significant condition is the frailty. Frailty is different from all 3, but may involve all of them at the same time or may be caused by other conditions. Again, muscle mass is reduced, skeletal muscle mass is reduced in the general frailty, so that if you say this patient is frail, also you will again miss the diagnosis because frailty is not a radiological disease. It's the reduced physiological reserve across multiple systems, even including the immunity. This is an educational slide. My younger colleagues may take it to differentiate between these vulnerable conditions given 4 conditions. Let's again confirm. For example, almost all of you know that Fearon's Delphi consensus says that cachexia can be diagnosed if a patient has 5% weight loss at past 6 months, or 2% weight loss with body mass index lower than 20, or 2% weight loss plus sarcopenia. However, if you say by just looking at the muscle area converted to muscle mass index, this patient is sarcopenic, although he or she is not, then you also go to a misdiagnosis is cancer cachexia, which means that your failure propagates between these states. Another one is the impaired comparability across oncological studies. You know that even if you use the CT-based parameter, you use still lumbar 3, 4, 2, thoracal 12th, 11th, 7th, 18th, or the cervical 3rd vertebral levels to measure the muscle mass. This makes a heterogeneity between the study, although it is straightforward for measurement. And also, in some of the studies, as I shown before, some authors apply the consensus definitions, others CT-based definition. How to compare them and reach a reliable result. Be sure that if you can't reach reliable results from independent studies, you cannot also reach the good results in meta-analysis, which should be reliable because they will guide the clinical treatment decisions or preventive decisions. Another consequence is decision making. It impacts decision making. How it makes therapeutic leverage, biological misdistribution, and clinical harm. How chemotherapy dosing, treatment intensity, or perioperative risk may be determined by this sole parameter incorrectly. You may take this as a surrogate and make your decisions. This is not a multidimensional biological syndrome, just lowered muscle mass in CT. And you may, because you made the sarcopenia diagnosis, unwarranted dose reductions, misaligned supportive strategies, for example, although not needed exercise may come into the scene, and inappropriate cachexia-oriented management can be played roles in such patients, although it is not right. Another one is its impact on trial design and translational oncology. You are mixing the phenotype. You are diluting the signals. I mean that you are diluting you may say this treatment is effective or not. You may increase the false therapeutic negatives or positive. For example, you may use anabolic steroids for malnutrition, you may use even in sarcopenia, and you can get better. You can get increased skeletal muscle index, but it will not affect strength or function. The patient is still sarcopenic. Therefore, false therapeutic or negatives can be achieved with this methodology, and more important is that single metric definitions, although always undermine the precision. So the precision of the supportive oncology measures either it is preventive or management maneuvers. They also call this such a practice also causes a hidden bias in oncology trials, especially across the treatment modalities. As I said, they may reduce the efficacy signals, inflate the toxicity rates, and increase the variance in survival outcomes like its prevalence rates. So that such kind of problems may also lead to exclusion of functionally vulnerable yet biologically responsive patients because labeled as sarcopenia excluded from the studies. Or really, you may include patients in studies, although they really have strength or functional problems, but normal skeletal muscle index, or this may lead to inclusion of advanced cachexia, highly frail patients in these studies. Why then, this is the last consequence, why CT-defined sarcopenia often misleads. This is a statistical problem because you said that if the muscle mass is reduced, then you say that this patient is sarcopenic, although there are three parameters, at least two need to be met for a strict diagnosis. Muscle quantity, strength, and function are distinct, but they are really correlated, and these are not binary parameters. Muscle mass, low, high, or normal. Muscle secretary, low, normal. Physical function, reduced, normal. How much reduced? For all three parameters is not important, just yes or no. What are we doing in such studies? We are, as I said, that sarcopenia definition and outcomes going to change the sarcopenia definition in a harsh manner, said that the muscle mass reduction is not needed for the definition, so that it is ambiguous. You choose this most ambiguous variable, CT muscle mass, you apply an arbitrary cutoff as if it is relevant for any kind of population. If it was aging group, should not define a new define new cutoffs because of the short and small habitus of their patient groups. And then you go and say low or normal, as I said previously, binary labels are in play. Then you go and classify the outcomes in according to these binary labels. Event is present or there is no event according to this erroneous practice. But it is not an unsolvable problem. What we have to do, we have to avoid binary sarcopenia labels present, absent. We have to use continuous models because biology is continuous. We can use continuous gradient models. As we instead of using CT cutoff, we can go with nonlinear effects such as the restricted cubic splines, and we have to not forget that one size does not fit everybody. We should not use the same threshold for anybody. It is very different statistically, my friend, to say there is a cutoff at 40 kilograms, and there is really it appears that there is a cutoff at 40 kilograms, but it begins from 20% and goes on straightly. And for example, cubic splines are very important. Not always the response is linear. Sometimes it may be in J shapes, or it may be inflating at some points. Detect these variances. As I said, there are many problems. Another problem is the ineffective use of the budgets, especially in the growing countries or source-limited nations, which is called financial toxicity, but it is beyond the scope of this presentation. Again, in 2025 and 2026, I took some studies here. I brought some studies here. You see that it is again the same practice is going on. Neither of the studies obey the rules for definition of the sarcopenia, but in their introduction, the official definition is always stated. Is it something to be two-faced or not? It is up to you. It seems that imaging-based sarcopenia becomes the body mass index of the oncology, but they are not. They are decisively prognostic, but not diagnostic for sarcopenia or any disease condition. You see that the formula is almost the same. One uses the height, both uses the height. Body weight is in body mass index. Skeletal muscle area is in the sarcopenia definition or skeletal muscle index. It means that skeletal muscle index is almost trying to replace body mass index in oncological patients. I know this tedious presentation may sometimes made you frustrated, or sometimes made you what is going on in the literature questionable. Maybe it is the camel condition. There are many crooks, but these inevitable crooks can be healed or not. This is the problem. We have to confess that CT-based myopia in strong prognostic indicator, still it is a strong indicator. But the problem is that you have to use myopia term, not sarcopenia. We have to be honest in this condition, because using myopenia instead of sarcopenia will not undermine its established prognostic value across many studies. Then what we have to do? We have to construct a common language by not using them interchangeably, which will enable study comparability, prevent misclassifications, or avoids or prevents over or under treatments, which will refine research by creating clear endpoints and patient selection, reduces harm by using the hopeless treatments, creating additional medical toxicity, all, as I said, financial toxicities. My final message is that using myopenia and sarcopenia together, not a substitute, is important. This will strengthen science and improve patient care. But I have to say something because I know that analogy is very important to remember things. Let us think that your real estate has called you for a house, new house, what you are looking for, and you went there and see that wall thickness were excellent, which is muscle quantities, and you said that this is a strong building. The walls are very thick, but what about its material? Is it really a good house? Can it endure the stress during an earthquake? What about the structural integrity? What about the comfort? What about the habitability in this, which is the physical performance? So that structural stability cannot be inferred from wall thickness alone. What about its ingredients? Sarcopenia also cannot be inferred from CT-derived muscle quantity alone. If we measure only myopenia, not sarcopenia, muscle quantity, not the clinical syndrome will be revealed. Therefore, modeling a single component cannot capture a multidimensional construct. And an important and last point is that we have to obey or follow the tripod, insert, and strobe depending on the article types. If we say sarcopenia is a syndrome involving three components, but examine it depending on the city-defined muscle mass, then we will violate these international rules, and the reliability of our conclusions will be questioned, become unreliable. For educational purposes, you can want from me. My slide said you can use it anywhere freely, and I would like to thank you very much for your engagement and listening these somehow tedious, somehow problematic presentations. Thank you very much.
On behalf of organizing committee, we thank to Professor Topkan for his wonderful presentation. Do you have any questions from the audience? You can type in the chat box.
Dr.
I have a
Sumay,
question. Mentor. From my notes, in your opinion, what would be the single most impactful step toward harmonizing sarcopenia for assessment in particularly head and neck oncology?
although we talked about the head and neck cancers, be sure that neither of the other oncological tumor site or other tumor sites have different behaviors. Strength is the first. I know it may be sometimes difficult to measure strength. It may sometimes be very difficult to say a patient to measure the function. Please walk. Please stand up from a chair. It may be very harsh, very difficult in some conditions. What I am saying that strength is the first. That is okay. But if you cannot measure this, you don't have to say that this is sarcopenia, because These conditions leads, although I didn't want to be, I tried to be non-accusatory. We have some responsibilities. We researchers always try to how can I say, choose the best terminology. I know sarcopenia somehow is more sexier than myopenia, more impactful for the journal, for the readers than myopenia. But it is really myopenia. It is not sarcopenia, and journals have to take care of this. The same journals are publishing the consensus reports, then go and again publish the studies which try to say that myopenia is sarcopenia. This is a human behavior. We all want that. What is our aim? To make our manuscripts acceptable. If we say myopenia, some editors may say, what is this? But sarcopenia is more influential. This is a pragmatism. This is a pragmatism which is also conflating between all the researchers. And one important point I have to say that some authors may say, although they are not asking questions, isn't an impediment to not say it's sarcopenia. It is not an impediment. What I want from you is to be honest. Say my opinion. My opinion is also important. You are not obliged to say it is sarcopenia when you are not evaluating all the needed components of a disease condition. Strength is the first. Your question.
Yeah, thank you, Professor. Dr. Norul?
Yeah. Anybody want to ask any question? Because it's very crucial that we are getting sarcopenia, we are getting cachexia. They are, there is very confusing actually that is a malnutrition, because we are not able to, go with the city only actually as described by Dr. Topkan, that the strength is and thickness is a different thing actually for the muscle as far as the muscle strength is concerned. So anybody having any issue related to sarcopenia in their management in the journey of head and neck cancer or oral cancer they are treating, any one want to ask any question, they can, because we have the top scientist available in radiation oncology. He can throw light on how to deal it and how to understand that what is sarcopenia in my opinion. Anybody want to ask any question? Or you can type on a chat box as well, and you can email to us support@ioccon.org, and we'll pass on to Dr. Topkan for answer and clarification. Thanks, Dr. Erkan, and thanks, Dr. Efsun, for joining us from Turkey, Istanbul.
It was a pleasure for us. Thank you
Yeah,
very much.
here, how is weather there in your means Turkey? Because here we are onset of summer now actually, so it's a little bit of winter, and night and evening is and morning is like winter, and day is very little bit hot, so it's a summer here. Yes.
Have a nice day.
Yeah. Okay, so yes, so we are going with our next speaker, Dr. Yash Mathur. He is about to join in 1 or 2 minutes. I think he is joined actually. Dr. Mathur, have you joined? Yes.
Yes, I have joined.
Yeah.
Name actually reflects.
No worry. I'll do it. I'll do it. No worries.
Yeah.
Let me introduce you formally, and then we'll take it forward. So because it's a responsibility of mine to introduce you. So Dr. Yash Mathur is a senior consultant, surgical oncology, head and neck. Dr. Mathur is full-time consultant, head neck surgical oncologist and robotic surgeon at SHCG Cancer Center in Mumbai, which is a reputed, center for oncology. He is amongst the trained and certified robotic console surgeon in India for head and neck oncology. He has completed his fellowship and training in the field of head and neck oncology and reconstructive surgery from India's premier oncology institute, Tata Memorial Center, Mumbai, known to everybody. He is one of the few minimally invasive robotic surgeons in India who expertise in auxiliary approach like Baba technique for robotic neck surgery. He has experience of more than 9 years in the field of head and neck oncology. He is currently director of oral oncology fellowship program along with being assistant program director of head and neck oncology program of HSG Cancer Centers, Mumbai. He is a part of faculty for DNV Physical Oncology program at HSG Mumbai. He is adjunct faculty at SPDC DMHER Varda. He has named amongst eminent oncologists head and neck in India today, 2025. He has been awarded Promising Oncologist 2024 by Times Network Group. He has been listed amongst top city oncologists in Outlook and India Today for 2023 and 24 consecutively. Then his area of expertise basically consists of treatment of surgical management of malignancies and tumors of head and neck and craniofacial region. He has received many awards in recognition of the work he has done in the field of head and neck oncology. Many cases he already been handled, more than 6,000 cases he handled. He regularly participate in workshops, conferences, and national, international level. He has been invited as speaker, faculty in various CME and conferences in at national and state level. Dr. Mathur has more than 10 international and national publication in the field of head and neck oncology to his credit. He has been a part of developing many research protocols and has been investigator in many quality of life studies for head and neck oncology trials. So over to you, Dr. Mathur. If I have missed anything, you can add on. And your slides are visible, you are audible, so you can continue with your presentation on emerging trends of robotic surgery in management of oral cancer.
Thanks a lot, Dr. Anwar. You have given a very, very elaborate introduction. Thanks a lot for such an introduction. So, basically, I practice a lot of head neck oncology, oral oncology at HCG Mumbai. We have been quite, towards use of technology and into our clinical practice. We have been quite towards developing newer techniques, newer management protocols that gives patient better quality of life. So I'll begin my presentation with a brief outline that how we are now heading in field of oral cancer and what are the recent advances, what are the things that we need to look in near future. So there is a definite role of AI that is coming up, artificial intelligence, which is right now in diagnosis evaluation phase, used quite in depth in for diagnosis, for evaluation, and for surgical planning also. Apart from that, newer surgical techniques or advanced technologies used like nerve monitoring system, robotic surgery, and also in treatment related newer advances, you have chemotherapy, immunotherapy, new recent advances which has improved disease specific survival. There are two recent phase 3 trials which have supported immunotherapy in oral cancer also, Nivo Postop and Keynote 689. Apart from that, aggressive rehabilitation and prehabilitation is very much important in today's oral cancer management. The reason is we have patients who are surviving for longer duration, even after getting surgery or after receiving systemic therapy and then surgery, they should have a better quality of life. So the entire discussion now is not only about survival in cancer, oral cancer, but also about good quality of life outcomes these patients should have so that they survive with a very decent quality of life after their treatment is done. So as we all know, India is world capital of oral cancer. This is recent Globocan data which has shown multiple organs, multiple different type of cancers incidence in our country. And overall, the incidence of new cases is close to 1.5 to 2 million in our country every year. So head and neck cancer is the seventh most common cancer globally. And we all know that India constitutes to around 35 to 40% of world oral cancer. If you see, this is Globocan 2022 data, which suggests that the burden of disease in our country for lip and oral cavity cancer is very high. For the male population, it is the most common cancer, and for females, it is the fourth most common cancer, making it overall as the second most common cancer in our country. So we all are aware what is the etiology. Our unhealthy heroes are also promoting it. Apart from this, there are other factors. Basically, these factors are not directly related to oral cancer, but I have put up just for the information that HPV virus, the incidence in our country for HPV virus induced oral or oropharyngeal malignancy is variable between 11 to 19%, depending on which study we quote from. Poor oral hygiene, ill-fitting prosthesis, malnourishment, these all synergistically act in causing oral cancer. So the fact is that in our country, the oral cancer is diagnosed late. It is diagnosed in advanced stages, and 70% of these patients that 50% of these patients that are diagnosed in late stages, they don't survive more than a year. So how do we help? So inherently, part of any oncology team or head neck surgeon deals with different kinds of site-specific cancer. Oral cavity cancer is the most common cancer, and neck addressing the neck or neck dissection is a part of the cancer treatment standard of care. Also, the expected outcomes for oral cancer surgery is basically not only getting clear margin, but also functional reconstruction and rehabilitation. And improved motor nerve function is to be expected as a good surgical outcome. So, how do we improve surgical outcomes? So, there are multiple ways by which we at our center try and improve surgical outcomes. For oral cancer surgery, oral intraoperative nerve monitoring system doesn't have much use, but definitely robot-assisted surgery is something which we are using and we are providing to our patients. Apart from that, reconstructive surgery with the help of 3D imaging and 3D models for plastic reconstructive surgery. We also do take care about prehabilitation, dental prehabilitation before the surgery. Apart from that, aggressive rehabilitation of our patients and some modifications intraoperatively so as to get a good quality of life after the surgery is done, like trismus release if required during the surgery, and giving patient good speech and swallowing therapy after the immediate surgery. So I'll just move on to just this is I'll go on to the robotic part. So our evolution as a surgeon, maxillofacial surgeon, or as a head and neck surgeon or oral cancer surgeon has started as open approach. We all surgeons have started doing open neck surgeries, open approach for doing primaries, and then moving on to endoscopic surgeries, and then finally to robot assisted surgery. So the journey is always first from the open approach, then forward to robot assisted surgery. So now I would just showcase this is how a usual robotic system looks like. And there are multiple robotic systems now available in our country depending on what platform you use. Each robotic system has its pros and cons. So the one that I am showing over here is basically Da Vinci X. It has a surgeon cart, an energy instrument cart, and a surgeon console. The in the middle is the robotic instrument with four arms. On the right side is the surgeon console with the master's controls that the surgeon uses in his hand to do the robotic surgery. And if you can see over here, there is yellow and blue paddles. These are basically your cautery paddles, how you use them. And on the left is the vision card, where you can help your where your assistant can see the surgery being performed and help you as a bedside or OT assistant during the surgery. It also has your energy instruments like cautery and camera recording everything. So going forward, I'll just talk about what are the indications of robotic surgery in oral cancer. So TORS is one of the indication which is used mainly for oropharyngeal malignancies. But in oral cancer, you have a slight indication in case you have a oral tongue lesion which is going on to the base of tongue. You can utilize robot-assisted surgery for taking your posterior cuts, wherein if you don't have to go for a visor approach, you can transorally use this is how the instruments are set in with a FK retractor or a Dingman retractor, and patient is positioned, and this is how you can take a base of tongue excision without having to do a mandibulotomy or without having to go for a visor approach wherein you have to cut down the mylohyoid muscle of ipsilateral side, and hence you have dysphagia later on. So I'll not go into oropharyngeal malignancies, but this is how we can help in oral cancer definitely. So I'll just showcase this one case of robotic TORS, which is basically a oropharyngeal malignancy, P16 negative, which was treated primarily by concurrent chemoradiation, and patient had a disease-free interval of around 9 months, but then patient developed a recurrence on the lateral pharyngeal wall, and the only option left for him was to undergo excision. So in such a scenario, doing a morbid surgery like giving a incision on the face and mandibulotomy would have given a post-operative very bad morbidity to the patient. Also, possibility of having osteoradionecrosis increases since these patients have been subjected to radical radiation. So we opted for a TORS surgery, and patient had active swallowing status post-operative day 5 and a good healing. We left the area raw without any reconstruction, and this is how, with the help of a cautery spatula and Maryland forceps, we could take out the small primary. So now I will move ahead to the neck dissection. We all know neck dissection is an integral part of oral cancer treatment, and the history from 1837 till today, it's getting, there are newer techniques that are coming up, newer approaches that are coming up, and now SLNB, that is sentinel lymph node biopsy, is one of the options for treating early oral cancer. But then all these things are yet to be established in Indian setting, SLNB especially. There are many trials that are going on. There are many studies that have been done world over, and it has been found to be a option for managing neck in early oral cancer patients. What else do we surgically do so that we can provide our patients a better quality of life outcome? So, possible outcomes due to surgical complications in neck dissections are many. So how do we overcome these outcomes or these complications so that we give our patients a better quality of life, not only in terms of survival, but also in terms of cosmetic outcomes. So these are the traditional approaches or traditional incisions that were used, and these are few of the recent incisions: a single horizontal incision or a visor approach for a bilateral neck, which are commonly used, angle split or a lip split, which are commonly used in our day-to-day practice. So these are also the post-operative outcome, but still these patients, they have some cosmesis related issue after the surgery. So the remote access neck dissection or basically robot assisted neck dissection was started in South Korea, wherein people over there have a lot of the patients over there want a lot of cosmesis, and they have a lot of inclination towards good cosmetic scar that is required in their practice. So the first robotic neck dissection was done in South Korea by Kim et al., and it was done using retroauricular approach. So there are now many approaches that are available for doing robot-assisted neck dissection surgery. The most commonly practiced approach is the retroauricular incision for robot-assisted neck surgery, along with a few of the modifications which are like TARA or combined approach for retroauricular as well as transaxillary approach. Then there is also BABA approach, and there is Reamind. So multiple names, different approaches have a long learning curve. So this the surgery actually had the mean OT time when as compared to the first case, and towards the end it was reduced by 29% for MRND group, and it was reduced by 53% as compared to selective supraomoid neck dissection group. So one of the drawbacks of neck dissection with robotic surgery is also that it is time consuming. So but the robot assisted retroauricular approach is basically a modified layer incision in which we camouflage the incision into the hairline, and it also goes in the skin crease, skin fold behind the pinna of the ear. So this is the incision that I started our robotic surgery program with, wherein I started with a retroauricular approach, and we used to give incision along the skin fold of the pinna, and then we used to take it over the mastoid and into the hairline, the posterior aspect of hairline. So this is aided by retracting the skin using a modified Thomson retractor. This is a copper malleable retractor that we use in our surgery for retracting the skin. And the benefits of this approach was we had a very good vision of the tissue. Also, this approach also gave us a camouflage scar which was not visible, and patients also had benefit of less blood loss. But then this approach is also not a minimally invasive approach, as we gave a large incision, and the incision has been transposed from the anterior neck fold into basically a retroauricular area, that is in the area where it is hidden. So it doesn't provides us with all the benefits that a minimally invasive surgery or a laparoscopic surgery approach gives in as compared to an open approach. So this is partially a open approach with a camouflaging of incision. So this is how I started with a scissor and a Maryland forceps dissecting level 1B. So this is the level 1B that we are dissecting. I'll just fasten the video. And the basic problem with this approach, if you try to do this retroauricular approach for neck dissection, is the level 1A, wherein you need a camera that should take you right up to the level 1A and show you where you are taking your cuts. So many surgeons have used endoscopes now for doing retroauricular approach for neck dissection, and they have been successfully doing it. So use of robotic retroauricular approach didn't appeal us much, and we didn't find much benefit in this approach for doing neck dissection. So we have modified our approach from here on. So this is what I am clear, the digastric muscle that I am clearing over here. And this is basically a level 1B now that I am doing. So this is the submandibular gland that is being dissected, and this is the facial artery and vein that we have clipped, and we use it for anastomosis or a reconstruction if desired by the plastic surgeon. So again, this approach, as I told, was a robotic approach in which air docking was done. The instruments were, placed just below the skin in air, and there was no added benefit as compared to open approach apart from scar satisfaction score. So this is the same case that I have shown the video, and we had in one of the cases darkening of the skin in the mastoid area. So although this revert back and our patient's outcome after 2 months, if you see there is no visible darkening of skin in the mastoid area, but still the benefit of robotic surgery was not very much obvious. So patients' other outcomes were as good as the what we achieved in open approach. So then we modified our approach, and these are the evidence that is available that for many surgeons who have done studies over the robot assisted surgery, they all could find that overall scar satisfaction score was the only benefit that they had, visual scar satisfaction score over and above the open surgery. So we have moved on to transaxillary approach for neck dissection, which is a novel technique which was first started again in South Korea in 2013. Modified, there are many modifications of it. Some have attempted gasless, that means they don't use any gas to create a pneumo inside. And these gasless approaches are also now being practiced, but with a wider incision. So multiple approaches that are present nowadays with different names are Tara, Baba, Aba, Mind. These are multiple approaches by which neck dissection can be done. So what we use is basically a Baba approach at our center, wherein we use these four blue lines are basically the ports that we insert during the robotic surgery. And these four ports are basically 8 millimeter ports in which we insert the instruments and the camera, so as to go tunnel it below the skin and do the neck dissection. So I'll just play the video that I have done a Baba approach for oral cancer neck dissection. So if you see in this approach, these are our port placements. We place four ports. The markings are basically on the anterior chest wall and anterior axillary line. So these are the four ports, and the first incision is usually taken on the left side, which measures around 2 centimeters to 3 centimeters. And from that incision, we insert the port. These are the ports that we use for inserting it. So once that incision is taken, we create a tunnel over and above pectoralis major muscle, and we reach up to the second port and give a stab incision and then insert two ports. After inserting both the ports, we use camera and a monopolar scissor to create a subcutaneous plane, which is towards the opposite side, that is crossing the midline and going up to the site of third and fourth port. So as to we create a working space, and during the surgery we encounter internal mammary perforators which we coagulate. So once you have reached on the opposite side, you insert with the help of trocar third port and the fourth port. So the instruments that I use during the surgery are basically a monopolar scissor, Maryland bipolar forceps, and fenestrated bipolar forceps. So once this tunnel has been created and you have all the three instruments, surgical instruments inside the working space, then from below upwards towards your lower border of mandible, you create a tunnel. So this is how, once all the 4 ports inserted, the appearance looks like. All the 4 ports in situ and 4 instruments in situ. So then we continue with the robotic neck dissection upwards towards the lower border of mandible. And if you can appreciate in this video, these are the 2 sternocleidomastoid muscles, and this is a suprasternal notch area. So with the help of one of the bipolar forceps, we retract the skin and create a tunnel. So with this entire approach, we do a subplatysmal flap raising up to the lower border of mandible, and also during this surgery we preserve cutaneous nerves which come laterally so as to maintain the sensation on the clavicle and in the anterior chest wall area. So if you see in this is the subplatysmal flap raising over the sternocleidomastoid muscle which is going on. And then we go on to the lower border of mandible. Basically, this is the platysma void area in level, this is the area of level 1A, wherein you will see platysma on both the sides, but in midline, there is no platysma, it is the subcutaneous fat which is visible. So after doing the entire flap raising, we take out a fibrofatty tissue between both the bellies of digastric, clear level 1A, and then we flip over this tissue to go to clear next level 2, 3, 4. So in the space that we have created, we park this tissue in the supraclavicular area on the opposite neck side where we have created a space. And then we start with delineation of sternocleidomastoid muscle. This is the omohyoid muscle. And if you can appreciate, there is IJV, which is palpable, and EJV. So we then create a tunnel below the sternocleidomastoid muscle and use one of the instruments as for retracting the sternocleidomastoid muscle, and then do the clearance of the fibrofatty tissue in and around anterior, medially, and lateral to the sternocleidomastoid muscle. So during this entire procedure, we make sure that the internal jugular vein is preserved and spinal accessory nerve dissection, the tissue around the spinal accessory nerve is done without causing any thermal injury to the spinal accessory nerve or to any of the other vital structures. So what we do in this case in our technique is basically we go above the spinal accessory nerve and below the spinal accessory nerve with the help of camera and instruments, and we do the dissection without touching it. We also preserve our common facial vein up to the lower border of mandible and facial artery so as to give our plastic surgeon a full length of vessel to do anastomosis. So this anastomosis is achieved basically by giving a small 2 centimeter or less than that incision in the neck fold and then bringing out these vessels outside and doing an anastomosis with the flap that has been inserted. So this is how the facial vessels are clipped and preserved the entire length. And I'll just fast track the video. Once the entire tissue has been gathered, level 1B, level 1A, 2, 3, and 4, this is collected in a plastic bag which is inserted through one of the ports, and after the hemostasis is achieved and a thorough wash has been given, the tissue is brought out through the first incision, thereby avoiding any possible seeding of the cancer cells. Now, this is how after the closure all the 4 ports look. One of the patients and his outcome after robotic surgery. This is a tongue CA which we had operated, and the outcome in terms of shoulder function. his speech, his shoulder movements. So the outcomes are as good as an open surgery. Cosmetically, it is definitely better than an open surgery. Shoulder dysfunction is also something which we are prospectively in our data. We are gathering data right now. We have done 30 plus cases of BABA approach for oral cancer neck dissection. And we are seeing that oncologically it is a safe procedure. Same patient, even the marginal nerve paralysis rate and handling of spinal accessory nerve is quite low as compared to an open approach. So as compared to an open case, definitely scar satisfaction is much more in this. So the indications for robotic surgery in head and neck space are evolving, and with surgeons adapting to the robotic platforms, the skill set are getting advanced, and skill sets are getting further more sharper. So right now it is used for early oropharyngeal malignancies, for neck dissection, for parapharyngeal masses, and for thyroidectomies. So the benefits are manifold. Definitely, the main benefit that I haven't spoken till now about the BABA approach is that the entire surgery is done in a virtually bloodless field. In all the surgeries that I could do, I have used less than one gauze piece for controlling the bleeding. So our blood loss has been minimal. That is, maybe you can say it between 5 or 10 ml. Patient have got faster recovery as there are no sutures placed in the neck, no possibility, zero possibility. In fact, till now, zero surgical site infections. Even with free flap cases, our precision is more. Our lymph node yield has been marginally higher as compared to similar open cases that we do. Patients have been faster in recovering in terms of neck movements, in terms of shoulder movements, and we are in the process of maintaining long-term data. And it also, robotic surgery also helps us in avoiding surgeon associated tremors, which is natural with age. It is possible that every surgeon might encounter. There is also minimally reduced shorter hospital stay, I should say, by a day in cases wherein we are doing primary closure, as compared to those cases wherein we do free flap, the hospital stay has not reduced much. So another study, this is basically a study for modified BABA technique, wherein it was found that the surgical time has reduced over a period of 80 cases, and it has also shown that the patient, this is an oncologically safe procedure in terms of the oncological clearance and lymph node yield. This is our data right now that we are still maintaining. So our this is the console time, but our active instruments time have come down to 204 minutes average. So I'll finally conclude that the benefits of having a transaxillary approach is better control, better vision, better working space for the surgeon in doing neck dissection. It also gives a superior cosmesis for our patients. Also, it's a truly minimally invasive surgery as compared to a retroauricular approach. The blood loss is hardly 10 ml or lower than that. We have got zero infection rate and definitely better oncological clearance. Also, our lymph node yield is 29.06 till now. And similar cases that we are tracking for open approach, our lymph node yield is around 26. So as per ASCO guideline, minimum is 18 for selective neck dissection. And yes, everything comes with some drawback also. So yes, there is a long learning curve and definitely a cost which is on higher side as compared to an open approach. But definitely this is the way future. If possible, we should give such options to our patient and give them a better quality of life options. So I conclude my talk by saying that there are no secrets to hard work. It is a result of preparation, hard work, and learning from failure. So if we don't give a best option to our patient, it itself is also a kind of failure. So the best option, in the sense, option of any less invasive surgery should always be given to our patient if it is indicated as an SLNB, if it gets established, or right now as a robot assisted neck dissection surgery in oral cancer cases. Thank you so much for patient hearing.
Thanks, Dr. Yash Mathur, for your mesmerizing and you thrown light on robotic surgery and how it is effective. And I think it would be a future actually that we are getting even 5 to 10 ml of blood loss, very low scar, minimal infection. So this would be a definitely a good quality of life, good recovery, etc. So it's being a future. Anybody who want to ask any question, they can unmute yourself and ask question to Dr. Yash Mathur. He is a leading oncosurgeon from SGG Center. So you would be, getting clarity if you want to, refer or you want to any plan for your, oral cancer cases, with the tongue cancer and all.
So I'll be more than happy if anyone would like to ask any question.
There is a one feedback, Dr. Mathur, from Dr.
Yes.
Hassan Imran. Good presentation, awesome. So I'm just passed on that. So
Thanks
if
a
you
lot.
can stay with us, you can stay. Maybe if any questions come, I'll come back to you for the query. Very
Sure.
interesting session, Dr. Shipra Deshpande, she is saying. Good.
Sure.
So nice. You given us your precious half an hour in this quite busy weekend. And with your permission, we are
Hello,
moving.
Yash. I have a question.
Yeah.
So, very good presentation, and that was a nice display of the skills as well as the techniques that you have discussed and shared. So, this is Dr. Asim Mishra. Yeah.
Hi.
Hello. So, I would like to know, like, initial part, you would be definitely using a surgeon directly raising the flaps and other things, even in Baba and these techniques. So, what is the learning curve according to you?
So learning never stops. It
In
is
learning curve
always,
in terms like the one person who starts doing thyroid in
yeah.
Baba technique, and like what is the learning, how many
Yeah.
surgeries, and yeah.
So at least before, I would say, independently operating, one should have supervision for at least first 5 surgeries. First 5 surgeries, at least there should be someone who is supervising you, and then developing your own set of movements and skills. It might take up to 10 surgeries at least, or maybe 20 surgeries. It depends on an individual, but minimum 10 surgeries is what I would think is required to, for an individual to say yes, in his own set of hands, he is now good enough to go ahead and do Baba or Baba approach for neck dissection. Doing thyroid with this approach is relatively easier as compared to doing neck dissection. Also, the reason is clearance of level 2B. So, because the reach of the instruments up to level 2B is at times not possible. It is also, the reason is also different kinds of patient that we treat. Some patients might have longer neck, some patients might have bulkier neck. So reach of instruments is also a challenge. So at least 10 cases, I would say, is something which someone should do either under supervision or at a center where these procedures are regularly done.
Thank you so much.
Thanks, Dr. Mathur, for responding to the query of Dr. Asim Mishra. Dr. Asim Mishra is a speaker and he would be joining after Dr. Divya. So with your permission, Dr. Yash, we'll moving on to our next speaker, next session, Dr. Divya Raj. Should we?
Thank you.
Yeah,
Yeah, please.
Okay. Thanks for joining us. Yeah. So we are moving to our next session. We have privilege that we have, a great, what I would say, dental surgeon who is associated a long time in head and neck oncology, and she would be throwing light on the complication, basically complication of head and neck cancer and all. And let me introduce her formally, and then we'll move to the next presentation. I'm just giving the present. Yes. So Dr. Divya Raj, she is from Trivandrum, and she is medical. She did his medical university from in 2020. Did MDS in oral pathology and microbiology from Kerala University. She has first rank holder and the best outgoing student of Raja's uh, Dental College of the year 2002, and a university rank holder for her MDS examination of year 2015. She was awarded Best Postgraduate Research Dissertation in the State Award Shastra Puruskaram 2015, and the Best Poster Presentation Award at Indo-Singapore International Conference on Head and Neck Cancer in 2015 for her thesis Frequency of Human Papilloma Virus Infection in Oral Squamous Cell Carcinoma and its Clinical Significance, a retrospective study. She was also awarded UICC Technical Fellowship in the year 2017. She is also member of the panel of experts of the Kerala State Council for Science and Technology. Presently working as associate professor and officer in charge in the dental division, Regional Cancer Center, RCC Trivandrum, renowned cancer center in southern India. She has got more than 20 years of experience in the field of dental oncology. Her area of special interest include prevention of radiation associated complication in oral cancer patients, pre and post treatment dental care cancer patient, prosthetic rehabilitation, oral cancer patients following surgery. She is received training from National Dental Center, Singapore, and Tata Memorial Hospital, Mumbai, in the field of dental oncology, maxillofacial prosthetics, and in essential of palliative care from Indian Association of Palliative Care. She is a life member of the Association of UICC Fellows and Multinational Association of Supportive Care in Cancer and Indian Association of Oral and Maxillofacial Pathologists. She is active involved in various national and international research projects and various research publication on her credit. If I'm missing any point, Dr. Divya, you can add on. And you are our regular, speaker. You have spoken multiple our previous editions and all. So over to you. You are visible, and just please share your slide and continue.
My screen is not getting shared. I will join once again. Sorry for the delay.
No issue, no issue. You can join. You disconnect and connect again.
Okay, okay, okay.
Yeah. Dr. Divya is facing an issue while sharing her slides. So we are waiting her to join again. Maybe she would able to share her slides presentation now. We are just waiting for her. Sorry for the inconvenience. We are on the mark on time. We are just say 23 minutes lagging. So we are going as per our scheduled time. Yeah, Dr. Jivya join again.
Am I audible?
Yeah, you are audible. You
And
are audible. Your
my slides are
skills.
visible.
Yeah, your slides are visible.
Okay. Thank you for giving me opportunity to speak in this esteemed international conference. And next 15 minutes, I will talk about the oral complications of cancer treatment and its management. Now you can see these are various articles which are published in various journals, including Lancet in 2025 and 2026 regarding the importance of dental oncology in cancer treatment. All these articles states that inclusion of dental professionals in the multidisciplinary cancer team will help to improve the quality of life of cancer patients. Now, why we want to treat oral complications during cancer treatment? Because most of these oral cancer patients during treatment will have difficulty in eating, talking, chewing, etc. And this can affect patients' quality of life. Even the treatment dose has to be lowered or changed, or we have to change the treatment schedule. The treatment has to be delayed, or sometimes the treatment has to be stopped only because of these oral complications. So it is very important to manage oral complications. Coming to the oral complications of chemotherapy, most of you are aware about oral mucositis infections, which are viral, bacterial, fungal, bleeding from the oral cavity, xerostomia, dental caries, alteration in taste, neurotoxicity, and changes in dental growth and development if we are giving chemotherapy or radiotherapy to patients patients during their childhood. Coming to the oral complications of head and neck radiotherapy, they are mucositis, xerostomia, trismus, radiation caries, and osteoradionecrosis. How we will manage these complications? First, let's see about oral mucositis. Oral mucositis is an inflammatory-driven process which causes cell death of the epithelium. It is usually seen 4 to 7 days after starting up of chemotherapy. Certain risk factors may hesitate the development of mucositis. These are type, dose, and schedule of radiotherapy or type of cytotoxic drugs which we are using for chemotherapy. If we are using chemotherapy along with radiation, there is more chances of developing mucositis. Patient-associated factors like age of the patient, their other comorbidities, if there is any mucosal trauma due to some ill-fitting dentures or sharp tooth, their oral hygiene is poor, then there is more chances of developing oral mucositis. This is a WHO scale for grading mucositis. There are usually 4 grades of mucositis. This is the initial stage, which can even proceed to stage 4. During that time, the patient will find very difficulty in swallowing, chewing, etc. So in this stage, we have to depend on nasogastric tube for feeding. Coming to the management of oral mucositis, our prime aim is to eliminate the infection and irritation, for which we can give anti-inflammatory agents, antimicrobials, coating agents, anesthetics and analgesics can be given. And we should ask the patient to maintain thorough oral hygiene. If their oral hygiene is poor, suddenly this grade 1 mucositis can change to grade 4. And we can ask them to avoid tobacco, alcohol, and other carbonated drinks. They can take soft, bland diet if possible. and maintaining adequate hydration is also important. Some studies had shown that photobiomodulation using low-level lasers will help in healing this oral mucosal lesions. But I don't have any personal experience in using this low-level laser. So, but most of the literature states that we will get much benefit from using low-level lasers. Coming to oral infections can be either bacterial, fungal, or viral. This occurs due to changes in the oral microflora due to chemotherapy or radiotherapy. Some chemotherapy drugs will cause myelosuppression that will also predispose to development of infections. Impaired host defense mechanisms, salivary gland dysfunction. This usually occurs in patients who are undergoing radiotherapy. Their mouth will be very poor in secreting serous saliva. In such cases also, we will see they are more prone to get oral infections. Poor oral health and hygiene. Coming to oral candidiasis can be seen in various forms like pseudomembranous candidiasis, erythematous candidiasis, angular cheilitis, or even hyperplastic candidiasis. We can manage this candidiasis with the use of topical polyenes or azoles. If patient is not getting any relief from this topical agents, we can give them systemic antifungal medications such as fluconazole. Viral infections like herpes simplex and varicella zoster are very common. This is managed with antiviral drugs, and the pain can be managed with analgesics. And in this case also, proper oral hygiene is important. Coming to bacterial infections, the mucositis can appear with a superadded bacterial infection. We can see dental abscess, periodontitis, parotitis, etc. In those cases, we can give antibiotics, anti-inflammatory agents, analgesics for relieving the bacterial infections, and also we should reinforce about the oral hygiene. Coming to xerostomia, most of the patients after who are taking almost around 45 gray of radiotherapy develops xerostomia. The xerostomia that can be due to salivary gland hypofunction. When patients are undergoing this radiotherapy, usually the serous acina of the salivary gland will be affected. So watery saliva will be decreased, serous saliva will be decreased, and patient will have thick ropey saliva. In such cases, the patient will experience taste disturbances, difficulty in chewing, impairment in swallowing and speaking, and even this can predispose to development of caries. How we can manage this xerostomia? Certain lifestyle modifications are there. That is, we can ask the patient to take frequent oral sips. This will help to moisten their oral mucosa. And again, we should ask them to avoid alcohol and caffeine, spicy, sour, and acidic food. If they are having very sticky mucosa, then we can ask them to apply olive oil or ghee or butter so that there will be a lubricating effect on their oral mucosa. Some of our radiation oncologists ask the patient to use vitamin A capsules for applying into the oral mucosa. This will also help to improve their moisturizing effect in the oral cavity. I already told you that all these patients will have thick ropey saliva. So for reducing this thick secretion, we can ask the patient to use sodium bicarbonate saline mouth rinse. How we can prepare the sodium bicarbonate saline mouth rinse? Into 1 glass of warm water, we can add 1 pinch of salt and 1 pinch of sodium bicarbonate. This can be used to gargle their, this can be used as mouth rinse several times in a day. So this will help to improve the, reduce the thick secretions, and they will get a soothing effect in the oral cavity. Commercially available saliva stimulants and saliva substitutes are also available. Saliva stimulants are available in the form of chewing gums, lozenges, etc. And these are available in our this part of the country. That is, this is a wet mouth. This is available in the form of a solution. This is a spray. And even gels and Bioxtra gel is also available. If patient is not getting any benefit from these topical agents, we can add on systemic agents like pilocarpine. Coming to taste disturbances, most of the post-radiotherapy or post-chemotherapy patients will complain of altered taste sensation or no taste sensation. This post-radiotherapy patients frequently complain about inability to eat spicy food, typically this red chili. They can't tolerate red chili. In those cases, what we ask them to do is take pepper instead of red chili. Yeah, most of the time, patients can tolerate pepper. If we can, they can tolerate pepper, they can avoid red chili, and they can move on to pepper. And even zinc supplements will also help to improve their taste sensation. Then coming to trismus, when the patient's interincisal distance is less than 35 millimeter, then it is known as trismus. This can occur either due to tumor invasion. Sometimes retromandibular, if the lesion is in the RMT area, retromolar trigone area, then it is extending to the medial pterygoid or lateral pterygoid plates. The patient will have severe trismus. Otherwise, the cause of trismus is tissue fibrosis. This tissue fibrosis may be due to surgical scar contracture or due to tissue fibrosis due to radiotherapy. In such cases, the patient will have a difficulty in speaking, swallowing, and their poor oral hygiene is also very poor. And these are some pictures. This is the normal mouth opening, and this is one of our patient who was treated for carcinoma buccal mucosa. Only wide excision and primary closure was done for this patient. Even then, this patient is having severe trismus due to scar contracture. See the interincisal distance. It is less than 10 millimeters. In such cases, we can ask the patient to do stretching exercises. In my experience, actually, stretching exercises using fingers is the best one for correcting the trismus. And even they can use tongue blade for using stretching. This will also give benefit for the patient. At least the stretching exercises has to be done 60 times a day. That is 20 times in the morning, 20 times in the evening, and 20 times in the afternoon. By doing this stretching exercise, most of the patient will get benefit within a month. Other agents like dynamic bite openers are there. This is a screw gauge, and this is a Therabite, and Heister's mouth opener are also there. This will also help to improve the mouth opening. Coming to radiation caries, mostly approximately 30% of the patients who are treated with head and neck radiotherapy develop radiation caries. This reduces the quality of life of the cancer patient, and also this can predispose to osteoradionecrosis of the jaw. These are the various stages of development of radiation caries. Here you can see the superficial enamel changes. See, after seeing this, we can identify that, oh, this patient is prone to get radiation caries. In this stage, if we try some agents for preventing radiation caries, a patient will get benefit. This is the second stage. Here, the enamel will become brown or blackish pigmentation. In such cases, even if we do the fluoride application or some preventive measures, we won't get much benefits. So the radiation caries has to be managed from the initial stage itself. And this is the third stage where the demineralized spots, enamel cracking occurs. And this is the final stage where the entire crown is amputated. Coming to pathogenesis of the radiation, the radiation caries can be either due to direct effect of radiation or due to indirect effect of head and neck radiotherapy. The direct effect is directly on the chemical and biochemical combination of the tooth, and it can even decrease the enamel micro hardness. Indirect effects are due to hyposalivation, patients' high keriogenic diet, inadequate oral hygiene, oral microbial shift. Most of the studies have shown that in this post-radiotherapy patient, they will have higher amount of lactobacillus count in their oral cavity, and this will predispose to caries. And even after radiotherapy, this patient's pH in the oral cavity will become acidic. In those cases also, the enamel, calcium hydroxyapatite will leach in the acidic saliva, and this will predispose to development of radiation caries. How we can prevent this radiation caries? We should all be aware about this radiation caries. That is, if the patient is going for radiotherapy, then for the head and neck region, there is this patient will develop radiation caries, and we should try to prevent that in the initial stage itself. And various studies have proven that if we can provide proper oral care before the starting up of the treatment, then those patients will get benefit from this developing radiation caries. And those patients who are non-compliant had more chances of developing radiation caries than patient with good compliant. For preventing radiation caries, we can ask the patient to maintain good oral hygiene. They can brush their teeth with fluoridated toothpaste and ultra soft toothbrush 2 to 3 times per day. Interdental cleaning is also must. Nowadays, we will get that water flows, which is much better than other interdental cleaning aids. And fluoridated mouth rinses can be also used. We should advise the patient about non-cariogenic diet. Their xerostomia should be managed. We can even apply fluoride for preventing radiation caries, and tooth remineralizing agents are also available. This is coming to the fluoride therapy for preventing radiation caries. What we use in our center is professional application of neutral sodium fluoride. And first application of this neutral sodium fluoride will be done before starting up of radiation. And then every once in 3 months, the patient should undergo professional application of neutral sodium fluoride for preventing radiation caries. We can also advise the patient to use fluoridated toothpaste and mouth rinses. These are some commercially available neutral sodium fluoride gel. This is fluoride mouth rinse, and this is fluoride varnish. If the tooth becomes damaged, then it is better to use composite resins and adhesive systems. Studies had shown that, from my experience also, glass enamel cement and resin modified GIC had more restorative failure rates. If endodontic treatment is possible, we can advise the patient to undergo root canal treatment under antibiotic coverage. Coming to osteoradionecrosis, here the devitalized bone exposed in the oral mucosa in patients who had undergone radiotherapy. It is usually common in mandible. It can occur either after a traumatic event like dental extraction or spontaneously, even in the absence of malignancy. This causes local infection and also can even predispose to fractures. This is one of my case who developed osteonecrosis of the maxilla. Coming to the management of osteonecrosis, we can, in our center, what we use is, initially we will do conservative treatment using antibiotics and mouth rinses. And if the exposed bone is mobile, we will do gastrectomy. And some studies had shown that pentoxifylline combined with vitamin E is beneficial in managing osteoradionecrosis, but it's very difficult to tolerate this pentoxifylline because the patient will complain of severe gastric irritation. And surgical resection can also be done if the patient is willing to undergo a surgery for this osteoradionecrosis. We can remove the necrosed bone. Segmental mandibulectomy can be done, and that area can be reconstructed with flap. I don't have any personal experience with hyperbaric oxygen therapy, but I don't know whether that will only 1 or 2 of my patients went for hyperbaric oxygen therapy to some centers, and then they have spent lakhs and lakhs of rupees. But they won't, I will advise from my side that surgical resection is the best if we can do surgery for osteoradionecrosis. Coming to the prevention of osteoradionecrosis, we should always avoid tooth extraction in a patient who had undergone radiotherapy for head and neck cancer. We can do endodontic therapy wherever possible. If we are planning for any extraction, we should discuss to the radiation oncologist regarding the field and dose of the radiation. Then only we can establish the risk. And we should get a consent from the radiation oncologist and also from the patient. We should tell the patient that there is a chance of developing osteoradionecrosis. So if you are planning for extraction, then it should be done under prolonged antibiotic coverage, minimal trauma, and suturing should also be done. Another entity is medication-related osteonecrosis of the jaw. This usually occurs in patients who are taking bisphosphonates, that is anti-resorptive drugs, in case of patients with multiple myeloma or in patients with CA breast or prostate who are having bone metastasis. They will be treated with bisphosphonates. In such cases, there are more chances of developing medication-related osteoradionecrosis. There also, there will be an exposed bone which is there for more than 8 weeks without any, there can be a oroantral fistula will be there, or it can occur anywhere in the maxillofacial region, and there should not be any bone metastasis in those patients. And this way, the common signs in here also, the common signs are pain, infection, purulent discharge, foul smell, and non-healing extraction socket. Sometimes the CA breast and prostate patients will go to the dentist and will do the dental extraction. They won't tell the dentist that they are undergoing this bisphosphonate therapy. In such cases, sometimes the extraction wound won't get healed after the extraction. In such cases, they are more prone to develop medication-related osteonecrosis. Management is of osteoradionecrosis due to medication is also similar to that of osteoradionecrosis. There also we can do the local debridement of the exposed bone, antibiotics, antibacterial rinses. In our center, what we used to give is Ciplox 500 milligram twice daily for 10 days. First 10 days of the every month, first 10 days, they have to take this Ciplox and Ciplox 500 milligram twice daily. Along with that, from my side, I have seen that patients who are using betadine gargle, 5 ml of betadine in 1 glass of water, to which add 3 drops of hydrogen peroxide. That can be used to rinse their oral cavity. This will give a benefit. This will help to reduce the inflammation and also that purulent discharge. And combination of pentoxifil and tocopherol and surgical resection can also be done. Coming to oral complications of head and neck surgery. Here in these pictures, these patients had undergone a segmental mandibulectomy for CA tongue, and we can see that their mouth opening is reduced. Their occlusion is not correct. So they have altered orofacial structures. Sometimes there will be drooling of the saliva. Sometimes there is increased saliva or decreased saliva. Their function, they won't be able to chew. And their oral hygiene is very poor, will be poor, very poor. And in such cases, we can do certain prosthetic rehabilitation. This is a case who had undergone inferior partial maxillectomy for carcinoma maxilla or palate. In such cases, we can give obturators for closing this oroantral fistula, and this will help to improve their speech and swallowing. This is a palatal ramp prosthesis which is used in patients who had undergone segmental mandibulectomy and having segmental or hemimandibulectomy and having malocclusion. This palatal ramp prosthesis will help to correct their occlusion. Guiding flange can also be used. This is a palatal augmentation prosthesis which is used in patients who had undergone total glossectomy or near total glossectomy. This will help in swallowing. And nowadays, there are so many implant-supported facial prostheses are also available. Other dental considerations, we dentists should always regularly follow up these cancer patients for ensuring their oral hygiene protocols, for applying sodium fluoride if the patient had undergone radiotherapy for head and neck cancer. And we should also regularly reinforce them regarding the importance of habit cessation. And their other complications can also be managed during the follow-up sittings. And in all post-chemotherapy patients, we can do dental procedures if the hematological indices are normal and should be done under antibiotic coverage. Always we should keep in mind that patients who had undergone radiotherapy for head and neck cancer are in a lifetime risk of developing osteoradionecrosis of the jaw. And if we have to fabricate definitive processes or dentures, that can be done 6 months after the treatment, and orthodontic treatment 1 year after the treatment only if the patient is disease-free. With this, I conclude my speech telling that cancer treatment saves life, but preserving quality of life is equally important. Dental oncology bridges this gap by preventing complications, restoring function, and supporting patients throughout their cancer journey. Thank you.
Thanks, Dr. Divya, for your presentation on complications, and basically more we have thrown light on caries during cancer therapy and chemotherapy. Anybody, Dr. Shipra Deshpande saying very good presentation. Anybody want to ask any question, or they can put the question on chat box. Actually, we are lagging 20 minutes, so we have bound to go to our next speaker. So Dr. Divya, if there is any questions coming, you can answer on the chat box, or we'll take it on the after Dr. Asim Mishra's. I'll request you you can stay here for some time.
Okay.
Yes. Yeah. So, we have the privilege that Dr. Asim Misra is with us, and he is also our speaker in our last edition. And last time he has spoken, he has spoken on margins of oral cancer, and again this year he is talking about margins and micro involvement in oral cancer. He is known to people who are into oncology because he is from prestigious Mahanama Pandit Madan Mohan Malviya Cancer Center and Tata Memorial Center, Varanasi. But as a moderator, I have to give her for formal introduction. So let me introduce Dr. Asim Misra. He is a professor, surgeon of surgical oncology, and currently heads head and neck services at the Mahanama Pandit Madan Mohan Malviya Cancer Center and Tata Memorial Center, Varanasi. Trained at Premium Institute, he completed his MBBS from Vijayanagar Institute of Medical Sciences, MS ENT from Grants Medical College with a University third rank, and MCH in head and neck surgery from Tata Memorial Hospital, Mumbai. His professional journey spans roles as senior resident, clinical fellow, assistant professor, associate professor, and then promoted to professor, reflecting over a decade of dedicated service in head and neck oncology. Dr. Misra's clinical expertise include comprehensive management of head and neck cancers, mandible reconstructions, post-treatment surveillance, and outcome research. His research interests focus on oral cancer epidemiology, early detection strategies, tobacco and polysubstance use, imaging-based response assessment, and multidisciplinary treatment approaches. He has contributed extensively in peer-reviewed literature with 59 documents, 902 citations, around 871 citing documents, and including publication in Cancer Journal of Clinical Oncology, BMC, Oral Health, and other high-impact journals. He has participated in landmarks, randomized trials, and multi-center epidemiological studies. Through academic leadership, clinical excellence, and impactful research, Dr. Mishra continues to advance evidence-based head and neck oncology in India. Dr. Asim, if I have missed anything, you got any, any recognition, any award recently, you can add on because it is our previous profile. So you can add on. If I missed anything, your slides are visible, you are audible, you can continue.
So thank you, Dr. Nurul, for the kind introduction and for giving me this opportunity on this platform. And I chose this topic. Last time it was margins, and this time I've added a microenvironment in that margins. So this is not just because I felt like I have to do something or change the topic. It is because as we are evolving the last 15 years, margins have changed to microenvironment, and it is not only the margin that is important, it is also important where that margin lies. And in the management of oral cancer, because oral cancer is primarily treated by surgery followed by adjuvant treatment. And that adjuvant treatment is governed by several factors, and margin is one of them. So whenever a surgeon operates and he looks at the histopathology report, it's more like a examination report or examination result card of the surgeon. So that margin is something which is only under the control of surgeon, and therefore understanding the biology is very important, because the microenvironment plays the important role of biology. So margin without microenvironment, even if it is a free margin, may not be useful. So a complete picture will only come when we look at the entire tumor. So now what is margin? Now, as we can see in this picture, there is a central yellow part, which is the tumor or the cancer cells. And whenever this tumor is excised or removed from the body with an adequate tissue cover all around it, when we can see that there is a good cuff of the normal tissue all around it, that is a negative margin. Now, negative margin is also measured in terms of certain distances, like 1 millimeter it is involved, 1 to 5 millimeter it is closed margin, and more than 5 millimeter it is free margins. Similarly, if the tumor is excised such that one of the edges of the tumor or any or more than one of the edges of the tumor are at the margin, that becomes a positive margin. So the normal tissue cuff must be there to call it an adequate resection, and that adequate cuff of tissue should be at least 5 millimeter in distance. Now, this is as per the existing criteria and guidelines. So what is post-operative margins and how are they governed? So we have to understand certain basic characteristics of the human body. And elasticity and compliance is something which is a basic mechanism of the human body. What we call it is resilience in the spirit of a person. Similarly, there is tissue shrinkage. So that tissue shrinkage or resilience must be there all the time. And whenever we cut a tumor, we place a knife or cautery at a distance and we remove it. As soon as we cut it, there is almost 20 to 40% of the tissue shrinkage. So suppose we have resected something taking a wide margin of 1 centimeter. This 1 centimeter can be finally measured to somewhere around 5 to 6 millimeter only because of the tissue shrinkage. So we have to understand that when we are looking at the post-operative surgical margin, the first thing that we must consider after resection, the tissue shrinkage is going to happen, and we have to resect even more. The second thing that is important is everybody who is operating is going to send that tissue for histopathology report to the pathologist, and that tissue will be sent in formalin. So whenever we are going to place that tissue in the formalin, we know formalin fixes the specimen. Now, when the formalin is fixing the specimen, it is going to actually dehydrate the cells so that the cells can be preserved, the architecture can be maintained. And as the dehydration happens, there is further 10% shrinkage. So the final shrinkage can be somewhat upwards of almost 50% in some cases, based on the site of the tissue and the size of the lesion and the nature of the mucosa that is being resected. So we have to consider those two characteristics for assessment of the final margin. Now, third part that we have to be careful is about field cancerization. What is field cancerization? So whenever we develop cancer, because oral cancer is primarily caused by carcinogenic like tobacco, alcohol, and even trauma. So entire area that is going to be there may be afflicted by the carcinogen, and the tumor along with that surrounding area may have changes, and that changes may be either visible or may not be visible. So if they are visible in the form of some dysplastic changes, you can see the field cancerization from your naked eyes. So whenever such field cancerization changes like dysplasia or erythroplakia or something is there, we have to go even further around it to remove the entire specimen with tumor-free margins. Now, this is with a naked eye. So we are placing our knife at 1.5 centimeter so that if tissue shrinkage is there, at least there at the end of the surgery, we have around 7 to 8 millimeter of tumor-free margin. Then if we are seeing a gross examination and we are seeing a field cancerization, we have to go even further. So this thing makes us clear that as an aptitude for a surgical resection, the basics that guides us are good visual assessment and gross examination even before we are resecting the tissue. And this is going to improve the surgical outcome. And that is how the surgical training must take place. So gross examination is something which is going to give us an immediate feedback and help us remove the entire tissue with precision. So as I discussed, there are several factors which are tumor factors and patient factors that are going to affect our margin status. Like a tumor which is there in the floor of the mouth or in the tonsillar pillar. That means that any tumor which is near the muscular or directly in contact, the mucosa is directly in contact with the muscular layer, there the shrinkage is going to be more. Tumor which is there in the keratinized part of the mucosa, like in the dorsum of the tongue or in the cutaneous part of the skin or in the skin of the buccal mucosa, those are going to shrink lesser. If there is any tumor invasion, so if the tumor is having star-like or stellate pattern or extensive progression or worse pattern of invasion of type 5, those may have invasion beyond the gross examined boundary of the tumor. So those tumors will have to be examined properly. There may be submucosal disease. So many a times what we notice is when we are examining, the tongue lesion is just 1 centimeter to be on visual examination. But when we palpate, we can see surrounding induration. That surrounding induration must be considered before resecting. We cannot say it is a small tumor. That induration will make it a T4 tumor or even a larger tumor. So that is assessment intraoperatively and preoperatively is very important. Now factors like tumor budding or worse pattern of invasion type 5 where there is an isolated tumor metastasis from the boundary of the tumor to certain extent more. And this extent can be as high up to 7 millimeters or even more. Or if there is perineural invasion along the nerve, the tumor is spreading or there is field cancerization. So all these things and many more factors keep on coming to us as we do more and more cases, as we learn more and more about the biology, these list is going to get longer and longer. But as a surgeon and as we gain experience, we have to take care and we must take care of all these before we operate. Now, why margin is important? This is also a surgeon has to know that when we do not remove the tumor with free margin, that is at least 5 millimeter pathological free margin, the survival is going to go down. So a 5 millimeter tumor free margin is going to confer a better prognosis and absolute reduction in local recurrence. And therefore 5 millimeter margin, at least 5 millimeter margin is a must. Now, early oral squamous cell carcinomas, this was a study done by Sloan Kettering in New York. This study showed that the survival was as low as 66% versus 90% when the margins were less than 5 millimeter versus more than 5 millimeter. So we have evidence that margin is going to improve our survival. However, scientists went from 5 millimeter and they tried to push their limits. So what they started doing, they started saying, we will review that margin status. Can we bring it down further? So this was a retrospective audit done at Memorial Sloan Kettering, and they had resected the tumors properly, adequately. However, they had a subset of patients which had margins less than 5 millimeters. And whatever analysis they did, it showed that if the margin is 2.2 millimeter, even then they had better survival. Now, this was quite misleading article because all patients that were subjected to surgery were operated by an experienced surgeon. The intraoperative and the gross assessment of the margins was more than 1 centimeter at resection. However, incidentally, because of the biology of the disease, the margin had become 2.2 millimeter, and that was the study that did not write adequately. And it led to, and they started writing that they are going to redefine the close margin as 2.2 millimeter, and more than 2.2 millimeter, it will be free margin. Therefore, we at Tata Hospital analyzed and conducted a study on all buccal mucosa and also on tongue cancers. And what we found was that as we are resecting from 1 millimeter margin, 2 millimeter margin, 3 millimeter margin, as the incremental margin happens, the survival improves till 7 millimeter. Beyond 7 millimeter, there is no further increase. But till 7 millimeter, there is improvement in survival. So we cannot say, based on that one paper, that 2.2 millimeter margin is free. So in T1, T2 cancers, we need at least 6 millimeter margins. And in T3, T4 tumors, we need at least 6.5. So measuring 0.5 millimeter is very difficult. So we had got the cutoff of 7 millimeter. So it is very important that we take at least 7 millimeter margin. Now, a similar study on tongue cancer was also done, which showed that up to 7 millimeters, we had advantage of adding at least 15 months more to the local control as compared to when the margin was less than 7 millimeter. Now, we know that we will remove margins. We can remove 7 millimeter. We also can remove 7 centimeters. But removing everything is not going to help, because we showed that beyond 7 millimeter, it is not increasing, but still we are not able to achieve 100% survival. And the reason is we also have to look where the margin is. So the tumor is there in the tissue. And what is that tissue? The soil, if that is the normal tissue, and the seed is the tumor is growing. So we also have to analyze the normal tissue. And that normal tissue has so many different immune cells. Even a small insect bite is there, there becomes an erythema or red dot or anything that happens, there is an inflammation. And when there is a tumor which is growing, there definitely is going to be more and more reactions and tissue reactions that are going to happen around it. And that is the microenvironment in a normal sense. And that microenvironment is full of macrophages, regulatory T cells, dendritic cells, endothelial cells, fibroblast, and many, many inflammatory markers, and many, many different types of immune cells. And therefore, it is important that we understand both how the tumor is talking to the body, or the how body is behaving with the tumor. So we said that the microscopic spread beyond the gross disease is an adverse prognostic factor. And how we said that was that whenever a tumor is going beyond that normal boundary, it is because the tumor wants to jump and go and spread everywhere, or whatever is the nature of the tumor, the biology of the tumor. So whenever a tumor is going beyond the gross disease, that means it's a bad biology. And that bad biology associated with bad prognostic factors. So whenever there is a tumor which is going beyond its limits, it is also causing more perineural invasions, more lymph node metastasis, higher depth of invasion, poor differentiation, and all those things are going to confer a poor survival. Therefore, it is not just the margin, but how the tumor is behaving in the tissue. We did another study on the pattern of invasion. So Brandon Jensler, they demonstrated 5 different types of pattern of invasion. So what we did was the low risk pattern, that is the pattern of invasion 1, 2, and 3, and the poor pattern of invasion, that is pattern of invasion 4 and 5. We compared them, and we found that whenever the pattern of invasion was 4 and 5, these tumors had higher perineural, higher nodal metastasis, and poor differentiation. May I request the please to mute yourself, please. Dr. Hemant, can you please mute yourself?
बात है कि मैं सुनने का मन तो है नहीं दो तो अगर मैं रहूंगा मैं रहूंगा ये लो मैं रहूंगा तो ही रिकॉर्डेड सेशन के
It's a request to please mute yourself while the presentation is going on. The host can mute the speaker. So the tumor microenvironment, and we analyzed the lymphocyte pattern of spread. And what we found that whenever the pattern lymphocytes had a continuous lymphocytes around it, those had a better survival, and they had a better disease-free survival as well as a better hazard ratio. And the lymphocyte pattern, that is the pattern 1 with a continuous infiltrating, so lymphocyte invasion is a better outcome. This was further proved that whenever there is tumor infiltrating CD20 lymphocytes around the stroma, they have a strong host response. So the body is fighting against the cancer and they have a better survival. Now, this was a study done at our own center in Varanasi, which showed that whenever there are some viral infections, this was done during the COVID-19 pandemic, and the COVID-like infections, like even the influenzas or any other similar infections, these can accelerate the disease progression. So patients will have upstaging of disease from T1 to T4 at a faster rate, almost the double the rate. Within a month, this patient progresses from T1 to T4 or even T4 to distant metastasis. So they have a higher incidence of distant metastasis and higher local recurrences. So we have to be careful when we are treating those patients to assess what is the neutrophil lymphocyte counts and ratios at that time of diagnosis. And that is going to help us identify the patients correctly and manage them and triage them. So this was one of our studies, and we are doing further studies on the similar pattern to see if we can identify such patterns. So what is the extent of microenvironment? That is also very important, because if we say that there's a 5 millimeter of tumor-free margin when the margin is free, there has to be some extent for the immune changes also. So what we did was we did a study at our center, and we just did a 32 patient study. What we found was the median distance of the microenvironment is 3 millimeters. And this is from 1 millimeter to as high as 9 millimeters. So certain patients have a small immune infiltration and response. Certain patients have immune response up to 9 millimeter of tumors. So we have to identify these different tumors and then treat them accordingly. We do not know whether it is good or bad. So that also needs to be classified further. But that is what we found, that lymphocytes in the microenvironment up to 9 millimeter, they have a very good prognosis. Only till 1 millimeter, have a bad prognosis. And all those things had been reported. So this is under publication, which will be soon up for publication. So we have to ensure that we achieve good margins. Till we have further evidence, we have to ensure that we place our knife at least 1.2 centimeter away from the tumor to get the tumor-free margin. Consider tissue shrinkage, field cancerization, submucosal disease, and do a good gross examination of the margin. Margin alone may not be the most significant factor in time to come, because margin along with the microenvironment and extent of changes will change the direction of the treatment. And that extent of changes must be recorded. We have proven that lymphocyte response in the microenvironment, that is going to improve survival. And prognosis of a cancer cannot just be based on a measurable distance. It's constantly changing and it's going to evolve. Thank you.
Thanks, Dr. Asim, for giving a very enlightening talk on margins, and it's very important because the recurrence is common in oral cancer, and also margin become very important. Anybody want to ask any question? We have very renowned oncosurgeon from Tata Cancer Hospital, Varanasi. So he is a very renowned oncosurgeon. And anybody having any having a patient you are treating, you want to get guidance and all, you can ask question here. Otherwise, you can ask question in the chat box, or you can also email to us, and I'll forward it to Dr. Asim for the query. Frozen section, please comment. Shipra Deshpande is asking that what is frozen section, please comment.
So the frozen section is whenever we are resecting the tumor and we want to assess the margin status or the tissue status, so what are we using the frozen section for? If we are using it for margin, most commonly it is used for margin assessment. So this gives us a guide if we can have a tumor-free margin at the time of resection. So the tissue is frozen, a section is cut, is stained by hematoxylin and eosin, and the pathologist tells us within half an hour if that margin is free. However, there is a drawback because only limited sections can be processed. So we have to be careful which section is being processed. If you have any specific question or comment on frozen section, you can please put up.
Any further queries?
Dr. Asim, I have one question, Dr. Yash here.
Yeah, please tell me.
I just wanted to know, with your experience, how often have you encountered that you have taken sufficient margin, grossly more than 1 centimeter or even maybe around 1 centimeter, and yet your pathologist on frozen section or maybe even in final histopathology might say that there was a small satellite tumor island which was around 1 centimeter away, not 1 millimeter or 2 millimeter away. So in such a case, if on one of the margins you have a island, isolated island of tumor, will you consider it as a positive margin or will you kind of increase your adjuvant treatment? What would you do in such a case?
So whenever histopathology has been sent, we have resected 1.5 centimeter and there is or even 1 centimeter and grossly the margins are free. And my pathologist is reporting that at satellite of 1 centimeter, small nodule is there. So it is going to be considered as a positive margin, no doubt about it. Now, whether I'm going to resect that margin or intensify my treatment, that depends upon the resection. If it is a small tongue, shabbily done, a surgeon who does not know how to operate, it has been operated outside and the margins are free or reported, then I'm going to re-resect it. But if I am sure about the surgeon that the surgeon has been very careful in operating it and just small nodule is making that margin positive, I am going to intensify my treatment. And that satellite is going to cause the margin involved. However, in practice, to find a nodule 1 centimeter away from the primary tumor, it is very less. We see in like 1 in 10,000 cases, such a thing may be there. Most of the times, whenever such a thing happens, there is a submucosal disease, or the disease is going till that part, or we are trying to resect with some compromising some status or trying to save a structure. Other than that, we never find that there is an extensive resection or the extent of the disease till 1 centimeter. On an average, it is around 2 to 4 millimeter or 5 millimeter max. But definitely there can be incidences like this.
Yeah, thank you.
Thanks, Dr. Ashim, and thanks, Dr. Yash, for a very healthy discussion. With your permission, Dr. Asim, we supposed to go to our next speaker, Dr. Shahida Nasreen. She is a radiation oncologist. So should we move to the next presentation?
Thank you so much.
Yeah, okay. There is a one clarification. She was asking actually how much correctness the same Dr. Shipra Deshpande was asking.
Okay. So the frozen section in predicting a good resection, if the margin processes, that is a gross examination has been done properly and the closest margin has been sampled properly, then frozen section is going to give us almost an accuracy of upwards of 90% in assessment of that particular margin if on frozen section. However, if you have processed anterior margin and your posterior margin somewhere there was a subcutaneous spread or a perineal invasion, then that may be missed. So grossing is very important, whether it is done by the surgeon or by the pathologist. Unless the orientation of the specimen is proper, that correctness may be wrong. So correctness depends upon the grossing and that, but otherwise, if it is grossed correctly, the accuracy is upwards of 90%.
Okay, Dr. Shipra is thanking you, Dr. Asim.
Thank you so much.
Yeah. So, Dr. Shahida, You can, meanwhile, you can share your slide and let me introduce you. Uh, yes. So we have
Good evening,
privileged.
all. Are my slides visible?
Not yet, but yes, now it's visible. Can you make it on a presentation mode, Dr. Shahida?
Yeah, let me.
Meanwhile, I am giving your formal introduction. Dr. Shahida Nasreen is an accomplished associate professor in Department of Radiation Oncology at Sher-e-Kashmir Institute of Medical Sciences, Srinagar, Jammu and Kashmir, where she currently holds a regular service position with a superannuation date 24. She earned her MBBS from Government Medical College, Srinagar, under the University of Kashmir, followed by an MD in radiotherapy, radiation oncology from Sher-e-Kashmir Institute of Medical Sciences in 2011. Her career trajectory includes progressive roles such as senior resident at the same Sher-e-Kashmir Institute of Medical Sciences, consultant and senior resident at Jaslok Hospital and Research Center, Mumbai, as well during 2012 to 2014. She's also consultant at Medanta, the MedCity Hospital, Gurgaon. She was assistant professor at Sher-e-Kashmir Institute of Medical Sciences between 2018 to 2022, and her current position since July 2020 encompassing full-time clinical practice, teaching, and research responsibility. With major research interest in radiation oncology and cancer epidemiology, Dr. Nasreen has extensively publication records over five past years, featuring studies on esophageal carcinoma, epidemiology and trends, low-grade gliomas, IMRT in prostate cancer, supervena cava syndrome, squamous cell carcinoma treatment patterns, endometrial carcinoma, nasopharyngeal carcinoma outcomes, and esophageal metastasis, gastric cancer, radiotherapy, and carcinoma cervix experience from Kashmir. Notable work include contribution to the Journal of Radiation and Cancer Research, Journal of Cancer Research and Therapeutics, and Indian Journal of Palliative Care, highlighting her impact on cancer research in regional context. Dr. Shahida, over to you. Your slides are visible and you are audible. And
Thank you, sir. Thank you so much for such kind words.
yeah, you can take a small break when the iftar times comes, and then
Thank
we
you,
can
sir.
continue.
Thank you.
Yeah. Okay. Thank you.
Good evening, everyone. I'm going to talk about the recent advances in radiotherapy in oral cavity cancers. Before going to the proper topic, I just want to stress on the point why we are talking about the oral cavity cancers as Indians. This is the data from the Globocon 2022. As per this, the total number of new cases in 2022 were 19,976,000 and total deaths were 9,743,000. And this is the scenario all over the world. As we see in top 5 malignancies, oral cavity and lip is nowhere in the data. Now we are moving to the India. The number of the new cases were 1,413,000 in 2022 and 916,000 deaths occurred in 2022. And when we see the top most malignancies in men, it is number 1 lip and oral cavity, and even in females at number 4 is the lip and oral cavity. This is the reason we are more concerned with the oral cavity malignancies in India. And one important thing is that this malignancy is preventable. So we should, because most of the risk factors are modifiable in case of the lip and oral cavity malignancies. That means up to 70% of the malignancies we can prevent. And as an Indian, we should put stress on these points, that we should take the preventive measures to decrease the incidence of this malignancy. As we see in the world scenario, they don't come among the top 5 malignancies, but in India it is number 1 in men and at number 4 in case of the females. Now moving to my proper topic, recent advances in radiotherapy in oral cavity cancers. As such, there is nothing different from the rest of the malignancies in case of the oral cavity which has advanced in radiotherapy. I will be talking in general for the malignancies, but more emphasis on the oral cavity malignancies. I'm going to complete my talk under the heading of radiotherapy techniques, imaging modalities, radiotherapy dose, and fractionation. First is the radiotherapy techniques, what we have gained since years. Radiotherapy given by the external beam radiotherapy or the internal radiotherapy, which we call brachytherapy. When we talk of the external beam radiotherapy, we have photon therapy and proton therapy and the heavy particle therapy. Talking about the photon therapy, when we talk of the technique, we have a conventional 2D radiotherapy, three-dimensional conformal radiotherapy, intensity modulated radiotherapy, image guided radiotherapy. First, we start to do the two-dimensional radiotherapy. As we see, we used to mark with a pen on the patient's body, and then we used to take this particular area. But as we know, parotid is located here, and that is inside our target volume. When we used to give the radiotherapy, either by the 3D conformal radiotherapy or by the 2D technique, we used to irradiate the parotid glands also. This is for the simplification. I am talking about the parotid gland. So the patient will have the lot of toxicities, side effects, early side effects and late side effects. And at the same time, we are not able to give the full dose to the tumor because rest of the normal tissues are also irradiated. That was the limitation of the 2D radiotherapy as well as the 3D radiotherapy. Then we moved to the IMRT. As you see here, this is the tongue lesion. And these are the nodal areas which we are treating. By IMRT, we can regulate the dose distribution. We can give high dose to the tumor and decrease the dose to the normal tissues. As you can see from the dose was, which is blue, we are giving full dose to the tongue, which is the tumor here, and parotid is severed. That means we will have a controlled tumor control, and at the same time, we will have less toxicities. When we talk about the advantages of IMRT, it is the improved target conformity. That means target is completely covered. That can produce internal dose inhomogeneity, which we call a dose painting. There occurs a better normal tissue sparing. And at the same time, IMRT technique enables us the dose escalation. That means we are increasing dose to the tumor and at the same time decreasing the dose to the surrounding normal tissues. And one more advantage of the IMRT is it can compensate for the missing tissue. If there is a missing tissue, we can put a compensator, and that can lead to the dose distribution to the tumor will be good, and at the same time, normal tissue toxicity will be less. But as with every technique, there is advantage, but at the same time, there are disadvantages. And the disadvantages include increased clinician time for target and the organ outlining because we have to contour it. It is a time consuming process. It needs extensive quality assurance programming because it is a higher quality radiotherapy technique. It needs a extensive quality assurance. So more time consuming, more expertise are needed, and increased machine treatment time. It takes time because we are treating with multiple beams as compared to the conventional radiotherapy, and at the same time increase planning time and increase integral dose. Low dose to the rest of the body is increased with the IMRT, which was not with the 2D and the 3D radiotherapy. There was a systemic review and meta-analysis of intensity modulated radiation therapy versus conventional two-dimensional or three-dimensional radiotherapy in head and neck squamous cell carcinoma. What they have concluded that IMRT significantly reduces the risk of moderate to severe acute and late xerostomia compared to 2D, 3D CRT in curative intent radiotherapeutic management of head and neck squamous cell carcinoma. So we moved from a less better technique to a better technique to the IMRT, from the 2D radiotherapy to IMRT. Then there was another technique which is in newest, that is the volumetric arc therapy. We call it a VMAT. What happens as we see in the IMRT, there is more time. A patient has to spend more time on the treatment machine for the treatment. What happened with the volumetric therapy? It can reduce the treatment time and comparable or improved dose distribution versus fixed field IMRT. In simple words, we have a same control as IMRT, but treatment time was reduced from the volumetric arc therapy. There was a multi-institutional comparison of volumetric modulated arc therapy versus IMRT for head and neck cancer. They included independent of institutional specific optimization strategies. The quality of the VMAT plans, including double arcs, was superior to sit-up and shoot IMRT plan, including 5-9 beam portals, while the effective treatment delivery time was shortened by 50% VMAT. So we improved the tumor control, decreased the toxicity, and at the same time, we were able to decrease the treatment time with the VMAT. Then further, we moved to another technique which is called image guided radiotherapy. What happens with it? We put our imaging device inside the linear accelerator. What happens with that? When a patient is treated with radiotherapy, we use immobilization devices at the time of the planning, and we use the same immobilization devices at the time of treatment. But still, there are chances of the movement, the internal movements, respiratory movements, bowel movements, and setup errors. So there are still chances of errors. What happens with IGRT? We have an imaging technique inside the linear accelerator. At the time of treatment, we take an image and we fuse it with the image which we have taken for the planning purpose. And if there is error, we apply that error so that there is no miss of the tumor, and at the same time, the normal tissue toxicity will be reduced. They will receive the less dose as we have planned already. It is more important for the mobile tumors immediately adjacent to the organ at risk and in difficult radiation conditions. There was a study that impact of post-operative daily imaging guided radiotherapy on overall and local progression-free survival in patients in oral cavity cancers. Till now, we were seeing the treatment control was there, tumor control was there, and at the same time, toxicities were less. But we were not able to achieve a better progression-free survival or the overall survival. But with the invention of the IGRT, image-guided radiotherapy, we were able to do it. What they concluded from it, for patients with locally advanced oral cavity cancers, post-operative IGRT results in better overall survival and better local progression-free survival, less marginal failure, and shorter overall treatment time than post-operative non-image guided IMRT. When we give radiotherapy to a patient, for that matter, even a chemotherapy or whatever the treatment for the malignancy is given, during the course of the treatment, if the tumor is very big, there occurs shrinkage of the tumor because of the response, or there are the large nodal mass, they shrink because of the response, and the tumor mass decreases. Or patient loses the weight, especially the GI malignancies and the oral cavity malignancies. What happens during the course of the disease? They develop the radiation reactions and they are not able to take the feed properly, so weight loss occurs, and malignancy itself leads to the weight loss. Or there, for example, patient is post-operative. At the time of the planning, patient was having some inflammation. With the course of the time, that gets resolved. And what happens with all the three things? The patient loses the weight. There is a decrease in the volume of the tumor. So to compensate for this thing, there was a technique what is called adaptive radiotherapy, because if we are going to give the image guided radiotherapy for this, we are not able to give the proper shifts. What we we developed another technique that is called adaptive radiotherapy. What is adaptive radiotherapy? In which we do replanning patients during the treatment, either in response to weight loss or the tumor shrinkage, or at predefined interval over the course of the radiation. Replanning allows the radiation plan to adjust to the changing tumor and the normal tissue anatomy, reducing dose to the sensitive structures, minimizing dose inhomogeneity, and the inadequate tumor coverage. ART is particularly aiming to spare the organs at risk. But the challenge with the ART are the identifying the most relevant candidate, the optimum timing of the replanning. The third week is suggested at the optimum time of the replanning. I need 2 minutes, huh? Please. And thank you. The third week is the optimal timing of planning as per the studies are considered. I will explain this with this diagram. When we treat a patient with radiotherapy, first we do the simulation. Simulation is we put the patient on the simulator couch. We take a CT scan of the patient on the day of planning, and that CT scan at that time. Uh, what is difference from a normal CT from the simulator CT is that we have a flat tabletop. We have lasers which we use for the positioning, and actually this simulates the machine. That's why it is called the simulator. It is equivalent to the machine except it doesn't treat the patients. So we put the patient on the simulator. We use immobilization devices like head casts, neck rests, and we keep the record of all the things. And then this imaging is transferred to the planning system, where we do the contouring of the patient, organs at risk, tumor, and the rest of the body. Then our physicist make the plan, and he keeps in the constraints of the normal structures and gives the maximum dose to the tumor. What happens? This is the 2D. This is our at the time of simulation. This was our tumor. This was the organ at first risk, and this was the organ at second risk. But when we take the patient for the treatment, this is the actual position because of the respiratory movements, because of the setup errors, and this is totally a different scenario. What happens when we treat with the 2D? As you can see, expected is this, and what we achieve is this. Tumor is controlled, but organ at 2 is receiving different dose which we expected, and organ at risk 1 was is receiving different dose which we expected. And this is the same scenario with the 3D CRT, IMRT, IGRT. But with ART, we do the replanning of this patient so that tumor receives the maximum dose and organ at risk receive the minimum dose, so that the toxicity is decreased and the tumor control improves. How is ART given? It is given online or real-time adaptive planning, or offline interfractional adaptive planning. Online is more important for where the anatomical changes such as tumor shrinkage or variation in patient positioning occur frequently. And the offline is suitable for systemic or the slow progressive changes, for example, tumor regression or the weight loss. There was a systemic review on clinical adaptive radiotherapy for head and neck cancers. They concluded that the literature on clinical ART in head and neck cancers is limited. ART is associated with small reduction in dose to the organs at risk, but the influence on toxicity and the disease control is uncertain. But I think we need the larger groups to study this adaptive radiotherapy, and we need to define a time when we should do the replanning, and hopefully that will increase the tumor control and decrease the normal tissue toxicity. There was a multicentric randomized control phase 3 trial of adaptive and the 18F FDG PET guided dose redistribution in locally advanced head and neck squamous cell carcinomas. What they concluded that the adaptive and dose redistribution radiotherapy enables dose escalation with similar toxicity rates compared to the conventional radiotherapy, while FDG PET guided dose escalation did overall not lead to significant tumor control or survival improvements. But thing is that this is under the preliminary conditions. I hope the further studies and the longer cohort will prove that this is a better technique. Then moving to another external beam radiotherapy, that is the proton beam radiotherapy. The beauty of this therapy is this Bragg peak. That is, it deposits maximum dose at particular depth, and at rest of its path, there is a very less deposition of dose. What happens with that? If we know the depth of the tumor, and if we know the Bragg peak depth, we can apply this radiotherapy technique, and we can have least side effects and the maximum tumor control. There is a maintenance of full dose of irradiation to the target range and reduction of irradiation to the adjacent critical structures. This is IMRT, and this is our proton beam therapy. You can see here that the proton beam therapy, the maximum dose to the tumor is same with both the techniques, but at the same time, our tumor, which is the normal tissues, surrounding normal tissues, they are better secured with the proton beam therapy. There was a systemic review and meta-analysis for efficacy and safety of proton therapy versus intensity modulated radiation therapy in the treatment of head and neck cancers. They have seen that the proton beam therapy demonstrated superior overall survival, disease-free survival, and better local control compared to the IMRT. The data also showed better safety outcome in tumor proton therapy patients, particularly when involving grade 2 acute toxicity events. Now moving to another therapy of the radiation, that is the brachytherapy. This is also called the internal radiation therapy. What we do here, we place application of the radioactive source directly to the tumor. The beauty of this therapy is the steep dose gradient. What does that mean? That means maximum dose goes to the tumor and there is a rapid dose fall off. Till date, this is the most conformal form of radiotherapy. It gives highest dose to the, we moved from the 2D conformal radiotherapy to the IGRT, to the adaptive radiotherapy. But none of those external beam radiotherapies are comparable to brachytherapy when we talk of the conformality of the radiotherapy. That means maximum dose to the tumor and minimum dose to the normal surrounding tissues. But why we are not utilizing it? Because it has its own limitations. This is the beauty of this brachytherapy. Maximum dose goes to the tumor and you can see the surrounding mandible is secured, which is not most probably possible with the external beam radiotherapy. What are its limitations? It is an invasive process because we need to put the radioactive source inside the tumor. It needs expertise, it needs better control of the clinician on his technique. And another thing is the size of the tumor. It is applicable for tumors less than 4 centimeter only. And we know when we need the nodal control, it is not possible for brachytherapy to control the nodes because we need bigger fields, we need bigger fields for such things. So it is not possible with brachytherapy. There was a paper on post-operative high-dose rate brachytherapy alone in stage 1A, T1 to T3, N0M0 oral cancers with negative prognostic factors. It was a retrospective study. They have seen post-operative HDR brachytherapy, 18 grays total, 3 gray per fraction seems to be 3 in 3 fractions, 18 gray seems to be as effective as the external beam radiotherapy. Now, moving from the technique to the imaging modalities, what has changed during the years? When we talk about the imaging, previously we used to take the X-rays for confirmation. The quality of the X-ray was not good, and we were not able to because to compare where actual radiation is going on. Then came the CBCT, cone beam CT. It is allowing for the accurate patient positioning. What we do, what is cone beam CT? This CT is done at the time of treatment. As I said about the IGRT, at the time of the treatment, we do this CT. This is a real-time adjustment during the treatment. For that, CBCT is done. We do the CT and we fuse this CT with the planning CT, which we have done at the time of simulator. And any error from this, we have some limitations for that. For example, we have 1%, 2% errors. We can correct it at that time. We correct that error and so that the radiation dose which we have planned for the tumor receives that, and the which we have planned for the normal tissues receives that much of the dose. What happens with it? It reduces the normal tissue toxicity, and at the same time, dose to the tumor increases, which ultimately leads to minimizing damage to the healthy tissue while maximizing tumor coverage. But there are issues with the CBCT. There is excessive scattering, which leads to the poor image quality, and there is a radiation exposure, ionizing radiation exposure to the patient. Another is the MR liniac, or what we call MRI guided radiotherapy. It is more important for the brain tissue, muscle, and nerve because we know resolution of CT for these brain tissue, soft tissue, muscle, nerve is not as good as with the MRI. It has a superior target pictures and it raises the target dose. Biomarkers of pictures directs the intensification or the de-enhancement of the radiation. So it is a better than the CBCT, but it is more expensive and not available everywhere. There was a paper, the value of CT, MRI, and PET-CT in detecting retropharyngeal lymph node metastatic head and neck squamous cell carcinoma, and sensitivity and specificity of MRI is better than the CT, although the specificity is almost equal, but the sensitivity is more with the MRI. And the future plan is the PET clinic. It is under process, not yet installed anywhere. Now moving from the technique to the then imaging to the fractionation. This is the fractionation means in how many days we are going to complete the radiation treatment, and how much dose we are going in to give in particular setting. We have moved from the conventional radiotherapy to the stereotactic body radiotherapy. What has changed in conventional radiotherapy? The dose per fraction is 1.8 to 2 gray. But in case of the stereotactic body radiotherapy, the high dose per fraction is given, that is 6 to 10 gray. And the number of the fractions is also reduced because we are giving high dose per fraction, the number of the fractions will decrease. And in conventional, we used to give in 28 fractions, 30 fractions, but here number of the fractions is very less. What happens with it? It typically delivers a highly inhomogeneous dose within the target. There occurs a hotspot of 120 to 160%, and the high dose per fraction is used. And there is also a sharp dose fall off outside the target. Dose heterogeneity leads to anti-tumor transformation of the tumor microenvironment. This is how SBRT or the SRS acts. First is the direct effect. Because it is a very high dose, it directly leads to the cell death. There occurs vascular damage. What happens with vascular damage? If patient is having a hypoxic cell, it leads to the HIF1 alpha release. That goes to the circulation, and it induces the immune response that leads to the reduced metastasis, or it can indirect cause the cell death. Indirect cell death, when indirect cell death occurs, there occurs a release of the immune response, and that leads to the decrease in the recurrence of the metastasis. And third is the immune cytokines. Immune cytokines are released with the SBRT, that leads to the immune response, and that leads to the systemic response. What I want to say here, that when we use the SBRT, it is not the local. When we talk of the radiotherapy, we say it is equivalent to the surgery. There is a local control. But when we talk of the SBRT, it is not only the local control, it leads to the activation of the immune system, and that activation of immune system leads to the systemic response, which is usually not with the conventional radiotherapy. This is again the same. When SBRT is given, it leads to the activation of the CD8 T cells, and mature dendritic cells leads to the release of the CD8 T cells, and they cause the immune response and further death of the tumor cells, and micrometastasis, if there are, they are controlled with the SBRT. This is again the same, and because of this quality of the SBRT, this time the studies are going on with the PDL1, PDL2 immunotherapy, targeted therapy with the SBRT, because it has been seen they have a synergistic effect, because SBRT is already stimulating the immune system, and with the immunotherapy further adding to it, we have a synergistic effect, and there is a beautiful tumor response. There is not only the local control, but the systemic control with the SBRT. What are the clinical indications of the SBRT? In afferent setting, untreated elderly patients who are not candidate for definitive surgery or radiotherapy, and in metastatic and recurrent settings, we are using at this time the SBRT. There was a multi-institutional phase 2 study of concomitant stereotactic irradiation and cetuximab for recurrent head and neck cancers. They concluded that these results suggest that short SBRT with cetuximab is an effective salvage treatment with good response rate in this poor prognosis population with previously irradiated head and neck cancers. Treatment is feasible, and with appropriate care to limiting critical structures, acute toxicity are acceptable. This combination may be the reference treatment in this population. Stereotactic body radiotherapy as primary treatment for elderly patients with medically inoperable head and neck cancers. They concluded that there are encouraging survival and relatively low toxicity in elderly patients with unresectable head and neck cancers, which may provide an aggressive, potentially curative local therapy while maintaining quality of life. There is another new technique, spatially fractionated radiotherapy. Actually, it is not a new technique. It is a very old technique. It was initially introduced in early 1900. What they used to do, a metallic grid were used to deliver a high dose through small interspersed openings, allowing recovery of the normal skin through sparing of the stem cells in the blocked areas. This is now being used, and how we give it, either the grid therapy or the lattice radiotherapy. In grid therapy, we use a sieve-like metal block or MLC to generate high dose peaks and intervening low dose valley areas throughout the tumor. And in lattice radiotherapy, what we do, we create small 1 centimeter in diameter islands of high dose spheres, vertices, using conformal technique VMAT. What happens with this? Inhomogeneous dose distribution can normalize aberrant tumor vasculature, overcurve tumor hypoxia, and enhance the anti-tumor immune response. High doses, they cause the normalization of the aberrant tumor vasculature and overcomes the tumor hypoxia. This is the sieve-like structure which we use for it. What happens with this? We convert cold tumor into the hot tumor. What does that mean? Cold tumor means it is there is fibrosis, there is hypoxia, that is a cold tumor, because radiation doesn't affect on such areas where there is a fibrosis or hypoxia. What happens? We give a higher dose. When we give high dose, it affects on the cold tumor also. And in case of the hot tumor, what happens? Low dose fractionated radiotherapy we are giving, that activates the immune system like the SBRT, and that acts on the hot tumor. So its mechanism of action is almost as the SBRT, but here we are giving low dose also, so there is a better activation of the immune system. So it acts locally, it acts systemically. It enhances the local control, it decreases the systemic failure. This is, yeah, you can see here the high doses of 84.3 gray receiving here, and at the same time the peripheral area is receiving 43 gray, and this area is receiving 66 gray. This is the beauty of this technique. There was a paper in Red Journal, evaluation of specially fractionated radiotherapy and the definitive chemoradiotherapy with curative intent for locally advanced squamous cell carcinoma of head and neck, initial response rates and toxicity. They have concluded for the treatment of locally advanced neck squamous cell carcinoma of head and neck, grid followed by chemotherapy and SIB-IMRT is well tolerated and yields encouraging clinical and pathological responses with similar acute toxicity profile as in patients receiving chemoradiotherapy without grid. There was another paper, clinical outcome of specially fractionated grid radiotherapy in the treatment of bulky tumors of head and neck. Feasible for the palliative or definitive management of large tumors of the head and neck. In combination with external beam radiotherapy, SFGRT can provide timely symptom management and improved patient quality of life in the palliative setting. In the definitive setting, can result in an excellent clinical response. Treatment toxicity was found to be within an acceptable range. There was another paper combining specially fractionated radiation therapy and the immunotherapy opens new rays of hope for enhancing therapeutic ratio. SFRT has the potential to overcome tumor radio resistance and modulate the local immune response, which could lead to a significant improvement in tumor control locally, regionally, and distantly, while preserving healthy tissues. Combining this with the immune checkpoint inhibitors is a promising strategy for treating metastatic cancers and can trigger as-Bacall effect. There's another that is called the Scott shot radiotherapy. What we do it is a cyclical hypofractionated palliative radiotherapy. That means we are giving high dose per fraction with a gap. There was a RTOG 8502 trial for advanced pelvic malignancies. It was introduced for that. They were given a cycles of 18.4 gray delivered in 4 twice daily fractions. That means 3.7 gray per fraction over 2 consecutive days. Cycles were repeated every 3 to 4. Total of 3 cycles were given. COT was subsequently studied for the head and neck tumors, and this time the immune checkpoint inhibitors are given along with the COT. It is under investigations. Take home messages: ART demonstrates significant potential for success when patients are carefully selected and the timing and the frequency of treatment replanning are optimized. Brachytherapy is still the most conformal radiotherapy and has a role in early oral cavity lesions as a sole modality. Salvage or the adjuvant SBRT for oral cavity lesions can be used in appropriately selected cases. SFR and Scott shot radiotherapy combined with immunotherapy represents a promising advancement in cancer treatment. Thank you.
Thanks, Dr. Shahida, for throwing a light on various modalities of radiotherapy in managing head and neck cancer. Anybody want to ask any question? Dr. Nasreen is with us. You can ask any query, anything, anyone having any patient related to oral cancer, and you are planning for radiation therapy. You can ask question to Dr. Shahida Nasreen. She is from a leading institute, Sher-e-Kashmir Institute of Medical Sciences, which is one of the leading institute in Northern India. If you have any query, you can write on a chat box as well. And you can also email it to us. We can forward it to Dr. Shahida for the answer. Dr. Shahida, thanks for sparing your precious time.
Thank you so much, sir. Thank you.
Even during your iftar time, we have interrupted you and we have taken your time.
No
so
issue,
now
sir.
you can relax and you can break your fast completely. With your permission, we are moving to our next speaker, Dr. Shahida. Should we
Thank
go?
you, sir. Thank you. Definitely.
Thanks a lot. Yeah,
Thank
thanks. So, Dr. Kehinde, are you there? Yes. Could you unmute yourself so that, yes. Dr. Shahida, could you stop your screen share? Yes. So, Dr. Kehinde, could you please share your slide? Meanwhile, I'll introduce you formally. Can you say hi? Can you unmute Dr. Kehinde? I think he is there in the meeting room, but something, he's not able to. I think Dr. Kehinde is joining through other device.
Can you hear me now?
Yeah. You are audible.
Okay. All right, sir.
Yes. So let me introduce you and then you can continue, Dr. Kehinde.
Okay.
Yeah. So we are fortunate, we are privileged that Professor Kehinde Kanmodi is with us. He is a globally recognized public health scientist, dentist, and interdisciplinary research and extensive experience in academia, research leadership, and policy engagement across Africa, Asia, Europe, and North America. He is trained in Nigeria and the UK. Professor Kanmodi holds a Bachelor of Dental Surgery from University of Ibadan and the Master of Public Health in distinction, and he also did his PhD in public health from Tesidet University, UK. Due to his extraordinary academic achievements, Professor Kanmodi rose to professional rank at the very young age at 33. years in Cambodia, Asia, which made him the youngest professor in the Asian country. Currently, he holds 2 professorships in public health and 2 Nigerian universities. He is also a senior collaborator with the Global Burden of Disease Collaborators at the University of Washington, USA, and executive director of CEPHA's Health Research Initiative, also called as CEPHAS in Nigeria, a not-for-profit organization he founded in 2016 to advance evidence-based health policy and practice. As at today, CEPHAS is the leading private non-profit corporate research organization in Nigeria, according to Nature. Professor Kanmodi has over 345 peer-reviewed publications, over 20,000 citations, and 34 H index as a Google Scholar. He has contributed to numerous high-impact papers published in Lancet, Nature Medicine, Journal of the American College of Cardiology, BMC Public Health, BMC Global Health, PLOC1, among others. He has also supervised several higher diploma, undergraduates, and doctorate students in Cambodia, Nigerian, and Rwandan higher institutes. His research interests span global health, oncology, digital health innovation, and academic industry collaboration. He is recipient of multiple competitive academic grants and awards and has reviewed grants for prestigious funders such as Bill and Melinda Gates Foundation and the Science of Africa Foundation, and serves as editorial boards of international journals including BMC Public Health and PLOS1. As a passionate advocate of triple helix model partnership, Professor Kainmundi has led multiple collaborative projects bringing research, innovations, and sustainable development. And due to his high level of international engagement, Professor Kanmodi has granted several international interviews of international media, health organizations, and has delivered several lectures across several countries. Of recent, he delivered an invited lecture under the auspices of the President of Egypt at the 2023 African Health Expo in Cairo. If I missed anything, Dr. Kainde, you can add on. And you are going to speak on oral cancer control in Nigeria, strengthening university, industry, government, and collaboration. So over to you, Dr. Kanmodi. And your slides are visible, your title slides are visible, you are audible, you can continue.
Thank you very much, sir. Yes, my name is Kehinde Komodi. My first name is Kehinde. And thank you very much for the introduction, and I'm very grateful for the opportunity to present in this international congress as a keynote speaker. As the moderator has mentioned, the title of today's presentation is Oral Cancer Control in Nigeria, Strengthening University, Industry, Government Collaboration. So first of all, I'm going to present from an industry/NGO perspective. So I'll first talk briefly about CEPHAS Research Initiative, the organization I founded in 2016. It was established in 2016 and incorporated in 2017. CEPHAS is a non-profit health research organization based in Nigeria and engaged in public health research, advocacy, and education. At CEPHAS, we collaborate with institutions, community stakeholders, and other non-governmental organizations. And in fact, governments as well. Is an omission on my slide, to solve diverse and pertinent health-related issues in Nigeria, Africa, and beyond through scientific, participatory, and equity-based approaches. CEPHAS, according to Nature Index, is ranked as the #1 corporate research organization in Nigeria. Below gives a glimpse of our profile and impact. At CEPHAS Research Initiative, we have over 270 peer-reviewed publications. We have a paper accepted yesterday. We got in a widely journal in Health Science report. We got a paper, we got a revision from BMC Cancer on a research on electron microscopy. And also we have a paper published earlier this month on a digital on a mobile health application that we co-developed to educate the public on oral cancer. The name of the app prototype is called Beat Oral Cancer. So we're about to launch it. So those are some of the works we've done of recent that are published papers. And also we've delivered 20 plus presentations in scientific meetings. And fortunately for us, We have 3 speakers from our organization presenting in this very prestigious international conference. And we have research collaborations with 300 plus institutions across the world. We've collaborated with researchers from 300 plus institutions across the world. And in CEPHAS, we have 60 plus researchers. And our output is higher than several fifth generation universities in Nigeria based on Scopus. And the opening context to this presentation is that in Nigeria, oral cancer is considered as a leading cancer type. In a recent meta-analysis conducted on Nigerian populations, the disease is found to have a pool prevalence of 20%. So based on the meta-analysis of prevalence data on oral cancer across different geopolitical zones in Nigeria, it was found that 20% of Nigerian population is suffering from oral cancer, although these statistics should be interpreted with caution because from my look of the data, it was mostly clinical-based data, not really community-based data. So as a result of that, we need to consider the limitations of those data there. They conducted the meta-analysis on. So this is just a pooled prevalence of existing data. So, but regardless of that, regardless of the reliability of that prevalence of 20%, I can, based on clinical experience, anecdotal evidence, I can say that the prevalence of oral cancer in Nigeria is significant. Because the cancer is becoming commoner every day, so it's not that it's a rare disease, it's a very common disease. And in Nigeria, most patients with oral cancer present late at the hospitals for treatment, and the survival rate of the disease among Nigerian populations is lower than that recorded in high-income countries and even some middle-income countries. Overall, the above indicates that oral cancer is a disease of serious public health concern. I will not be surprised if the survival rate of oral cancer in India is higher than Nigeria. The reason because India has more advanced technology than Nigeria, and also India is arguably the #1 country in the world when it comes to oral cancer research and innovation. So India has done a lot on oral cancer research. So definitely India should have, most likely, we have higher survival rate than Nigeria. So these are issues. That's why I mentioned that Nigerians Nigeria's survival rates in oral cancer will be lower than some middle-income countries, like reference to India, for instance. So Nigeria's universities remain centers of knowledge creation on oral cancer, yet the translation of oral cancer research into societal impact is extremely limited. Because what I've observed from experience as an academic with my academic research experience for over a decade now, I noticed that universities, industries, governments, they work in, will I say, silos. Everybody work on their own, everybody to their tent. They don't really communicate maximally compared to when based on my experience, for instance, in countries like the United Kingdom, United States, Egypt, and even India. So these are areas where requires a lot of attention. So bridging the gap between industry, academia, and government is vital for innovation, national competitiveness, and sustainable development, especially in the area of oral disease prevention and control. This keynote lecture aligns with the conference theme: recent advances in diagnosis and management of oral potentially malignant disorders. In what sense? How does it relate with it? Oral potentially malignant disorders can lead to oral cancer. So if we are not having a research on oral cancer as a whole, including the prevention of it and the care of it, we will keep having a high number of oral cancer cases in Nigeria. So I deliberately focus on oral cancer in this presentation because oral cancer is one of the end stages of oral potentially malignant disorders. The conceptual overview now. Industry academic government partnership is a cooperative relationship where academic institutions, industry sectors, and governments collaborate to exchange knowledge, skills, and resources. The knowledge can be in terms of like scientific knowledge, skills, technical skills, and resources like money and maybe so any resources can be in kind, it can be in cash. So the goal is to co-produce innovation-driven solutions to real-world problems. That is the goal of industry, academic, government partnership. And also, what are the core values that makes this partnership to succeed? There must be mutual trust, there must be relevance, and it must be sustainable. In a situation where the university does not trust the government, for instance, in a situation where the university will make an agreement with the government and the government will violate the agreement, they'll be the first to violate the agreement, that they will not fulfill the agreement that is written in ink, that is signed by government representative and the university representative, then the government end up not fulfilling its obligations, then there will be problem of trust. And when there is problem of trust, it's difficult to have industry, academic, government partnership. It's just like grant applications. When the recipients say that they are going to produce counterpart funding and they are not producing it, and they sign that they are going to produce counterpart funding, it's going to affect mutual trust. It will affect subsequent collaboration opportunities. And also, the collaboration needs to be relevant. It should be on sources that are of mutual interest, and it must be sustainable. And also, that's the problem we are also having. For instance, in Nigeria, a current government will be there. Then after 4 or 8 years, another government will enter. The agreement the past administration had with the university, it goes null and void. Then the new administration will bring their own agenda and sign. So there is no continuity. So it's affecting sustainability. I can say that I'm not a politician, but I can say that, like for instance, in India, for instance, India, in terms of national government, they have like this sense of like, let's say, stability in a sense that there is continuity in government. That's why India could go to, I think India went to the moon or went to, I know India went to the space, last year or so, and also production of so many stuff, vaccines and the likes. This is not a industry engagement alone. It involves collaboration between industry, university, and government. So these are areas where a to establish I mean industry, academic, government partnership. This is important to ensure that innovation-driven solutions are co-produced. If there is no mutual trust, there is no relevance, there is no sustainability. It will be difficult to achieve. So the Nigerian context, Nigeria faces the innovation implementation paradox. For instance, Nigeria has strong oral cancer research potential, but weak industrial translation. For instance, how many genomic labs do we have in Nigeria that are producing, let's say, HPV test kits, for instance, or a HPV rapid test kit that a dental patient will come to the clinic for? Okay, I come for oral cancer screening. Okay, they want to test whether the patient has HPV. Does the patient has HPV strain 60? Does he have 18? Is it the benign HPV strains? Is it the carcinogenic HPV strain? We don't produce such kits in Nigeria. So these are issues. And Nigerian institutions have started indicated, research universities have indicated that the prevalence of oral sex is increasing globally, and Nigeria is not excluded. Nigeria is not an excluded country. We are also reporting increased prevalence in, let's say, oral sex, for instance, which is also increasing everywhere in the world. So it's not only limited to any countries, everywhere. It's a global issue due to social media and advancement in technology and the likes, and influence from drama and the likes. So we are facing the innovation paradox. Universities will indicate that this is a problem, but for instance, look at the HPV testing kit. We don't have industry for it. The government is not prioritizing on it. They are only focusing on malaria treatment and stuff like that. So Nigeria contributes significantly to global scholarship. We are ranked high to it in our own right in terms of global scholarship, but we rank low. We rank low in innovation indices. Universities are underutilizing national industrial growth strategies. For instance, how many universities are connected to industrial parks. So these are issues we are having. So in the Nigerian context, universities are underutilized in national industrial growth strategies. Like for instance, Rwanda has adopted similar. In Rwanda, they have science parks where, for instance, in Kigali, when I was in Rwanda in 2023, I was privileged to know more about that. University of Rwanda with Carnegie Mellon Africa, with African Leadership University, and some big institutions in Rwanda. They have a central park where they are developing, they are incubating technologies. So similar, we need to adopt those best practices, just like Silicon Valley to Silicon Savannah in Kenya and the likes. We need to adopt those kind of strategies and bring it to Nigeria in the Nigerian context. I know Nigeria we have something similar, but it needs to be highly utilized. It's highly underutilized right now. Nigeria needs to maximize it. And what are the global lessons? I use the global lessons from United States, for instance, University Industry Research Consortia, for instance, where the government is an omission there. I need to put the government there, where the government also sponsors. Let's look at Harvard University. Like recently, the president of United States is having a meeting with Harvard University that I want to give them billions of dollars or something for funding. So issues like that are part of government industry university partnerships. When the university gets it, they use it to build startup companies. They use it to, for so many activities. It's just like, let's use the case of COVID-19, for instance. When there was COVID pandemic, Oxford University, Harvard University, they collaborated with is it AstraZeneca or the likes and Moderna and the like to co-develop vaccine to save the world and with the support of funding from the government. So that is university industry government partnership. And it's an example, for instance, in the UK, we also have knowledge transfer partnerships in the UK, so it's like the COVID experience. It's happened in the United States, it's happened in the UK. Asia Triple Helix Model Government Industry University Synergy. I'm sure of this, for instance, in Thailand, this applies, and also key insights. Institutional frameworks and government incentives drive sustainable partnership is very important. Government needs to incentivize partnerships to make it sustainable. So the current status in Nigeria, we have numerous MOU without measurable outputs. Many universities, and I'm sure these problems are not limited to Nigeria. Some universities in India too will be experiencing, not only some, many. For instance, because in India are so many universities, so definitely many too will have similar problems. Like for instance, numerous MOUs without measurable outputs. Some universities sign MOU every time, but they don't measure, okay, we have this MOU with this university, we have this MOU with this partner. Okay, what are the outputs? What did we achieve? Did they reflect on, okay, we've signed MOU with this organization in 2025, now we're in 2026. What are the things we are able to achieve together? If we are not able to, if maybe we have a goal, are we able to attain that goal? If we are not able to, do they do like situation analysis that what are the conditions that makes it not to be optimally maximized, to be optimally utilized, to maximize the opportunity, the partnership opportunity? Some of those MOUs are just signed papers just to have numbers. That we have MOUs with this number of universities, this number of organizations, just for statistics purpose. But the real outputs, the intended goal are not measured. And when when an objective is not measured, it tends not to be, does not help in terms of evaluation and monitoring of partnership engagements. Now, also limited funding and technology incubation platforms in Nigeria is very limited. The government is have limited funding for technology because it's very important for growth in the innovation sector and weak intellectual property frameworks. Where, for instance, piracy, let me use the word of piracy in terms of movies. If any country, the world, if they are finding it hard to regulate, to prevent piracy, it will be very difficult for them to regulate intellectual property because that's just because the attitude shown towards piracy protection of privacy, because piracy is also related to intellectual property. So, like for instance, Nigeria piracy is common in some days, though it's declining now compared to before, and I'm sure it's also everywhere in the world in some places, but it's just more pronounced than some places than the other. So, look, private sector engagement in university-led R&D. For instance, in Nigeria, for instance, private sectors are not really engaged in university-led R&D. Most times it's okay, allocation from the government, allocation from the government. The university needs to partner with GSK. The university needs to partner with Orabi. They need to partner with Unilever. University partnering with Mercedes, partnering with Boringa, Inge, or big companies like that, Moderna, AstraZeneca, in collaboration in research, where the research they develop within the walls of the university will be translated in the industry or developed for the general public use. So those are the issues we are having. There is low private sector engagement in university-led research. And private sector is this sector that really drives the economy of a nation. When they are not engaged in R&D, then innovation outlook will be very low. Barriers to effective collaboration, structural disconnect between academic priorities, industrial needs, and government priorities, poor funding mechanisms, and limited research commercialization support, and also fragmented innovation ecosystem. There needs to be interconnected innovation ecosystems. Not that each innovation ecosystem will be working in silos. It's just like we should look at the field of medicine. For instance, when I say medicine, I'm saying medicine in broad term, which is inclusive of dentistry or oral cancer research, for instance, is related to, let's say, biosensors. Like for instance, a company that is doing maybe a sensor, for instance, maybe they are developing sensor. Some sensors can be used to detect oral cancer, for instance. So if maybe oral medicine research is working in silos, they are not collaborating with a company or an innovation maybe a company that does biosensors or generally sensors generally, or maybe a company that is into AI. Look at it, oral cancer has occurred, which is the role of a clinician to detect. Then biosensor, they can use the technology to sense the presence or absence of oral cancer. Then AI can be used to predict cases similar to enhance diagnosis. So AI company, biosensor company, and detection of oral cancer. So we need a clinician there. We need someone in biosensor research and someone in AI research. So we see the essence of interconnectedness of innovation ecosystem. When it's fragmented, it will be difficult to have innovative, to be able to generate an innovation in systems like that. So for instance, these are the major barriers we are having in Nigeria, and also barriers to effective collaboration, policy inconsistency, and lack of institutional autonomy. When the policy is not consistent, like for instance, the national policy, another government will come in, we say, okay, henceforth, this thing must be done this way. Then another government comes and say that no, it must be done the other way around. So inconsistency affects effective collaboration because it changes the way things are done. It has a ripple effect and lack of institutional autonomy. When institutions are politicized, where is the governor or a traditional leader or a politician that will determine who will be the vice chancellor of a university when it's not? Meanwhile, it should have been merit-based. It should be it should be appointed based on competitiveness, not about who knows who. So in situations where it's only people that are close to the corridors of power that could hold leadership positions in institutions, then there is no institutional autonomy. And in that situation, it affects innovation and also low industry confidence in university research capacity. When industry does not have research or in confidence in university research, like for instance, a department of oral pathology where maybe 80% of their research is knowledge, attitude, and practices concerning the risk factors of oral cancer forms 95% of their publications. No innovation, they are not doing research on immunohistochemistry, they are not doing research on the use of maybe cancer signaling techniques in molecular signaling techniques in detecting cancer, all this molecular biology research. They are not doing that. They are only focusing on knowledge, attitude, and practice. In situations like that, industry cannot have confidence in the research capacity of such university. So those are the barriers we are having in Nigeria. So those are areas that needs to be work on. Theoretical frameworks. What is the theoretical framework that can improve university, industry, government synergy in Nigeria? I will recommend triple helix model. This model promotes knowledge exchange, innovation clusters, and policy alignment, where knowledge is generated from the university and innovation is developed in partnership between the industry and the university with support of government. So the policy, for instance, if the government wants to release funds, they will create a policy to that effect. Okay, in the policy, we do this, we do that. So that will empower the university and the industrial sector. So triple helix model is one of the best model to use to boost university, industry, government collaborations, which can help in the fight against oral cancer in Nigeria. Strategic pathways forward, institutional reform, establish dedicated industry liaison and innovation offices with the inclusion of an agenda for oral cancer. If these offices are established, some universities have it, and if not all, but there needs to be an inclusion of an agenda for oral cancer. If it is there and they are not having focusing on agenda for oral cancer prevention and control, it will not favor oral cancer research in Nigeria. Co-funded research projects, shared investment in applied oral cancer research will also help, where the industry drop funds, the government drop funds, the university also drop funds. Internship and fellowship programs, industry embedded student researcher placement on oral cancer related research and innovation will also help. Research commercialization units, which are related to IP protection, patent, and startup incubation, where researchers that develop novel ideas, novel solutions, innovative ideas, innovative solutions are protected, their intellectual property are protected, they are helped to get patents, and they were supported to start up an incubation, to start up a company like startups. So roles of Nigerian universities. Nigerian universities as knowledge brokers and innovation catalysts on oral cancer research and innovation. They've been integrating entrepreneurship and industrial exposure into the national curriculum. Unfortunately, this is not in the curriculum of dentistry in many dental schools in Nigeria, which is very important. It is not enough for Nigerian institutions, and I'm sure similar situations that will also be in India, that we only train dentists to just be clinicians, just to be diagnosing oral diseases alone. We need to train dentists to have capacity in entrepreneurship and leadership, because innovation requires leadership experience too. To be an innovator, you need to be a leader. To be a successful innovator, you need to be a leader. To be a successful, to have industry, university, government partnership, there needs to be leadership skills, because this is a leadership activity. We need to prioritize multidisciplinary and translational research. There are situations where you see many research projects in dentistry. You will see a paper, all the authors are Department of Oral Pathology, Department of Oral Pathology, Department of Oral Pathology. Then you see another study, Department of Periodontology, Department of Periodontology, Department of Periodontology. You see another study, Department of Oral and Maxillofacial Surgery, Department of Oral and Maxillofacial Surgery, Department of Oral and all the authors, no interconnectedness. And I did multidisciplinary and translational research to cut across disciplines, like researchers from Department of Physics, Department from Engineering, Department of Molecular Sciences, Department from Computer Sciences, Department from Oral Pathology, Department for Oral Maxillofacial Surgery, like that's all bringing in their expertise to produce multidisciplinary and translational research that can have broader applications, and also encourage faculty industry sabbaticals and joint publications. This is very common in Nigeria. It's extremely rare to see a university researcher collaborating with a researcher in the industry. In fact, the percentage of university industries in Nigeria that employ PhD holders, masters holders are very low. In fact, the one of PhD that is extremely low. for them to encourage research in the industry sector for Nigeria, they need to strengthen the industrial sector to have the capacity to hire researchers at doctorate level so that we enhance faculty industry collaborations. Roles of the industry shift from import dependency to R&D investment. Establish industry researchers and fund university labs, e.g. oral oncology labs. I'll give an example. An example is in University of Malaya in Malaysia, which is the best university okay, it's Petronas that is the first, then Malaya is number 2 in Malaysia. They have this endowed chair on oral cancer or oral maxillofacial pathology in University of Malaya. It's an endowed chairship. Chair is an endowed chair for people in the industry to come and take that have done a lot of innovative research in oral cancer. So Nigeria can adopt similar. Also, to adopt open innovation models that leverage academic expertise and participate in policy dialogue on higher education and innovation. Like for instance, when there needs to be policy on education, maybe curriculum development, curriculum review, and other aspects like that. The industry needs to be actively engaged because people are trained in the university to go and work in the industry. So why shouldn't they be engaged to at maximum level? So these are areas that need to be focused on. Nigeria is doing this, but it is not enough. Nigeria needs to up the game to be able to be more innovative in that aspect. And also policy and government roles. The government needs to introduce tax incentives for industry-funded oral cancer-related research so that it will encourage, it will shift the momentum, increase the momentum towards oral cancer-related research. Now, Nigerian government needs to strengthen technology transfer offices. It's very important. We have in Nigeria, but it needs to be strengthened. It is not, this current strength is not enough. More strength is needed, and to also institutionalize performance-based research funding so that it will incentivize research funding. That okay, performance-based. Okay, you get this funding, you do well on it. Okay, we give you another one. Not that people that did well they perform well on a research grants, on a funded project, and people that did not perform up to expectation if another funded project are rewarded equally. It shouldn't be like that. It should be performance based, and that way it will encourage everybody to sit tight and to be more productive, and also create innovation clusters around universities, e.g. tech parks, hubs. An example is the Silicon Savannah in Kenya that established recently. An example is the Silicon Valley. An example is also the one in Rwanda, the technological park, the Kigali something park in Rwanda. So the way forward, building of trust and continuity through sustained dialogue. There must be sustained dialogue. There must be intercommunication, because effective communication is very important. And how can communication be effective? It can be done through sustained dialogue. And there must be trust. Through that dialogue, trust must be built, and it must be a continual trust. And also promotion of South-South collaborations among African countries. Because, for instance, we share similar socio-demographic characteristics and also similar challenges, similar climate, similar geography, similar geography. So we need to promote that aspect, because from what I've observed, collaboration, not only African universities alone, we also need to collaborate with universities in India, in Asia, in Cambodia, in Thailand, and the likes. But what I've observed is that the collaboration rate outside Africa for Nigerian institutions is even way higher than collaboration within Africa. We need to look inwards, because it's better when solutions are produced inward from inside than to be seeking for solutions outside. An example, the lesson that Nigerian government learned was during COVID, relying on external countries in Europe, in North America to provide vaccine, when they have scientists back at home that they can empower, they can support to develop vaccines for the national benefit. So those are the issues. So harnessing of digital platforms for virtual research and innovation exchanges. Because we live in, look at this conference, for example, where the the organizing committee, they are leveraging on digital platforms. So as a result, researchers across the world could come together to participate in a conference to engage ideas. So these are ways forward to build industry, government, university partnerships in Nigeria. It has been adopted, but it's still not enough. More needs to be done. And also, the way forward is to encourage evidence-based policy making supported by joint university, industry, government data. What is CEPHAS doing in this regard? At CEPHAS, we are collaborating with several Nigerian universities and NGOs in cutting-edge and translational public health research projects on oral cancer. In fact, we are about partnering with a government institution in Asia, and from there we start looking based on that, we start looking for partnership opportunities with government agencies in Nigeria. Getting partnership with government agencies in Nigeria can be very difficult sometimes. So we are working towards that. So right now, we are actively collaborating with universities and NGOs in Nigeria and the United States in the 5+ evidence synthesis and translational research projects on oral cancer prevention and promotion in Nigeria. And also, we are very keen in strengthening our collaborations with universities and government agencies and NGOs and industries across the world through MOUs. For universities, industries, NGOs, and governments are interested in signing an MOU and collaborating with CEPHAS, please contact info@cefashri.org. So this is the bibliography, these questions and answers. Thank you very much.
Thanks, Dr. Kehinde, for throwing lights on how means you are doing collaborating with the various universities as well as your government in doing research and making policy on research based, evidence based, and you are doing great wonderful work related to oral cancer. Anybody want to ask any question? Any want to collaborate with Kefa's health? They can write to at info@kefashri.org for collaborating for any research work, any MOU you want to sign. You can connect Dr. Kehinde for the same. And anybody want to ask any question? You have said rightly, Dr. Kehinde, that we should engage university, industry, and government together, and we should encourage the startups. We should do multiple research. We'll safeguard the research by patents, etc., so that more people get enthusiasm in doing research and all. So it's great that your NGO is doing great at Nigeria. And if anybody from India want to connect you, I'll definitely connect with you so that we have better, more coverage and more data with you, so that have a better research and all.
Thank you very much, sir.
Anybody from audience want to ask any question? Dr. Kehinde is with us. So anybody, you can put a question in chat box and you can write to at support@ioccon.org or ioccn.co. We can forward it to Dr. Kehinde for the query, or any networking you want to do with Dr. Kehinde with KFAS, they can do. Thanks, Dr. Kehinde, for joining. And I think this is the third time we are joining on this platform and all. So it's a privilege that you are joining from different part of the world, and we are here in India. There are multiple speakers who joined. So your colleague has spoken yesterday, Dr. Benjamin Okeke, and he has thrown very lights on how digital and artificial intelligence and digital health, how you can help to managing oral cancer and all. So this is a great day today. Thanks a lot for joining us. And there is an announcement for tomorrow that we would start tomorrow 10 o'clock sharp in the morning, and there would be multiple speakers tomorrow who is the multiple aspects. We are talking about psychology. We are talking about reconstruction surgery. We are talking about immuno-based therapy, chemotherapy. We will talking about nutrition, something about diagnosis. Then precision surgery. We will have there one speaker will join from Sri Lanka. One would be joining from Germany, Dr. Stefano Cavalieri. Then we would last at the end, we would be talking about rehabilitation and palliative therapy and all. So this is how our day tomorrow. Today we have thankful that in the morning Dr. Cheena joined, Dr. Saurav Juneja, Dr. Altaf, Dr. Priti, Dr. Sujata, Dr. Professor S. Erkan, Dr. Yash Mathu, Dr. Divya Raj, Dr. Ashim Mushra, Dr. Shahida Nasreen, and at the last but not least, Dr. Kehinde Kanmodi, who joined and who enlightened all of us with the, we have get, different walk of life and different experiences, and they have shared, and it have, enlightened our attendees who joined our program. So with this note, we are signing off for the day. We'll joining tomorrow at 10 sharp in the morning with our first speaker, Dr. Rajesh Talwar. He will be talking about how to manage psychologically, because he is an anesthetist as well as a psychologist. So he will talk about how to manage the mental challenge of the patient suffering from oral cancer. Thank you so much, everyone. Yes, Dr. Vishwas Kadam. Do you want to add anything, Dr. Vishwas? Any opinion, anything? Can you unmute and you can give your suggestions and all, and we can take it in our next edition. Anybody have to contribute anything, any opinion, any suggestions, we can, it's most welcome. Okay. So we are signing off for the day. And thanks all IOCCON 2026, all who joined us. And it was a very great day today. A long marathon meeting happened on Zoom. It's an advantage that we are joining together on a virtual platform. So world is in our backyard, and we are, we are very close to each other. We are sharing our opinion, data, and everything. So thanks all to joining, and we are signing off for today, and tomorrow we will join at 10 o'clock in the morning. Thanks.